आपने अभी स्पीकर मोड में नहीं किया ना, आपने साइड से किया हुआ है, ठीक।
Good afternoon, everyone. Greetings from the City Beautiful. I welcome you all to the Obstetric Critical Care Workshop with emphasis on maternal emergencies. Stronger collaboration, better outcome. Although fewer than 2% women require ICU admission during pregnancy or peripartum period, maternal mortality is high when critical care is required. Estimates ranging from 3.4% to 14%. Without further ado, I would like to invite Dr. Komal Gandhi, Assistant Professor, Department of Anesthesiology, PGI MER Chandigarh, to conduct the pretest.
Good afternoon, everyone. So now we'll be conducting the pre-test. The pre-test has simple rules. In next few seconds, you will be seeing a link which is in the form of Google form, and it has 15 questions in it. So you have to select a single best answer and submit the whole of the Google form in the end. This link will be active only for 10 minutes. So your time starts now. So for those delegates who have joined us late, we are starting with the pre-test. To see the pre-test questions, you need to click on the quiz tab, which is at the bottom of the screen on the left side. If you are not still able to open it, kindly refresh it. And please don't go on the full platform view. There will be 3 red buttons in the bottom in platform view, and the extreme left side of the screen will show you quiz, a red button written quiz. So you need to click on that, and the time for this link is only 10 minutes.
Thank you, Dr. Komal Gandhi. I would now like to invite Dr. Vanita Jain, Professor, Department of Obstetrics and Gynecology, PGIMER, Chandigarh, to deliver the welcome address.
Good afternoon. It is my great pleasure to warmly welcome you all to YUVA FOGSI 2021, a conference with the theme of Optimizing Perinatal Health. Today, we start this conference with a workshop on critical care. The focus of this workshop is on maternal survival and health, key priorities across all global health systems today. In the next 5 hours, we will be dedicating ourselves to cover the wide spectrum of principles of care of a critically ill parturient. The components of care pathway for a critical ill woman include number 1, early recognition, second, a quick response, and finally, the different levels of critical care. Early recognition of clinical deterioration in a pregnant woman, which may be life-threatening but still potentially reversible, is of paramount importance for a good maternal and fetal outcome. So today we shall be discussing the recognition of a critically ill pregnant woman and the risk stratification in obstetrics. Also, we shall discuss how to transport these women if required. The second component is response, and this requires a multidisciplinary team which includes not only obstetricians but anesthesiologists, obstetric physicians, intervention radiologists, neonatologists, fetal medicine specialists, and so on. And so today, we have invited faculty from these specialties on board as expert panelists to discuss different clinical case scenarios. And finally, to demonstrate the care given to these women in high dependency units, we have prepared e-skill stations. These deal with the major causes of maternal mortality, that is hemorrhage, sepsis, and preeclampsia. We also have an e-skill station for demonstration of management of maternal cardiac arrest, the principles of cardiopulmonary resuscitation in a pregnant woman, and the role of perimortem cesarean delivery. Apart from this, we shall also be touching on the recent concepts of point-of-care ultrasonography in maternal emergencies. And for all this, we have a galaxy of invited faculty, each an expert in their field. Although our team has done the background organization of this workshop, the success of the workshop depends upon the delegates. We would like this workshop to be interactive. So I appeal to the delegates, please put your comments and questions in the chat box. Our team shall try to address them. It is your inputs which will determine the success and the relevance and benefits of this workshop to you at your workplace. Finally, I would like to confess that organizing a workshop on a virtual platform is quite challenging, and all of us are learning as we move along. I hope there are no technical glitches, but in case of any, please bear with us. Our team sincerely hopes that the workshop proves to be an enjoyable and a productive opportunity for all of you. Thank you.
Thank you so much, ma'am. The most common indications for ICU admission are hypertensive disorders of pregnancy and postpartum hemorrhage. So we would like to start the discussion with the topic critically ill preeclamptic parturient, challenges for obstetrician and anesthesiologist. So let's welcome Dr. Sunil Pandya, Founder Director, Prerna Anesthesia and Critical Care Services, Hyderabad, to moderate this session.
Good afternoon, all. Am I audible? Hello, am I audible?
Yes, sir, you are audible.
Yes, thank you. Welcome. I thank Dr. Vanita Jain, Dr. Kajal, and the team YUVA FOGSI North Zone for giving me this podium to share my experience and moderate this session. As we all know, hypertensive disorders in pregnancy are one of the commonest medical disorders that complicate pregnant women. Almost about 9 to 11% of parturients, they are affected with these disorders, and is one of the commonest cause of maternal mortality in our country. To address this issue in a sicker group of pre-eclamptics, we have two experts, Dr. Tarakeshwari Surapanedi and Dr. Manokant, both are from Fernandez Hospital. Dr. Tarakeshwari will be discussing on the challenges as far as obstetrician's perspective, and Dr. Manokant will be discussing challenges from the anesthesiologist perspective. To introduce Dr. Tarakeshwari, it's a voluminous thing, but in brief, she heads the Unit 2 High-Risk Obstetrics Unit as Medical Director. She also is Program Director of Perinatology Fellowship Program. She runs the High-Risk Obstetric Clinic at Fernandez Hospital. She almost past 1.5 decades. And she has several publications in a peer-reviewed journal and also contributed several chapters in standard textbooks. Importantly, she is a passionate clinician and excellent teacher. Over to you, Dr. Tara.
Sir, वही Dr. Sunil Pandya phone
नहीं उठा रहे हैं. On critically ill parturient obstetrician's perspective.
Sir.
Yeah.
Sir, वही Dr. Sunil Pandya से ही आ रही है.
Hello.
Yeah, Sunil.
Yeah. Over to you, Dr. Tara.
Yeah, thank you, Dr. Sunil. Good afternoon, everyone. Greetings from Fernandez Foundation. And it's a privilege for us, Fernandez, as an obstetrician, myself and anesthesia colleague, obstetric anesthesia colleague Manokant, to do these cases of a critically ill parturient pre-eclamptic mother. As we all know, hypertensive disorders of pregnancy constitute one of the major causes of maternal and perinatal mortality. And we all know that the various spectrum of the hypertensive disorders, no sooner, if you don't recognize, they may end up in a multi-organ dysfunction syndrome and also a maternal death. Earlier, we used to call it as a severe preeclampsia, but now we call as preeclampsia with and without severe features. And once preeclampsia is complicated with severe features, if you don't recognize and treat immediately, these conditions of hypertensive hemorrhage, eclampsia, and liver dysfunctions, they can go in for acute kidney injury and also due to vascular involvement, disseminated intravascular coagulopathy, secondary to abruption. Hence, it is very vital to identify a preeclamptic mother, and we will be lucky if they come with you with morbidity. But the next few cases, let us see how moms are mothers have come only with 1 or 2 symptoms or blood pressure, and very soon they landed up in the critical care units. Next few case scenarios I'll be doing with my colleague. I do the obstetric part and my colleague Manokant will deal with the anesthesia concern, so that we get a comprehensive picture of the management of this preeclamptic mother. This case scenario, 34-year-old fourth gravida who came recently to us, has got a very interesting obstetric history. This pregnancy, she is booked at 6 weeks and expected date is 2nd of July. The first pregnancy, she came to Fernandez in 2012 as a referral with severe preeclampsia at 30+ weeks of gestation, and investigations revealed HELP syndrome. We stabilized the mother and then had to do an emergency preterm cesarean section, and both mother and baby were fine, and the baby was 1.78 kg. She was fine, and she was discharged and followed for the first 2 weeks. After that, we didn't have any follow-up. She required antihypertensives for the first 2 weeks. The second pregnancy in 2016, after 4 years, she comes again to us, referral in view of gestational hypertension, but this time not a preterm, it's a late preterm, 36 weeks. When she came to us, she was having a blood pressure of 140/90, and the blood pressure was settled with a single drug, labetalol 200 milligram 8 hourly. She went back, wanted to have a term baby because she had a lot of problems with the preterm, and she wanted to have only term 37-week section. So she comes back at 37 weeks. That time we had only an albumin of 1+, blood pressure well under control. And but postpartum, after C-section, where she delivered a 3.2 kg baby, she required 2 antihypertensives for the first 2 weeks. And after that, no follow-up with us. She comes from a different district. Third pregnancy, she had a miscarriage, and the note showed that it was an early miscarriage, and she was normotensive. PP recording was there in the chit. This pregnancy, she came early. Don't know why. She felt very concerned. She got booked at 6 weeks, and she remained normotensive. But she did not have a TIFA scan with us. She did nor a first trimester fetal health check by the biochemical and the NT scan. But she was put on low dose aspirin from the district because of her previous risk factors, but she was only on 75 milligram low dose aspirin as per the NICE guidelines probably. Even though she came at 6 weeks, next time she came only at 28 weeks to us. And that time her blood pressure was 148 by 98, but previously all normal. And she has no tachycardia, tachypnea, saturations were fine. But considering her history, we wanted to admit her, but they declined and went back. And comes after 2 weeks at 31 plus 2 weeks to the emergency room with a home BP recordings of 170/100. Other symptoms she said were she had numbness over head and hand. And once she got admitted, over the time, her blood pressures were 170, 110, and saturations were fine, respiratory rate was fine, but she had brisk reflexes, and we have given her 10 milligram of nifedipine and shifted her to HDU. I want to remind all the residents that you should have the management of acute hypertension drugs to be labeled and kept in the labor wards and the emergency rooms, where according to your institute protocol, either you can use a labetalol or nifedipine, and that add the second drug, hydralazine, with the doses. And this is as per the current recommendations by the ACOG bulletin 2020. Our mother received 10 milligram of nifedipine and repeat in 20 minutes if needed, if the blood pressure is not coming down. And then you monitor the blood pressure and then add the second drug. And also, once you stabilize the mother, you should remember to have the maintenance of these antihypertensive drugs. And either it is nifedipine can be continued, or if you start labetalol, it can be given, labetalol can be continued. But remember, it's a relatively contraindicated in asthmatics. Then the course in the high dependency unit for this mother is, over the next 1 hour, she developed epigastric pain. She said she's feeling better with the numbness of head and hand. And when she developed epigastric pain, we started her magnesium sulfate prophylaxis, but labs did not show any abnormality from the admission time to the next 4 hours. But as another couple of hours, the epigastric pain became very severe. And thanks to Sunil, he was the person who told us and inspired us to do the bedside ultrasonography to look at the liver, kidney, free fluid. And everything looked fine. Amylases and lipases were normal, but the epigastric pain, there was no relief. I get a call from the resident at 2 a.m. saying that she's fine, her BP is stabilized, but epigastric pain. Immediately we told, considering her past history of health 8 years ago and gestational hypertension landing up in trouble, it can be a HELP syndrome. The symptom is only, even though lab parameters are normal, it's a severe epigastric pain. And we shifted her, stabilized her because the blood pressures are not coming under control. She went into the ICU where our anesthesia colleagues helped to stabilize her. And then we repeated in the next 4 hours, the labs, stabilized the mother, did a C-section after stabilizing her, because the bedside fetus, the NST luckily showed reactive pattern and the baby was 1.7 kilos. Over to you, Manokant, about your anesthesia concerns.
Yeah, so when we stepped in, we saw that the blood pressures were pretty high, 200.
Be on hold. I have to introduce you. Thank you, Dr. Tara, for your case. And I remember this case a few years ago. Dr. Manokant shall be discussing about the anesthesiologist perspective. I must tell you that he has taken over Fernandez Hospital from me, and I'm quite comfortable now going there only for teaching. Here's the high-risk obstetric unit at Hyderabad. He also is the program director of fellowship program in anesthesia for high-risk obstetrics. In addition, he did his fellowship in OB anesthesia from Massachusetts General Hospital, US, and he has done several workshops in obstetric critical care, ultrasound in critical care, and also relevance workshops. Over to you, Dr. Manokant, to continue this case, which is a team management, the obstetrician's perspective and the anesthesiologist perspective.
Thank you, Dr. Sunil. So when we went in, blood pressures were pretty high, 200 over 113. She was already on magnesium sulfate, and we decided to start NTG infusion also. So despite 45 minutes of NTG infusion, pressures were still high, 190 over 108. And subsequently, we received the lab reports, and that came back as a rapid deterioration from the earlier reports that were done at 11 p.m. So at 3 p.m., LDH was 738, SGPT was 255, platelets dropped from 1.5 lakh to about 1 lakh, but luckily PT-APT was still normal. So think about it for a moment and think what anesthesia would you give in such a scenario where labs have deteriorated, pressures are pretty high, 190 over 110. Would you go for a regional anesthesia or a general anesthesia? So coming to this case, when do you actually, so whenever we are in such a situation, I would think, what is the worst that can happen if I give a spinal anesthetic to this mother? So that's where I start and then plan my anesthetic. So when do you avoid central neuraxial blocks, and if you're planning to avoid, and how do you prepare for general anesthesia? So preparation for general anesthesia should be there for all cases, because we don't know when we have to fall on doing general anesthesia. So when do you avoid central neuraxial block? Platelets are less than 70,000. So now it is generally accepted that platelet counts above 70 to 80,000. It's pretty safe to do a spinal anesthetic. If there are clear signs of intracranial hemorrhage or intracranial pressure raised in ICPs, or if there's a complete abruption and mother is hemodynamically unstable, or if there is an absolute refusal from the patient, even in such a scenarios, you should try hard to convince her that regionals are much safer generally. This is a focused review done by Vanessa and their colleagues. They looked at spinal anesthesia for severe preeclamptic mothers. So they've looked at various studies that studied this aspect. So what are our usual concerns? So we usually think that when we give a spinal anesthetic, when pressures are over 200 or 190, there's a sudden precipitous fall in blood pressure. There may be a uteroplacental hypoperfusion compromising the baby, or in our anxiety to treat that hypotension, we may end up in pulmonary edema or high dose of or severe hypertension from excessive use of vasopressors. So this study looked at spinal anesthesia. So they basically looked at the effect of hypotension in severely preeclamptic mothers and normal mothers, and they've noted that the incidence of so the severely preeclamptic group experienced a lower incidence of hypotension actually when compared to the regular mothers, and they received lower dose of epinephrine to correct it. So they concluded that spinal anesthesia can be safely administered even in severely preeclamptic parturients. Another study looked at the difference between epidural and spinal for a severely preeclamptic mothers, because again, the traditional teaching is to give epidural if the pressures are very high. So again, they have noted that although there is a higher incidence of hypotension with spinal anesthesia, it was generally easily corrected with epinephrine, and the doses of epinephrine required to correct hypotension was not different between epidural and spinal group. Hypotension was easily treated and short-lived, usually less than 1 minute in both the groups. So again, they have concluded that giving spinal anesthesia is safe even when pressures are very high, when there is no other reason not to withhold a spinal anesthetic. Nowadays, we also have very fine Whitaker needles, which are quite safe. Even 29 gauge is available. We generally use 25 or 27 is our 27 Whitaker needle is our go-to needle in most situations. So whether you are doing general anesthetic or regional anesthetic, common things are surgical site infection prophylaxis. So cefazolin, 15 minutes to 1 hour before incision, then have your PPH protocol ready, start oxytocins after delivery. If required, be ready with the carboprost or misoprostol tablets and oxytocin infusion. Anticipate slow recovery in these patients, continue seizure prophylaxis for 24 to 48 hours, and monitor them in HDU for any other complications that may happen post-operatively, like exacerbation of hypertension imminent eclampsia, hemorrhage, or worsening acute kidney injury or pulmonary edema. So coming to delivery details, female baby was born, birth weight was 1.7 kgs, UPGARs were 7, 8, 9. Baby was admitted into NICU level 3, received surfactant. About estimated blood loss was about 900 ml. Intraperitoneal drain was kept with and was closed with mattress sutures. So in this woman, we gave low dose CSEA. So low dose CSEA is another option. If you are hesitant to give spinal anesthetic, fearing a sudden drop in hypotension, you can choose to do low dose CSA, especially when the platelet counts are close to 1 lakh. So that's a good middle path where you can avoid a larger spinal dose, but still be assured of a good anesthetic block from spinal anesthesia, and you always have the epidural to top it up if need be. Postoperatively, so the labs worsened a bit on 0 post-op day, and they stabilized on first post-op, and eventually patient improved. She was treated with labetalol, depin, and enalapril post-operatively. NTG infusion was tapered gradually, and she was discharged on 4th post-operative day on 2 antihypertensives. Baby was discharged from NICU after 7 days, and she was followed up by physician in the postnatal period. Take-home message: do not ignore complaints of persistent epigastric pain with a past history of hypertensive disorders. And regional anesthesia is always preferred, even if pressures are very high at the time of induction, especially when there are no other comorbid factors which would prevent you from doing a spinal anesthetic.
So now, after this, the first mother who had only symptom of persisting epigastric pain, who landed up in critical care situations. Now let's move on to the second mother, 32-year-old primey. She's just referred at 32 weeks because of the fetal growth restriction, and also the fetal Doppler compromise, increased uterine as well as umbilical artery resistance with the normal middle cerebral and ductus venosus. For a steroid therapy, essentially she was referred to us to have antepartum corticosteroids. She was asymptomatic, baseline blood test, which we call it as a preeclampsia profile, which includes liver function test, renal test, albumin, hemogram. That was normal. Her blood pressures were just 130 to 140, between 80 to 90 diastole. She got admitted because she's from outstation. And after 18 hours of admission, after the first dose of corticosteroid, her blood pressures, when we went for rounds in the room, it was 150 by 100. And we started her on oral nifedipine sustained release 10 milligram 8th hourly. So it was just, we thought it's a preeclampsia without severe features. But in the midnight, she started developing severe epigastric pain, and there was an acute rise in the blood pressure, and she was just brought into the HDU. And then we noticed that after Foley's catheterization, there was hardly any urine, but evening she passed good amount of urine in the room, but she became restless. And then we took her into the ICU, started on magnesium sulfate, and she was not lying down on the bed, and bedside ultrasound. At admission, it was a viable fetus, but suddenly it was an intrauterine fetal death and abruptio placenta. The trend of investigations, who was like a preeclampsia without severe features, when she came for admission and started having the rise in blood pressures, initially the LDH, SGPT, SGOT, creat, and everything was normal. There was a slight rise in the time when the blood pressure rose in the evening. It was 455 LDH, SGPT 370. Later in the midnight, they became very grossly abnormal when she developed abruption with intrauterine fetal death. We know that such a scenario where a mother who came just like a low risk with a mild blood pressure or a fetal growth restriction, it was very difficult for the family to accept, because we shifted her into the ICU, but she went into all these complications. She went in for acute kidney injury, and then she had DIC, and we just had to stabilize her in the ICU. Over to you, Dr. Manokant, now with these investigations.
So sudden abruption, IUFD, and rapid deterioration of labs are always a precarious scenario. And see this again, this is so common that severe preeclamptic patients becoming sick and showing up in the middle of the night for a cesarean section is such a common scenario. And if you are a trainee anesthetist, it is even more challenging. So looking at these labs, you can say, again, I want you to think what anesthetic you would give. So sudden deterioration of the labs, LDH, platelet count falling to almost 80, less than 80,000, LDH and SGPT in thousands, creatinine also rising with decreasing urine output. And so the concerns here were also there was decreasing urine output and the mother was restless and irritable. So what would you do in this case as an anesthetic? So it also there was the coagulation profile was also getting deranged. So obviously we planned for a general anesthetic in this mother. Before embarking on general anesthesia, everyone should be aware that there is increased risk of airway related mortality and morbidity in obstetric patients. So for a non-pregnant surgical population, the risk of difficult or failed intubation is about 1 in 2,800, whereas in obstetric population, it's 1 in 380. In pre-eclamptics, it's even lesser, 1 in 50. In eclamptics, because of the airway edema, it is still further less, 1 in 10. And obstetric critical care units, it is almost 1 in 8 mothers can have a difficult or failed intubation. So again, airway related mortality also is more in an obstetric population, about 2.3 per every 100,000. Also, incidence of front of neck airway access also is more in obstetric population, but it's about 3.4 per 100,000. So we all know that it's not just the obstetric airway that is difficult, but a mother who had a normal Mallampati grading at the beginning of her labor can change to a grade 3 Mallampati as she progresses through the labor because of fluid retention and airway of edema of soft tissue of throat. So whenever you are doing general anesthesia, all precautions that everyone should take are simple things like antacid prophylaxis. Then be ready with your difficult airway equipment. So mainly second generation LMAs and video laryngoscopes. And also never do general anesthetics alone in the middle of the night. Have an additional help or a senior who can come by and help you if required. The traditional teaching is to do a rapid sequence induction intubation with thiopentone and scoline and apply cricoid pressures about 30 Newton meters and use opioids after baby delivery, sometimes even inhalational anesthetics. So this is what has been the traditional teaching. But in the National Audit Project 5th NAP 5, it was pointed out that there was an increased risk of accidental awareness after general anesthetic in obstetric population. The contributing causes mostly are because of thiopentone induction. So it was suggested to use propofol instead. And usually it's the inexperienced provider providing general anesthesia in the emergency middle of the night, difficult intubating conditions, inadequate muscle relaxation. Again, because of the increased volume of distribution, you may have to give an higher dose of muscle relaxation to get adequate to adequately relax and to create adequate intubating conditions. The obesity is an independent risk factor for awareness. The lack of usage of sedatives or opioids before induction. The other thing is short duration between induction and delivery of baby. So again, babies are delivered. So surgery is started rapidly after intubation. So the mother may still not be in adequate depth of plane. So certain changes were suggested with this background. So it is suggested now that wherever possible, give at least give complete 100% oxygenation for 3 minutes at least. So instead of hurriedly inducing the mother, then ventilate before intubation, gentle ventilation. So previously it was suggested not to just hold mask, but now ventilate gently, see that the airway pressures are less than 20 centimeters of water. It's always better to gently ventilate than ventilate in panic when there is hypoxemia. Then apneic oxygenation via nasal cannula, 5 to 15 liters per minute. Then use of video laryngoscopes as first line devices for intubation. Again, the other aspect is to use opioids at the time of induction or not. So certainly it is beneficial to use opioids. Do not hesitate to use if there is an indication to use opioids at the time of induction, especially in preeclampsia patient mothers or mothers with cardiac disease or neurological compromise. So the baby, if the baby comes out limp, then baby can be managed in NICU. Do not hold back opioids where there is a clear indication. So in addition to what I have already said, the algorithm for managing difficult airway society also emphasizes that the cricoid pressure, if there is difficulty in intubating, relax or release the cricoid pressure. So do not hesitate to release the cricoid pressure. You can go for 3 attempts. The third attempt should be by an experienced colleague. After 3 attempts, if you fail to intubate, use a supraglottic airway device, preferably 2nd generation. If you are still unable to ventilate, then call the ENT surgeon and additional help and go for front of neck procedure. So planning, so it also do, if the patient mother is already on magnesium sulfate, do not stop magnesium sulfate. If there is acute kidney injury, look at potassium levels before you are using succinylcholine for muscle relaxation. You may have to use rocuronium instead, and also have a habit of doing blood gases for all these sick mothers before inducing anesthesia. Coming to treating acute treatment of hyperkalemia, you can use potassium binding resins or glucose insulin infusion, calcium gluconate, salbutamol nebulizations. If it is still not coming down, you should consider dialysis. And also treating acidosis, consider IV bicarbonates if bicarbonate levels are too low or the pH is extremely low. Most of the times, just careful fluid administration should correct the problem. And again, if the problem persists, consider dialysis. The general indications for renal replacement therapy also stands good in obstetric population. Okay, so we did this case under general anesthesia, and then she was transferred to ICU for elective ventilation, and gradually she was extubated. But what if this mother had eclampsia and was currently stable on magnesium sulfate? And what if she was fully conscious and GCS was 15 after throwing the eclamptic fit, and there was no coagulopathy, and also her BMI was more than 50. So with the background of extreme deterioration of blood reports, but an eclamptic mother who is conscious, coherent, and no obvious coagulopathy, what would you do? Would you still go for general anesthetic or choose a regional? So it is something you have to think. So again, I would start with thinking that what worse that can happen if I give spinal to this mother. So we all know that development of neuraxial hematoma after placement of neuraxial block is quite rare. So it is about 1 in 1,50,000 after epidurals and 1 in 2,20,000 in general population, and in obstetric population it is even rare, about 1 in 1,68,000 after epidural analgesia. And with spinal anesthesia, the incidence of neuraxial hematoma is unknown, so it is extremely rare for somebody to have a neuraxial hematoma after spinal anesthesia. So this is the meta-analysis which looked at studies published from 1947 to 2018. They looked at 7,509 neuraxial procedures where there was procedures, and only 33 patients had epidural or neuraxial hematomas, and this is all heterogeneous patients, not just obstetric populations. Among those 33 patients, most of the times the epidural hematoma happened when the platelet counts were less than 50,000, and there are actually only 5 obstetric patients. So between 1947 to 2018, there are only 5 obstetric patients who had neuraxial hematoma. Their platelet counts were between 44,000 to 91,000. And among those 5 patients also, 2 patients had obvious reasons to have hematoma. So one had spinal arteriovenous malformation, the other had a frank coagulopathy. Other 3 patients were HELP and eclampsia patients. SOAP recently came out with a consensus statement on how to manage patients with thrombocytopenia. So basically what they are saying is if there is any frank coagulopathy or bleeding, avoid regional anesthesia, but otherwise it is quite safe to do a regional block or spinal anesthetic if the platelets are more than 70,000, whether it is unknown etiology, ITP, gestational thrombocytopenia, or HELP syndrome, or preeclampsia. If it is HELP syndrome, check platelet counts every 6th hourly. Platelet counts more than 70,000, you can go ahead and do a spinal anesthetic if there is no coagulopathy. But the question comes when the platelet counts are between 50 and 70,000, how would you do it? So again, you have to assess risk versus benefit. So again, think whether general anesthesia is safe or regional anesthesia is safe with the background of risk of airway problems versus neuraxial hematoma. And you have to take what is the additional help and equipment that is available to you. So with all this in mind, you have to choose what to do if the platelet counts are between 50 and 70,000 and there is no frank coagulopathy. If the platelet counts are less than 50,000, obviously you should go for general anesthetic. Coming back to our case, so we did emergency cesarean section for this woman under general anesthesia. It was stillborn mother, a baby. Mother recovered after 1 month, but she required residual, but she had some residual renal failure that was requiring treatment. Coming to role of ABG, blood gases, again, if done early, it can help you in detecting sick mothers early. Base deficit more than -10 or more than 8 to 10 basically tells you that there is underlying organ dysfunction. This is one study that looked at that did ABGs in normal patients and patients with preeclampsia, and they've noted that whenever the base deficit was more than -8, there were the umbilical cord pH also was less. So this is one example where we did an ABG for a sick, severely preeclamptic mother with decreased urine output, and to our surprise, the pH was just 7.08 and base deficit was -21. So this made us to act faster. We rapidly stabilized her with antihypertensives and careful fluid optimization, did cesarean section under spinal, and then you can see that rapid improvement in blood gases and the maternal physiology by next day morning. So night 10:30, 10 o'clock, she was so sick. By morning 6 a.m., she was pretty much quite comfortable and the urine started coming out. So there's one example. If you act quickly, you can prevent long-term renal problems. So take home message, abruption with decreased urine output needs early delivery, close follow-up of renal functions in the ICU, and early initiation of RRT if indicated. Risk versus benefit assessment of the situation is essential whenever general anesthesia is contemplated for a severe preeclamptic mother. Coming to our case 3.
Dr. Sunil, since we have, I think, 2 minutes left, I'll quickly summarize the case 3. This is a lawyer couple, had 2 births with us, and this is the 3rd delivery. And in the 2nd pregnancy, she had gestational hypertension, but she was doing pretty well. In the present 3rd pregnancy, she was fine till 34 weeks of gestation, but she had acute rise in the blood pressure, 180 by 118, got admitted in the hospital. Pedal edema was there. There is no proteinuria. The liver function test, the LDH, SGOT, SGPT, creatinine, the platelet count was fine. So she actually feels that she's very fine. And even though she required antihypertensive IV for the initial 2 hours in the HDU, later in the next 48 hours, she was fine. She got the steroid cover for lung maturity and she wanted to go home. I just wanted to say that there are some difficult situations where a mother wants an outpatient monitoring, but you should have a form designated for this particular couple or that lady, and you need to follow up with having the maternal plan, the fetal plan, and the blood test when to repeat. So then this form is valid only for 1 week. You can't give for more than this. But within 4 days, she came back because she had decreased fetal movements. She has breathlessness at rest, and she thought she's fine and she didn't take an antihypertensive. So at this point, she was tachypneic, tachycardic, and 36 weeks of pregnancy with a blood pressure of 160, 110, the NST, though fine. In next half an hour, she became breathless and her blood pressure went up to 230 to 130. And here is a diagnosis of acute pulmonary edema for a woman who has gestational hypertension. So these are the lab values at 34 weeks and 35 weeks. You can see clearly the SGPT went up to 40 and then LDH was 174 at 34. But you know, she went into a pulmonary edema, and the role of ABG here, she showed which hypoxia and hypercarbia. So a mother who thinks she's the gestational hypertension, very severe pulmonary edema, here all of us should remember the HIPITAT trial, the obstetricians. We need to deliver the mothers at 36 weeks to 37 weeks to reduce the maternal morbidity, because these are the mothers who can develop pulmonary edema. So, or even abruption. Over to you, Manokant, with this scenario.
Okay. So for this scenario, I just want to talk briefly about management of pulmonary edema. So basically, whenever you see a mother with pulmonary edema, there are 4 things that you have to do. Clinical examination, apart from clinical examination, ECG, ABG, chest X-ray, 2D echo, and thorough clinical examination. With these 5 things, you can most of the times make the come to a diagnosis. And preeclampsia with preeclampsia, pulmonary edema, or pulmonary edema with hypertension and without hypertension. So for all obstetric patients, pulmonary edema with hypertension can be treated as a special entity. Here, if you aggressively treat hypertension and the pulmonary edema, and mothers quickly stabilize and you can carry on with regional anesthetic and normal delivery. Whereas if the pulmonary edema is because of some other causes like cardiac disease, sepsis, or embolism, that's a complete different line of treatment. So in pulmonary edema with backdrop of severe acute hypertension, if treated aggressively, the mother quickly bounces back, and also regional anesthesia can be done safely. So we have treated her aggressively. We gave her epidural in ICU and she delivered vaginally. Postpartum, she required some antihypertensive, levodopa and nifedipine, and she was discharged home on 7th post-op day. So take home message, exercise extreme caution and have thorough follow-up plan when discharging known preeclamptic mothers for expected management, because they can always come back with some acute emergency. Vaginal delivery and regional anesthesia are reasonable options after successfully treating pulmonary edema, especially if it is secondary to acute hypertension, when response to induction is favorable and participant is hemodynamically stable. Okay, questions?
Yeah, there are a few questions for both of you. Is echo mandatory for all preeclamptics? Anybody can take this.
My answer is yes.
I'm glad that answer is yes. Yeah, in the current scenario and with the availability of ultrasound with echo probe in virtually all the rooms, but what is your message for those who are practicing in rural areas or semi-urban setups where they don't have facility for echo or the anesthesiology is not well versed?
So if the preeclampsia is not very severe, then whenever possible, shift them to a higher center. If shifting them to higher center is not possible and medically patient is stable, then do deliver her under regional anesthesia as far as possible.
What is the role of bedside ultrasound in preeclampsia? One of that question for the speakers.
Again, bedside ultrasound for preeclampsia. Okay, if you look at from anesthetic perspective, if you're able to do a bedside 2D echo, then in situations where there is acute hypertension, you can quickly see what is the cardiac function and decide about the regional versus other modes of anesthetic. Coming to ultrasound,
I think obstetricians who all can scan should know how the placenta looks, how the kidney looks, and how the liver looks, and if there is any free fluid. We had mothers who are low hemoglobin, suddenly a drop in hemoglobin in the post-operative period, and we have detected liver hematomas. So I feel there is a role for ultrasound, and we all should be able to do the ultrasound to look at the free fluid, liver, and kidneys, definitely.
Manokant, from a critical care perspective, would you like to add anything to what Dr. Tara said? Role of ultrasound?
Obviously, these days, everyone should know how to do a focused examination with ultrasound, so that you can see if there is any intra-abdominal fluid or again cardiac function and things like that, and IVC, when there is decreased urine output, so that will help you in fluid management and things like that.
One of the delegate has asked do you use 29 gauge spinal needle routinely for all preeclampsia or only select cases?
In select cases, I would say, because 29 gauge spinal Whittaker needle also requires some skill and practice. But having said that, 27 gauge Whittaker needle is our go-to needle, our routine needle that we use in all patients, and that is pretty good. Again, the incidence of whether PDPH or hematoma is anyway extremely rare. So with 27 gauge Whittaker should be good enough. It's also easier to do. I would say even 25 gauge Whittaker needle is also good enough.
Yeah. One more question from the delegate is, what is the role of labor epidural in preeclamptics? Do you use at your
Weber epidural is helpful actually. So whenever, if the platelet counts are more than 70, 80,000, you can happily put in that epidural. Even if the platelets drop later on after putting the epidural, if you're fixing the epidural well, that should still be okay. Okay, giving a labor analgesia will obviously reduce sympathetic stimulation and will help in reducing the blood pressures and improving uteroplacental blood flow.
Dr. Tara, there is one question for you. I think we should wind up because we are running late. Last question. Any role of levetiracetam in eclamptic seizure?
Not really, unless until the first thing is Maxilf, and despite which she has convulsions, again the repeat dose of Maxilf, and still probably we are not sure about the diagnosis then, but not as a first line of modality.
So I would like to add here that there's no harm if you're unsure or to quickly control the eclamptic seizure while the magnesium sulfate is being loaded. Feel free to give benzodiazepine. So that's not an issue. And if there are repeated seizures despite giving adequate dose of magnesium sulfate, and if you're unsure what is the cause, you can give levetiracetam when you're unsure.
And can you give spinal after a tonic and clonic seizure? Dr. Monokan, some delegate has asked this question.
So again, when you're giving, the patient might have had an eclamptic fit, that is tonic-clonic seizure, but now after like maybe 2 or 3 hours have passed, mother is now is responding pretty well. She is already on magnesium sulfate. There are no obvious signs of raised ICT. I would still go ahead and give spinal if there is no coagulopathy. If the patient is unconscious or is having delirium, then that's a different story.
Yeah, thank you, Dr. Tara and Dr. Monakant, for the lovely interactive session. The team spirit was seen. So just to conclude the session, the take home from this session on hypertensive disorders in severely or critically ill parturient is it is a team management. Recognizing is important, and they deteriorate rapidly. So you need to monitor these patients serially, and they require ICU or HDU kind of monitoring at least for 24 to 48 hours after delivery. Thank you, Dr. Manokant, Tarakeshwari, and thank you, Dr. Vanita Jain and Dr. Kajal for giving us this platform. Over to you.
Thank you so much
Thank
for
you,
this lovely
Sunil.
opportunity.
And thank you, YUVA FOGSI and Chandigarh team. Thank you.
Thank you for this enlightening session. Next, I would like to welcome Dr. Kajal Jain, Professor, Department of Anesthesiology, PGIMER, Chandigarh, to moderate the e-skill station on a febrile and hemodynamically unstable parturient.
Am I live? Yeah. So a very good afternoon to all the delegates and the panelists here. So we move on to discuss another very important topic in obstetrics, and that is sepsis. We know that the maternal death following sepsis is very high. It is 11%, which is reported worldwide, and more so important is the morbidity associated with obstetric sepsis. So over the years, we have got the newer guidelines, we have got newer scores, and we have got so much recent development in this field. And therefore, we decided to take this on. And to discuss maternal sepsis with us, we have from our obstetric team, Dr. Pooja Sikka, Dr. Ashima Arora, and from the anesthesia team, we have Dr. Komal Gandhi. We have tried to make it a hybrid of, a PPT and, skills, we have asked our residents to do one scenario. So we are going to club both of these together and bring it to you. At the end of it, we are going to take the question answers. So you can tell us what exactly you have in your minds, which you face. You can share your stories, which you face when you are managing these cases. So I'll hand it over to Dr. Pooja Sikka, who will take you on to this PPT plus virtual scenario. Dr. Pooja Sikka, please.
So good afternoon. Before we start with the skill station, I would like to highlight the aims of the skill station, and we would like to answer the following questions. What is sepsis? Is obstetric sepsis different? What are the diagnostic criteria? Why do we fail to diagnose or suspect sepsis? And how to manage sepsis? So the definition and criteria of sepsis have been ever changing. For somebody, it is infection. For the others, it is fever. For others, it's leukocytosis, organ dysfunction, or shock. And we need more clarity and universality in the definition of sepsis. So as of now, the third international consensus definition for sepsis is that sepsis is a organ dysfunction because of a dysregulated host response to infection. So the culprits towards the sepsis is infection and the host. Clinically, your patient will either have infection, sepsis, or septic shock, and the term severe sepsis should not be used because sepsis and septic shock are equally important and dangerous medical emergencies, and the treatment and resuscitation should begin for sepsis and septic shock immediately. As far as obstetric sepsis is concerned, generally obstetric sepsis is associated with lower mortality if timely diagnosed and treated, because generally we are dealing with younger age population, healthy population. The disease is confined to the pelvis, which is amenable to surgical and medical intervention, and the bacteremia is also generally transient. However, when we clinically face the patients, generally the greatest missed opportunity is failure to recognize on our part. That is why we fail to respond to these patients also. So we need to differentiate a straightforward infection from one that can cause organ dysfunction or death. But how? What to follow? Do we rely on our clinical skills, lab values, cultures, imaging, or inflammatory markers? However, none is specific and none is validated for the use in pregnancy. So as of now, we have the guidelines from Surviving Sepsis Campaign for Management of Sepsis and Septic Shock 2016, and it was a quality improving initiative, and it emphasizes on implementation of sepsis bundles and providing EGDT, that is early goal directed therapy. Early goal directed therapy means that whenever you provide treatment to a patient, you have to start the treatment early with some goals and objectives in your mind. The goals during the first 6 hours of resuscitation should be to achieve a CVP of 8 to 12 millimeters of mercury. A mean arterial pressure of your patient should be more than 65 millimeters of mercury. Urine output should be more than 0.5 ml per kg per hour. And in patients with elevated lactate levels, you should target resuscitation so as to bring down the lactate levels to normal. So what is sepsis bundle? Bundle is a group of intervention when implemented together will result in better outcome than when implemented individually. So the Surviving Sepsis Campaign bundle constituents are that you should provide high flow oxygen as early as possible to your patient, send lactate levels, send blood cultures prior to antibiotics, administer broad spectrum antibiotics, and give 30 ml per kg crystalloids for hypotension, or when the lactate is more than 4 millimoles per liter. This should be completed ideally within 1 hour or till 3 hours of your resuscitation. And to be completed within 6 hours is that if there is hypotension, which is not responding to your initial fluid resuscitation, start vasopressors so as to maintain a mean arterial pressure of 65 millimeters of mercury. And if there is persistent hypotension despite volume resuscitation, start measuring CVP and keep on remeasuring lactate if the initial lactate levels were elevated. So finally, you should be liberal in making a diagnosis of sepsis. Not only vigilant, you should be hyper vigilant in vital monitoring and record keeping. You should set up a process of clear communication between laboratory and clinicians because mortality can be high. So with this background, I take you to our clean labor room where we'll see how we manage, diagnose, and provide early goal-directed therapy and septic bundles to our patients with sepsis. Thank you.
हाँ जी बताइए, हॉस्पिटल क्यों आना पड़ा?
बुखार लग रहा डॉक्टर साहब।
कब से हो रहा है बुखार?
ये 2 दिन से ऐसे डॉक्टर साहब।
अच्छा, बुखार के साथ खांसी, जुकाम, गले में खारिश?
नहीं, ऐसे तो कुछ नहीं है।
उल्टियाँ और दस्त तो नहीं लगी?
नहीं डॉक्टर साहब, ऐसे नहीं है।
पेशाब में कोई दिक्कत?
ये पेशाब में बहुत जलन हो रही है डॉक्टर साहब।
कल 10 बार रात को जाना पड़ा।
पेशाब में खून तो नहीं पड़ रहा है?
नहीं ऐसे नहीं, लेकिन रुक रुक के बहुत आ रहा है पेशाब डॉक्टर साहब।
इससे पहले प्रेगनेंसी में कभी ऐसी दिक्कत तो नहीं आई?
नहीं ऐसे कुछ नहीं डॉक्टर साहब।
कोई बाहर से दवाई तो नहीं खाई आपने इस चीज के लिए?
नहीं डॉक्टर साहब कुछ नहीं।
बुखार कितने तक का आ रहा है आपने देखा था?
कल देखा था डॉक्टर साहब, 102 तक गया था कल।
अच्छा, उसके साथ कभी भी आ रही थी?
थोड़ी बहुत होती है।
अच्छा, अभी तो आपको बुखार नहीं है, लेकिन आप पेशाब और बुखार की हिस्ट्री दे रहे हो, तो आपको एडमिट करके पेशाब और खून की कुछ जांचें भेजेंगे और आगे रिपोर्टों के हिसाब से फिर ट्रीटमेंट करेंगे। तो आप दाखिल हो जाइए।
ठीक है।
वो कर रहे हैं
शिवानी,
गुड आफ्टरनून मैम।
गुड आफ्टरनून। एनी न्यू पेशेंट्स हैव कम बाय लैब?
Yes, ma'am. Actually, 2 patients आए थे.
Okay.
One of them I want to inform you, ma'am.
Okay.
Ma'am, she is a primary gravida. She
Okay.
is 36 weeker, and she has come to me with complaints of fever and burning micturition since the past 2 days, ma'am.
अच्छा।
So on admission, because she gave such history, I sent a urine routine, and it is full of pus cells.
Okay.
So I admitted her, and ma'am.
Okay, let's examine the patient together.
Yes, ma'am.
What were her vitals when she had come?
Ma'am, when the patient came, she was not febrile, and her pulse was 100. Her BP was 92/50, and respiratory rate was 20 cycles per minute, ma'am. Saturation was 96% on room air.
If she had hypotension, then why did you not put IV cannula and start IV fluid, Shivani?
I actually checked her antenatal records, ma'am,
Okay.
and all her BP records were 90/60. So I thought her baseline of BP was itself on the lower side.
See, that's the dilemma of diagnosing sepsis in pregnancy. There are physiological changes which happen because of pregnancy, and they can mask the signs and symptoms of sepsis.
Yes, ma'am.
But this patient does look sick and definitely needs admission. What about this? हाँ, देखते हैं. What about the status of the fetus? Have you done NST for this
Yes,
patient?
ma'am. I did an NST for the patient, and it showed fetal tachycardia with reduced variability, ma'am.
Okay, and what about other investigations? Please correct them.
Yes, ma'am. Ma'am, the patient has had one fever spike now of 101, which the nursing staff has informed me. Ma'am, her ABG shows metabolic acidosis, and her lactate is 2.4, ma'am, with a total count of 24,000.
Okay. यहाँ दर्द हो रहा है. सांस नहीं आ रही डॉक्टर साहब. See, the patient definitely looks sick and is a candidate for assessment by mu score.
Okay, ma'am.
Right? So we'll assess her based on the mu score. And, as per the parameters that you've told me, patient's mu score is around 6.
Okay, ma'am.
So we need to admit the patient to HDU.
Okay,
Right? So you admit the patient to HDU, put IV cannula, flush IV fluids, start IV antibiotics,
Okay, ma'am.
catheterize the patient, send all the cultures.
Okay.
Okay. And I'll come in HDU and I'll assess the patient again.
Okay, ma'am.
I'll also inform the consultant on call in the meanwhile. You get all of this stuff.
Okay, ma'am.
Shivani, what is the status of the patient now?
Ma'am, I think the patient has deteriorated clinically because she is.
Let me just see her pulse.
Yes, ma'am. Ma'am, her pulse is now 130. Her BP was 80/40.
Okay.
And respiratory rate has increased to 30 cycles per minute, and saturation is 92% on room air, ma'am.
I asked you to catheterize the patient. So how much has been the urine output in the last 1 hour?
Ma'am, it drained around 10 ml when I catheterized the patient, and I've sent the same for culture sensitivity, ma'am.
What about her serum electrolytes, renal function tests, liver
Ma'am,
function
the
tests?
reports are awaited. It will take
Okay.
10 more minutes to get updated.
Okay. Have you done a repeat NST for the patient?
Yes, ma'am. It still shows fetal tachycardia with reduced variability, ma'am.
Okay. एक बार लेट जाइए आप.
ये लेटा जा रहा है डॉक्टर साहब.
कोशिश तो कीजिए.
सांस नहीं आ रही डॉक्टर साहब.
कहाँ पे दर्द हो रहा है? पीठ में भी दर्द हो रहा है? अभी दर्द हो रहा है आपको?
इधर भी दर्द है डॉक्टर साहब.
बच्चा अच्छे से हिल रहा है, पता चल रहा है आपको?
नहीं समझ में आ रहा डॉक्टर साहब.
Shivani, the patient is very sick and she has deteriorated in the last few hours. I think she has neurosepsis with impending septic shock.
Okay, ma'am.
So I'll discuss about this patient with our anesthesia team, and I'll also discuss the same with our consultant on call.
Okay, ma'am.
I think we'll ship the patient to ICU. In the meanwhile, you collect her investigations and you get her repeat ABG done.
Okay,
You
ma'am.
do stringent monitoring of her vitals and also keep an eye on input output.
Okay, ma'am. Ma'am, the HDU patient, BP on the monitor is 80/40.
We might have to start her on inotropes.
Yes, ma'am. Actually, I've given her paracetamol also. Still, her temperature is 102, and I've rushed 1.5 liters of fluid also.
Okay.
And
what about her investigations?
Ma'am, creatinine is 1.3.
And her urine output?
Ma'am, urine output is nil, ma'am. And her HB is 7. And I've already sent a requisition for blood cross.
Okay, see, I've discussed about this with our consultant and the anesthesia team. We have to shift the patient to main ICU.
Okay,
and they've started the process of preparing for the patient there.
Okay,
so you explain it to the attendants, you tell about the prognosis of the patient and the condition of the patient.
Okay,
in the meanwhile, we'll receive a call from there and we'll shift the patient to main ICU. Come, let's see the patient.
Happen at times. Your patient is very sick and you are still managing your monitors. So when the patient is connected, we are seeing that patient is showing a heart rate of 147 and I'm not able to see. The SATs are 93%. We are still waiting for the IBP. I think the team is connecting the patient to IBP and the central line is also being placed because this patient also needs invasive monitoring. Akriti, what is your plan? You are planning to do the conventional monitoring of hemodynamics? Please put your mic on.
The arterial line has been inserted and we have the invasive BP on the screen and the central line has been inserted. So we see that the CVP is low, that is 4, and the BP is also low. So I would like to give 500 ml of NS.
Are you really worried about this? What do you think from this screen? What do you make out? The patient is in sepsis or septic shock?
Ma'am, the patient is in septic shock and needs crystalloids at present.
You need to rush in more fluid?
Yes, ma'am. I need to give a bolus of 500 ml of NS.
Was she not given fluid in the
septic
septic
labor room? Ma'am, she was given only 500 ml of
She is not pouring urine as well? You would like to give still?
But the CVP is still low, so I would like to give more fluid.
So based on your CVP findings,
yes, ma'am,
and your low blood pressure,
and
you would like to give some fluids.
Yes, ma'am.
How much fluid?
500 ml of normal saline bolus over 15 minutes.
Okay, Shnaz, let's give her some fluids. She wants some fluids to be pumped in. So while the fluids are taking their action, let me show you what is actually going on in our body. This is what you see, the conventional hemodynamic parameters which we normally see and we treat our patients. Let us see what is actually going on when she is given a bolus of 500 mils of crystalloid over 15 minutes. So now this is another monitor which is telling you what is happening at the microcirculation level. If I have to explain you in details, and you look at the right side of the screen, where you see at the top cardiac output, CO is cardiac output, that basically will show you what a product of mean arterial pressure and stroke volume. It should be between 4 to 6 liters for an average adult. And then the next one you see at the third one, which is blinking, is the stroke volume, with the normal values for which are around 60 and above. The second one is stroke volume variation. This is a measure of fluid responsiveness, and the numerical value for this is less than 10. Can I have the marker here? Somebody was having the pointer here. So actually, if you see at the extreme left, you see one steep curve. And that steep curve, if I remind you of your physiology days, happens to be the Frank-Starling curve. The Frank-Starling curve, just in broad, if you just revise it generally, it just says the amount of stretch will determine the quantity of blood pumped out the next time. So basically, if you give volume, the heart will pump out better. So on the y-axis, we give the stroke volume. The y-axis, we give the stroke volume, and here we plot the preload. So the steep part of the curve just tells you the patient needs some more fluid and can respond to fluid. So this patient is, when she is also thinking that this patient needs more fluid, well, the internal dynamics are also telling you, yes, she does need some fluid, because she needs to be on the plateau part of the curve to be volume resuscitated. So basically the Frank-Starling curve, the cardiac output, the stroke volume variance, the stroke volume, everything is telling you that the patient needs more fluid, and her systemic vascular resistance is showing you that she's vasodilated. So she needs to be treated for septic shock. Let us see what she does next. So it's been 15 minutes, Akriti, and we have not been able to change her blood pressure. Her heart rate continues to be the same, and she has not responded really well. So what do you plan to do next?
Ma'am, the CVP is still low and the blood pressure is also low, and since there is no urine output, I would like to give a 500 ml more NS.
So you think you based on your CVP findings and based on your hemodynamic parameters, you would rush in another 500
Yes,
ml of
ma'am.
fluids, and this time again she will like to give a bolus of 15 to 30 minutes.
Give it.
So let's see when she gave this, what happened at this side of the monitor. Well, nothing has changed much. And as you all know that a lot of fluids are required during the initial resuscitation of septic shock. So your little bit of fluids are not going to do the trick, because anyways, this is the macro side of the circulation and this is the micro side of the circulation is not matching. So this patient is not responding. It's half an hour, 45 minutes on, and we are nowhere there. So Akriti, you're just given a liter of fluid. Do you think you want to go in for more? What targets are you achieving? What are you wanting to have?
Ma'am, I want a mean arterial pressure of 65.
Okay.
So I would like to give CVP of 8 to 12.
Okay. So what would you like to do now?
Ma'am, I should give more fluids. I would like to give more fluids.
One more?
Yes, ma'am.
Okay. So Shanaz, give some more fluids. Given. So well, the patient does seem to have responded a little bit. The pointer has come a little bit up on the steep curve. So patient is a fluid responder. She's responded to fluids, but we are still very low on the stroke volume variance, and stroke volume and the systemic vascular resistance also very low. Probably that is the reason patient is not being able to pump out the blood. Do you want to improve her stroke volume resistance, which is like the patient is vasodilated, you are filling her, but the heart is not able to take it? Would you like to add something?
Ma'am, I would like to add noradrenaline. We had stopped dopamine when she came to the ICU, so I would like to start noradrenaline. That is
At this point of time, would you like to start dopamine?
Ma'am, noradrenaline.
Noradrenaline over dopamine?
Ma'am, because noradrenaline is the pressure of choice in septic shock. It is a more potent vasoconstrictor, and dopamine will cause tachyarrhythmias at lower doses. Only at very high doses, that is more than 10 mics per kg per minute, it will lead to vasoconstrictive effects.
Let's give her some norepinephrine. We have given the patient norepinephrine at the standard doses, and let us see what happens next. The pressures are picking up. The cardiac output seems to have come in the green zone, but still it is low. And you have achieved a mean arterial pressure of 57, 60. There it goes. But patient is still not fine.
I think I should check the lab values.
Okay, now she has remembered she wants something from the laboratories as well. What would you like to see in the lab values? Your CVP is 6 and saturation is 91. Do you want something else to guide you for tissue perfusion?
So I would like to see the lactate and hemoglobin of the patient. So Ankur, have we received the lactate?
Yes, ma'am. The lactate is 6 and the hemoglobin is 7.
Hemoglobin is also 6?
Yes, ma'am.
Okay. So if the patient has got low hemoglobin and the patient also has high lactates, so you would like to give something here?
I would like to give 1 unit of PRBC, ma'am, since the hemoglobin is 6 and lactate.
I think she has taken a good decision because patient is still fluid deficient and patient also doesn't have RBCs, so her saturations are also low. Keeping all this in mind, yes, let's give her, Shinaz, 1 unit of given. So 1 unit of blood has gone in. Yeah, there. I think the pressures are now coming up. So patient, finally, if you talk about your fluid summary, and please check the urine output if there is some 5-10 ml there. And Ankur, can you give us the fluid summary so far? It's been 2 hours. So what all have you given so far?
So far we have given a total of 2 liter of fluid, 1.5 liter of fluid, and we started Norad here.
And 1 unit of blood.
1 unit of blood.
So are you happy, Akriti, now?
Yes, ma'am, I think the patient is responding to my management, and we receive such kind of patients in the ICU. My patient seems to be on the path to recovery.
So thank you so much. Let's go to the case again and see what all we can learn now. So this patient had fever. She came walking to you. She was conscious. She had oliguria, but she deteriorated so fast in front of you. So this is to highlight that most patients who suffer adverse outcomes are having some form of organ dysfunction that goes poorly recognized, and development of warning scores therefore can predict worsening and guide further management. So there should be an awareness among patients and doctors regarding evidence of organ dysfunction or warning scores or warning signs of organ dysfunction, and we will learn them one by one. So if you realize, the term quick SOFA was not used by our team. Quick SOFA means sequential organ failure assessment. It is a simple, prompt way to identify infected patients outside ICU who are likely to be septic. It has 3 clinical criteria: a respiratory rate of 22 per minute or greater, presence of altered mentation, or a systolic blood pressure of 100 millimeters of mercury or less. If 2 or more factors are present, it predicts risk of poor sepsis-related outcome. For pregnancy, the Society of Obstetric Medicine Australia and New Zealand have come up with obstetric modified QSOFA scores, in which the blood pressure less than 90 millimeter of mercury should be taken instead of 100, and respiratory rate more than 25 per minute should be taken instead of 22. Because of physiological changes, generally there is peripheral vasodilatation and blood pressure is generally less. So the blood pressure is not 100, it should be taken as 90. And because of the presence of tachypnea, due to physiological tachypnea, respiratory rate instead of 22, they suggest it should be 25. So our patient had some or the other form of sepsis. Maternal sepsis can either be antepartum or puerperal. Generally, puerperal or postpartum sepsis is more common than antepartum, and the patient can have several risks for going into sepsis, like immunosuppression, prolonged rupture of membranes, multiple and unclean vaginal examinations, instrumental deliveries, and infectious disorders like COVID, like tuberculosis, like dengue, like urinary tract infection. Most probably, our patient also had UTI. But what I want to highlight is that during pregnancy, uterine causes must be kept as strong differentials when your patient presents with sepsis. Uterine causes means most probably chorioamnionitis. The term III is used for uterine causes for sepsis. III means intrauterine infection or inflammation. It signifies that fever can be present with one or more of the following: fetal tachycardia, our patient had fetal tachycardia, maternal WBC count of more than 15,000, and presence of purulent fluid from cervical os. If you are able to diagnose chorioamnionitis, the treatment is not very difficult. It just requires aggressive broad spectrum antibiotics and early delivery for good maternal and fetal outcome. Most common infectious cause during antepartum period is non-pelvic in origin, and the organ systems involved generally are lungs, the gastrointestinal tract, and the urinary symptom. UTI is very common in pregnancy. Pregnancy predisposes to UTI, and the most common organisms are E. coli, Group A, Group B Streptococcus, but we should not forget that polymicrobial infection is generally most common, and that is why I give broad spectrum or polymicrobial antibiotic coverage to our patients. So then why there is failure to recognize and response to sepsis? What confuses us? It is because I feel none of the existing definitions for sepsis account for physical alterations in normal pregnancy. What is most affected in pregnancy and sepsis? Is it serum creatinine value, or is it fall in the mean arterial pressure? Is it that the common physiological signs of pregnancy like tiredness, breathlessness, vomiting, edema, palpitations, leukocytosis, thrombocytopenia, deranged liver function test misguide us and we miss sepsis? So we should be aware of the physiological changes of pregnancy. There are many. First of all, we should realize that the physiological changes of pregnancy are unique. They are limited in time. They happen only for 9 months. Virtually all maternal systems are dramatically altered. The change is rapid. and the basic mechanisms that underlie these alterations are somehow unknown. The cardiac output, for example, increases by 40 to 50%. It is maximum at 34 weeks. There is increase in stroke volume. The heart rate increases by 15 beats per minute. The blood pressure falls in the first and second trimester. There is significant increase in oxygen demand during normal pregnancy due to 15 to 20% increase in the metabolic rate. Maternal hyperventilation leads to a state of compensated respiratory alkalosis during pregnancy. So we should be vigilant for organ dysfunction or the changes in physiological parameters. How? We discussed Q so far. Now we will come to warning scores. We already have existing early warning score systems for non-pregnancy conditions. However, the physiological changes of pregnancy render them inappropriate, and therefore no validated system exists for their use in pregnant women. However, people have been trying and modified early obstetric warning score. The MUSE has been designed to allow early recognition of physical deterioration in pregnant women. A score of 0, I will explain later, triggers the use of a call-out cascade giving specific instructions regarding the level of monitoring, referral for advice, review, and immediate actions to be taken when a patient is getting sicker. However, this is still not followed in India, and I recommend that every institute should start using MUSE in a normal or an unwell pregnant woman. So the basic parameters of MUSE are 7: temperature, systolic blood pressure, diastolic blood pressure, the heart rate, respiratory rate, the level of consciousness, and the urine output. You can see that in the center, the white color, the 0 score is the normal parameters. To the right and to the left, the scores are 1, 2, and 3, 2 yellow and 1 red. When they increase from the normal, it is towards the right. And when the parameters decrease from the normal, it is to the left. But both are abnormal and both are given some scores. And I recommend, or it is recommended, that all obstetric inpatients must have a full set of observations and MUSE calculated at every transfer to a new area. You can realize that when our patient was shifted to ICU from the HDU or from the ward, MUSE was not calculated and the information was not given to the anesthetist. Any woman who triggers a MUSE more than 4 or 3 in any one parameter should have their oxygen saturations recorded with each full set of observations. That was mostly not done in our patient. So now let us see whether we gave the bundle care to our patient. The bundle care, as I already said in my initial lecture, has to be completed within the golden hour, the 1 hour or maximum 3 hours of your management. We did not give her high flow oxygen. We sent the lactate levels. Lactate levels are very important because it is an indirect evidence of the tissue oxygenation or tissue injury that is happening because of sepsis or because of hypovolemia. You should have to send blood cultures prior to antibiotics. Broad spectrum antibiotics though were administered, and what type of fluid and at what rate the fluid was given for correction of hypotension or for correction of lactate was not clearly documented. And that is most important because we have already said that the bundled approach to the management of sepsis patient is the most important for better outcome of the patient. So coming to antimicrobial therapy, empiric antibiotic therapy can be given, should be given for a duration of 7 to 10 days, which is generally adequate for most serious infections associated with sepsis and septic shock. And then it should be narrowed down according to cultures. daily assessment for de-escalation of antimicrobial therapy should be done, and measurement of procal levels can be used to support the shortening duration of antimicrobial therapy in sepsis patients. We gave our patient meropenem, and meropenem plus vancomycin provides adequate empiric coverage for most patients with sepsis. They are category C in pregnancy and can be safely administered to any sepsis or septic shock during pregnancy. But the crux of antimicrobial therapy, which we all should know, is that we should try to identify the site of infection. We should know the bug. We should know the susceptibility. We should not delay it. We should hit hard and hit early. However, we should not overtreat, and assess daily for clinical improvement and assess daily for slow or no response. For this, a clear process of communication should be set up between laboratory and clinicians, and thus critical call alerts have been set up in institutes. We just have to give a call to the microbiology department. You just have to tell them that a sick patient with sepsis has come. You just explain the clinical profile and they will give you the report of the cultures as early as possible. So coming to the fluid management, we must realize that in a patient of sepsis, fever, vasodilatation and capillary leak can lead to inadequate preload. So identification of fluid responsiveness is the crux or is the most essential component of resuscitation of a septic patient. In pregnancy, 30 ml per kg, which is mentioned in the early goal-directed therapy, could be, I feel, aggressive in pregnancy, as I already said, because of decrease in the plasma oncotic pressure. Pregnant patients are predisposed to pulmonary edema, and aggressive fluid or more fluid can lead to pulmonary edema. We should be cautious after giving initial fluid of maybe 30 and then come down to 30 ml, 20 ml per kg. NORAD is the inotrope of choice, and it has been widely studied for its effects on mother and fetus. We generally we have to give NORAD when the patient is not able to maintain her blood pressure after fluid resuscitation to a mean arterial pressure of more than 65. Presence of sepsis is not an immediate indication for delivery. We did not deliver our patient when she came at 32 weeks with sepsis, and the primary objective is only hemodynamic support and antimicrobial treatment if you have the evidence. Corticosteroids can be given for lung maturity. So now I want to highlight this article which was published around 4 years back on early goal-directed therapy, about which I had been talking in my initial slides. In NEJM, it was published, and it has shown that EGDT or early goal-directed therapy did not result in better outcomes than usual care and was associated with higher hospitalization costs across a broad range of patients. So EGDT or early goal-directed therapy is no longer recommended. And basically, we should focus on personalized care. So what we have learned finally is that the fight between humans and microbes will continue. Guidelines and recommendations will be changing. Pregnancy-related recommendations in sepsis are less, but the physiological changes will remain the same. If not, why? At least we should know what is to be done and work as a team. Thank you so much.
That was a very nice wind up of the whole sepsis e-skill station. Well, we have many questions, but due to paucity of time, I'll take the 3 very relevant ones. The first one is from a delegate who is asking us, should dopamine be preferred over noradrenaline in patients with deranged RFTs? So here I would like to say, as such, it was also pointed out in the drill that dopamine is no longer the vasopressor of choice because of its arrhythmogenic effects. And it has not even shown now to be, beneficial in patients with deranged RFTs. We have to prefer noradrenaline. And talking about noradrenaline, there's another question from one of the audience who is asking us whether noradrenaline is safe for the baby. So, we have not seen many studies with noradrenaline on fetus where sepsis is concerned, but I want to tell all obstetricians that noradrenaline is appearing as a vasopressor, as another vasopressor for cesarean sections. And its use is being seen in elective cesarean sections where it has been shown to be rather beneficial for the fetal outcome. So whether it is also beneficial in stressed conditions like sepsis is not been studied exclusively for fetal outcomes. But if we have seen evidence in normal cesarean section, I think even the fetus should be benefited, because ultimately you're improving the cardiac output, you're improving the stroke volume, and all the hemodynamic parameters are improving, so the baby is surely going to benefit. The third question and the last question which has come to us is any role of albumin in septic shock. So we've already discussed that crystalloids are the preferred intravenous agents of choice. Go a little low on IV fluids, as has been highlighted, 20 mils per kg. There is no benefit of adding synthetic colloids or albumin right now in our management of sepsis and septic shock. So it's better to go ahead with crystalloids. So with this, due to less time, if there are more questions, we will entertain those questions at the end of the session or through email. If you have, please do not hesitate to put them in the chat box. As of now, I'll wind up this sepsis e-skill station with the broad note that kindly recognize women with sepsis using bedside scores, early warning signs, and the basic management which has been shown in the skill station. Thank you very much. And now I would like to hand over to the anchor of the day, Dr. Urvashi.
Thank you for this informative session. We have all been witnesses to suboptimal patient care during transfer of a patient from one service to another, leading to adverse outcomes. With this, I would like to invite Dr. Bhavani from University of Maryland School of Medicine to moderate session on an important yet neglected topic, transport of a critically ill pregnant woman.
Good afternoon or good evening, everyone. This is a great pleasure for me to invite Dr. Anjan Trika. Now, I know him for about 25 years, and he is a gentleman and a scholar, and he's from All India Institute, and he is one of the authoritative figures in obstetric anesthesia in India. And I must say that the subject he is going to talk today is relevant to every obstetrician, because either you will be in the sending side, that means you are sending a critically ill patient to a tertiary center, or you're on the receiving side, that means you are getting a patient from another hospital referred to you. And Dr. Anjan Trika has extensive experience on this subject, and I will ask him to enlighten us on this topic. Good evening, Dr. Trika. Welcome.
Good evening, Dr. Kudali. Thank you very much for some kind words. You keep on changing the kind words and keep on adding a lot of adjectives. I really don't know whether I deserve them. But anyway, good morning. I think it's early morning with you. And
yes,
we are in the evening here. And I also must take this opportunity to thank Kajal. And I am sure Kajal is listening to us, and I'm sure Dr. Bhavani would agree with me that we will really have to find out from where does Kajal get all this energy. You know, maybe she needs energy bars day in and day out to be busy speaking every weekend and getting us to speak every weekend. Thank you, Kajal. Okay, so for the next 15 minutes, I've been asked and requested to talk about this topic, which often is neglected. And maybe our chairperson can talk about the efficient way these things happen in US. But sadly enough, we still are a way off from where we should be shifting our mothers who are a bit ill. So what I have decided to do is, when we talk about a critically ill participant being shifted, I have the strong belief that unless you have a shifting procedure in place, which involves all possible patients, then only you can see to it that a mother who is critically ill can be shifted. However, the shifting of the mother would have its own concerns. So I would, next 15 minutes, I will talk about these things. Patient transport as such, which is neglected. And then we talk about inter-hospital transfers, intra-hospital transfers, and then we also talk about our critically ill parturents. We must realize that all critically ill patients in a hospital or a nursing home or at their houses, like in India, in villages, they would need some part of some amount of shifting from a place to another place. Let's say in a hospital, a critically ill mother would need to be shifted from maybe a maternity ward to a HDU, from an HDU, maybe an operation theater, from an operation theater to a ICU, or whatever that matters. So shifting becomes a critical integral part of critical patients. And then this shifting, as we all know, could be inter-hospital or intra-hospital. And we see a lot many intra-hospital shifting also, and that is true for mothers also who are pregnant or after delivery. And this topic per se becomes important because I can assure you that in the last 30 years at AIIMS New Delhi, I would have seen all 6 things what I am projecting: equipment failure, device removal, hemodynamic instability, loss of airway, drug errors, and death. This I have seen in all shiftings in the hospital. Forget about intra-hospital. So when we shift critically sick patients, one thing which is very important is that we'll have to assess the risk-benefit ratio. And that is true for mothers. If you think a mother is sick, if you think that mother is hypotensive, if you think that mother is hypotensive, we've just heard a lecture on sepsis, and you think the mother is being managed well, do you really need to shift her to another building where there's an ICU? Think about it, see the risk-benefit ratio, and then go ahead and do it. And don't shift for the sake of shifting. And there will be very many things which would be done at the place where the mother is. Let's say you want an endoscopy done, ultrasounds are available. A lecture before sepsis was about preeclampsia, ultrasound being essential. So now we know that ultrasounds would have a probe which can give us some amount of echo picture. So do we really need to shift our patient somewhere else, because shifting can be an issue itself? And if a patient is in ICU, let's say our mother is in an ICU, has delivered, or maybe is pregnant, she lands up into ARDS, we plan a trachea on her. Do you think we need to shift her to an operation theater, which will be a couple of flights below or floors above, or a different building? So please consider that. And if a thing can be done at the patient's bedside and a transport can be avoided, that is the best part of the that will be the best for the mother. Exception would be radiology, and exception would be interventional radiology, but then those things will have to be taken in the stride and the risk accepted. So other issues would be organization skills, equipment, and manpower. Some of the important key issues are stabilization of a patient before you shift a patient. A mother will have to be stabilized before you shift her anywhere. You can't shift a patient who has a mother who is in sepsis, a blood pressure of 60 systolic. You plan to shift her to an ICU. You need to stabilize her a bit. You need to stabilize her a bit. And then when we talk about shifting from one hospital to another, then we need to have remember that there could be ground shifting and there could be air transport shifting. Now, this is also coming in a big way in our country, in India itself. We have patients being shifted from one state to another. And then there are some guidelines as to who should be accompanying what kind of patients, even mothers. If a mother is to be shifted to another hospital, what kind of or what level of help should be available, or attendance should be available while the patient is being shifted. So the attendants have been classified as a level 0, 1, 2, 3, and this level depends upon the condition of the patient, where the patient was being taken care of. Let's say we want to shift a patient from a simple maternity ward to a higher hospital for whatever reasons. Let's say the obstetrician or does an ultrasound and finds a cardiac issue in that patient in the parturient, and she decides to shift her somewhere else. Patient is perfectly fine. So you really don't need an expert person to be present along with her. So the accompanying persons have been classified. 0 would be a simple ward, and 3 would be a patient who would surely need at least one qualified doctor to be shifted along with her. And the patient along with the doctor, a patient, a doctor, and maybe another help. A word about fixed wing and rotor wing ambulances. Fixed wing would mean planes, a rotor wing would mean helicopters, and they have their own issues of physiological problems they cause as far as ill patient is concerned, which could also be a mother. Similarly, at the ground level, you have different levels of ambulances: a basic life support ambulance, an advanced life support ambulance, and a MICU ambulance. And a MICU ambulance is in fashion nowadays in India because you see a lot of mothers and other patients, or mothers who have delivered, who will end up into ARDS, are not doing well, and they're shifted from one center to another with an ECMO in place, which was started in different stage, and then they're going to a higher center. So these are the kind of transport vehicles available to us. Some other important things we have to remember, and this is my next slide, also that our monitoring has to be for all physiological functions. The transport modalities will cause problems. We talk about it. We need supportive and resuscitative equipments. We need medications. We need our respiratory equipments. And if we are going from one state to another, let's say from Chandigarh to Delhi, we have to take into account that we have everything available. Maybe the patient is just on let's say 5 liters of oxygen, but we don't really know what's going to happen to the patient over 5 hours or 6 hours or next 10 hours. And similarly, if we have our electrical equipments, we may have a foot operated suction machine, but if we have an electrical suction machine, whether we have enough of electrical sockets to use that. So we have those kind of ambulances available with us. So we must remember that before we shift patients, we'll have to do our homeworks. We'll have to have enough of gas on board before we shift them. And lastly, documentation and consenting is essential, is very essential. And you would have, if you have a mother whom you lose in the way, I can assure you, the way violence against doctors happens in India, somebody will come down to your nursing home and break it up after they realize that the patient was lost while shifting, right? So documentation and consenting, and the consent has to be very clear, witnessed, signed, and you talk to the person who's in charge of the mother. You don't take a consent from a young sister of a pregnant lady who doesn't have any say in India. You will have to call her mother-in-law or a mother or a father-in-law. At times the husbands don't have, not at times, maybe most of the time in India, husbands don't have a say in that. So a mother-in-law or a father-in-law or a mother would have to be called. And this is important, what we see in our country. I can drive down from Delhi to Chandigarh in 4 hours. An ambulance takes at least 6 to 8 hours. And if you have a farmer's rally, which is now going on, it is going to take you 12 hours. So all transportation by road, no matter if you are going to transport by air or a chopper, a chopper is easier by air. So you have to take into time the time of travel, because on that would depend upon how much of oxygen you need, how much of fluid you need, how much of other gadgetries you need. It's we've had patients who've been shifted, and this pandemic has really made us a lot wiser, because a lot of mothers or non-mothers have been shifted from various places with COVID positive reports, and they've got stuck in the way because of various traffic jams. You have flat tires. If you have a flat tire, what will happen? You can't take out the patient out on the road, get some oxygen, and then take her back in. So you will have to discount the time taken of travel. And this is important. Maybe many people are not aware of it. And it will be information for all of us and those who are not aware of it. Noise and vibration all cause problems when you are shifting patients, even mothers. Vibrations can cause increase and decrease in blood pressure. And if you are shifting patients by air, by helicopters or by planes, fixed wing planes, you would realize that both acceleration and gravitational forces will decrease or alter your blood pressures. And ideally, you should have a patient who lies vertically in an aeroplane and not parallel to the aeroplane. And the foot end should be towards the pilots and not the other way around, because when the plane goes up, you will be able to avoid any venous pooling. So these are small little things, and these have to be remembered. Sadly enough, what happens in India is that you don't have dedicated teams. They tend to pick up doctors or nurses. They do a kind of a moonlighting kind of a job or a locum job. So they are not really well aware of it. And if you have traveled in a fixed wing aircraft which is not very well pressurized, you will realize that what happens to the temperature. Even in summers, you wish that you were wearing a jacket or something of that kind. These planes, if you have a mother who develops ARDS and who has a let's say who has some amount of a small pneumothorax somewhere or a bulla, so this is going to expand when you shift patients to by air. So this is one of the indications to put a prophylactic chest drain in patients who are being shifted who are otherwise hemodynamically stable. If you shift them by air, it is worthwhile to shift them with a chest drain in place. And then motion sickness. Each one, even the doctor can have it, the mother can have it. They're all going to vomit. So if they have motion sickness, we'll have to take care of that. And these are the complications which have been reported as per the literature while patients have been shifting, have been shifted from one hospital to another by road or by air. If you see, everything has happened. So we must be aware of this, and then we must take care of this. And these are the risk factors for mothers who are likely to develop complications while shifting. If they were on ventilators, if you have high PEEP, she'll end up into a problem. If she's an elderly mother with, let's say, a history of an MI or a stent in place, history of CAD on various drugs, they are all likely to have complications while shifting, and these are the important risk factors. Now let's come to intra-hospital shifting of a participant. We talked about MEWs, we talked about Q sofas, we talked about a lot of things in the last 1.5 hours. But most of the times, our patients in the hospital are usually shifted to ICUs or operation theaters or for investigations. And what was told by the previous speaker, which was very right, that a communication between two teams was of prime importance. When you left or you are going to leave, when you are going to reach, what is going to happen, and ideally speaking, involve the higher end of the ICU or a HD where you plan to shift a patient early. If you think, let's say you're going to do a placenta accreta. In my hospital, about 3 days before a placenta accreta is operated, if she's an elective one, we know that one is around the corner. So we know that we have to keep a bed. We know that we need so many other things. So if you involve the ICU team earlier, your transportation will have less of a problem and your patients will be safe. And well, we all know that during transport, these things have to be taken care of. But again, at AIIMS, transporting a pregnant mother, a participant alone is not on. So there'll have to be 2 doctors because, be honest enough, we don't have the nursing expertise the way you can have it in USA or other parts of the world. So it all boils down to the doctor residents or even consultants for the matter. Shifting from the ward or the labor room or other such places to ICUs in a different building or different floors to monitor a fetal heart or not is still a gray area. There are no some guidelines available on fetal heart monitoring, primarily because if something goes wrong, what is the feasibility of intervention which can be taken at that time of shifting. In our hospital and in most of the hospitals in India, what we insist is that there is normally somebody sent before we shift a mother so that he can take care of the elevators. Elevator has to be stopped. Otherwise, you wait for about 5-7 minutes in front of the elevator to shift a patient who's really getting hypoxic or a patient who has a fetal heart which is not doing well. So these kind of issues will have to be settled. And yes, this is one thing which is never taken care of. And mind you, you go out of the present webinar, let's go out to PGI or come to AIIMS, most of the mothers would be shifted lying supine or whatever. It's just somehow it gets missed. I don't know why does it get missed, but it does get missed. So now we come to the second part, transfer between hospitals. Well, if you talk about transfer between hospitals of mothers, there could be 3 reasons. One is the mother is not doing well, which could be antepartum, intrapartum, postpartum. Other is that we know that the neonate would need a NICU and the NICU is not available at a given place. So we shift a patient to a different hospital. And what we forget is that after the delivery or whatever happens to the baby, both of them have to be shifted back. You'll have plenty of help while shifting to the patient to the hospital, but nothing after the hospital when the patient has to be shifted back. So all 3 types of shifting have to be taken care of. And most of the time in our country, it is because of a complicated pregnancy, or let's say after delivery PPH, or after at whatever level of gestation, or after delivery patient has aspirated or has an ARDS for any other reasons. So these are the patients who are normally shifted to a higher level. And then also because of the non-availability of NICU NICUs are available in most of the places, but they are slightly of different levels. If you have a premature birth, maybe the child would have to be looked after into a better NICU than anything else. And also what is happening nowadays is because of the availability of ECMO, you have teams which come and shift the patient from your setup to a higher setup where they really work. And we see this quite often nowadays. Yes, it involves a lot of money. If you are into corporate hospitals, this would mean a lot of money, but we are not talking about the financial aspect of this topic of transportation. I have specially kept this table, and I've specially mentioned that it is from 1995, a long ago, 1995. But the best part it is, A, B, C, D, E, F still holds good in our country and I think everywhere else. Begin with a full assessment when you shift the patient, invasive monitoring. And this we have done many times. If you have a person who's got to be shifted over 2 hours, it's worthwhile to put an RTL line and to have a transducer in place than to have an NIBP, which won't work, or there is a lot of vibrations in the ambulance. Indian roads are perfect. Bombay roads are all the more perfect. So at times, we need to overkill our monitoring so that our patient is safe and hemodynamically monitored. And all these things have to be taken care of. A, B, C, D, E, F, and the table was in an article in IGOA in 1995 by Donnelly. The thumb rule would be never shift a patient unless she has an IV line on board. Even if she is doing well, an IV line is not going to harm you, mind you. It's not going to harm you. It's not going to harm. Even if you put an IV line in 500 people and it is only used in one, I think you've done your job. Never shift patients from one hospital to another, mothers, or for that matter, anybody, unless you have an IV line in place. And no matter how stable your mother is, all non-invasive parameters will have to be monitored. And invasive, I've talked about. Many times we are shifting patients, mothers who are intubated, and that's where the problem arises. Once the mother is intubated, then the level of help available will have to be different. The level of attendance will have to be different. The transport ventilators, 90% of transport ventilators in India would be giving 100% oxygen. So somebody who's used to shifting patients with ventilators, with transport ventilators, where he can manipulate the FI to all that is required. So once a patient is intubated, a mother is intubated and shifted, the level of monitoring, the level of expertise changes. And the same is true with the fetal heart. Last line becomes again important. Unless you hand over, you have a warning system. When you took a patient, you had a warning system, you had a score on you. When you handed over, you had a score on you, and you have documented both the scores. Many times in India, it is but natural to have one of the relatives sitting inside the ambulance or with the driver when you're shifting the patient. That just calms or smoothens nerves at times. Well, don't say no to it. Somebody who's mature enough can always be made to sit with the driver in front of the box ambulance with the driver, and then they can be shifted. So these are small little things which have to be taken care of, and you only come to learn about it when you have been directly involved. And one thing which we normally do, even for all our ambulances, is that after a group of nurses and doctors have shifted mothers, then please, if they think something was wrong, have an incident reporting box in that ambulance. Let somebody anonymous put it down that NIBP was not working. Yeah, and put something that the mother was being, after they shifted the mother for 2 hours on supine, lying on her back, and then somebody realized that maybe those are the people, because if you have incident reporting, they will come up with answers. They would come up with answers that the moment a pregnant lady is to be shifted, it's a different ambulance where everything there is on the wall. It is mentioned that she has to be lying literally. Something of that kind has to be on board so that you keep on improving. And once you keep on improving, you will do well. Again, the same thing. And there are few cards which I have put across. I've taken it from a book, 2018, McGraw-Hill's. And these are the kind of things, if we have a dedicated maternity center, or we are dedicated high level or high number of mothers who are being shifted. If you have this there, that you are shifting a patient who has premature labor, so prior to the transport, this has to be all done, tick all. During the transport, tick all, and emergency medication, these are available or not. Simply, this is for preeclampsia and eclampsia. A lot of these patients, these mothers are being shifted. So please, prior to transport, during transport, after transport, and emergency medication. So if you have these kind of charts or cards available, or some kind of, forget about cards, you can have a simple registers. The registers are so common in India. You have a register, so somebody is responsible is that he or she takes it and then hands it over and comes back with an ambulance. So these go a long way. And this becomes important because every day in India, you see that in a, I'm sure Dr. Bhavani would have also read that in an Indigo plane, somebody delivered. So there's a video on that. There's a video on WhatsApp on a 1-minute-old baby delivered by an air hostess. So these kind of things go on. But the fact is that you have a contents of a flight nurse delivery bag. So why can't it be there in all ambulances? I'll show you a couple of photographs. Somebody delivers on the road. Somebody in India, they have last 3 months, there have been at least 4 news items in Delhi, I've read, where mothers had delivered in police vans. And I can assure you that, well, the outcome was good as per the news report, but there was nothing known as this available. So there has to be a delivery bag. Many airlines in all planes, they have it now. Though it is mandatory that if somebody is in the 3rd trimester, they don't really normally give her a ticket to travel by air. But still deliveries take place. So these kind of things have to be there. And this is the kind of skill which should be available. And this is again a chart that the skills should be there when we are shifting mothers from one place to another place, one state to another place. And in India, this becomes very important because in India, everybody can't afford a plane shift. Day before yesterday, it was not a mother. I shifted a husband-wife from Jalgaon, which is close to Pune by road, because it was costing them 9 lakh of rupees each spouse to be shifted from Jalgaon to Delhi. So a road was a better alternative. So if you have these kind of people available with us, a dedicated team who can shift us, a dedicated team who has some basic knowledge that, well, we are shifting a pregnant lady, these things can go wrong. This is my kit. Maybe I have to deliver halfway through. What I'm going to do. So these kind of things have to be brought into the guidelines, and then we're going to do well, and we're going to save a lot of mothers and babies. After having said all this, look what has happened. This is 2020 last year, carried in a utensil. And this lady gave a birth to a stillbirth. And look at the utensil. We've seen all these utensils in India. Maybe if you go to a marriage party, your Cokes and Limcas were cooled in this with plenty of ice in this kind of a container. So mother is being shifted like this. And this is not 1990s. This is 2020. And look at this. We've all seen these photographs. This is Assam. But what is positive out here is that tertiary healthcare worker, not tertiary, primary healthcare worker, Asha, told the lady on the right, the one wearing a red sari, to lie on her side. She's lying on a hand cart or a, she's been picked on shoulders, but somewhere down the line, you see that it is such a nice thing to see. She's lying on her side, and I can assure you somebody would have told her to do that. So Asha workers are a big issue in India, and they are the ones who can improve our transportation of mothers. They are such doing a wonderful job. They are being utilized even now for vaccination, the Asha worker. Asha worker has done wonders in India. And this is there, which is there in India. And I'm sure most of you know that number 108 ambulances. However, there are good stories and bad stories. These ambulances, I have been involved in one of the states buying these ambulances from various automobile manufacturers. What is important here is that if you're going to have it in your state, you're going to have it in a hospital, have a dedicated staff. The story tells you that, well, the outcome was bad. It is not important to buy a plush ambulance which comes at 108 number. You'll have 2 politicians coming in to inaugurate it, cut a tape. What is important is who are the people inside it, what caliber they are inside it, and that's where those cards come into play. And these were basically meant for hospital delivery. Mothers were paid some money, and these ambulances had the responsibility of shifting back mothers also. But if you have critically ill mothers, to be shifted to a higher end, you need to have the right staff in it. And it all boils down to, because government or you or me or our hospitals can't pay them, have a transport team in the hospital. If you worked abroad, well, I was in where I was abroad, every doctor wanted to be part of a transport team because he got another $500. He had some cash incentive if he went by a fixed wing aircraft or a helicopter to pick up a patient and bring back on the on the hospital roof. So some kind of incentive has to be given. Have a team where mothers who are sick have to be shifted to a different hospital, a higher hospital, or a higher hospital in a different state. And that's the way it's going to work. Otherwise, it's going to fail. To conclude, well, critically ill patients need to be transported either for investigations or for higher level care for mother, baby, or both. Separate shifting teams and equipment are ideal, and let us strive to have them. And guidelines for transfer, we cannot follow the guidelines mentioned in NHS. We cannot want the ones mentioned for Germany or for US. We will have to have our own guidelines, taking into consideration all our own logistical issues. Thank you very much. We'll be more than happy to answer any question.
Thank you, Dr. Tika. I think you have highlighted what are the current problems, particularly in India. And this subject, actually, the organizers should have given 1 hour, because this is a very, very important subject for all the obstetricians, particularly the sending and the receiving. Since the time is very short, I would just like to ask you one question. Would it be possible to develop some sort of a networking within the zone of the hospitals? For example, All India Institute and the surrounding area, prior network.
Yeah, actually, in certain states, it is being done. Tertiary care hospitals have certain primary healthcare centers and district healthcare centers which come into that, the drainage area. The same is true with corporate hospitals. Corporate hospital, which is a tertiary corporate hospital, will have drainage, middle level private hospitals where they can drain into. So it is there, but it needs a much more robust kind of organization, a totally separate organizations, a totally separate communication teams, a totally separate shifting teams. The idea is there, an average, and mind you, all over the world, it's the bureaucrat who decides what's to be done. They are aware of it. But India is such a huge country. So hopefully in another 2 or 5 years, we can have this on board. People are already thinking on it. Like we have a primary healthcare center in Ballavgarh, which is next to Faridabad, which is about 40 kilometers, and they have about 5 more centers away from Ballavgarh. So it is understood that we are catering to them. No questions asked. They have just got to phone us up that we've had a problem. We've had a cesarean section and the mother has had a problem, was not able to intubate. She's arrested. We are getting her after arrest. We were able to intubate. No questions asked. We have to accept it. And we are already ready in the A&E waiting for the patient. But then All India Institute is not India.
No, actually, I just wanted to bring that point, for the audience. So with this, I'll thank Dr. Anjan Trika, and I'll conclude this, session. And if any questions are there, Dr. Kajal will actually forward to Anjan, for communication with the audience. Thank you very much.
Thank you, Dr. Bhavani. Have a nice day.
Thank
Urvashi.
Thank you.
Thank you. It was a delight to witness this session. Next, I would like to invite Dr. Kajal Jain to moderate the session on recognizing the sick mother, risk stratification in obstetrics.
Ellison. Okay, thank you very much. So we will now invite our next speaker. Our next speaker is Dr. Ellison Langford, and I feel very happy to introduce Dr. Ellison Langford. She is not only an obstetrician by profession, but she has done a fellowship in anesthesia critical care. And this is one rare combination which we haven't seen as of now with anyone in India at least. So she has the knowledge of both sides, from obstetrician side as well as from the anesthesia side. And who would be better to address a very important topic like how to recognize a sick mother, like what is the risk stratification tools which we should know that to identify a sick mother. So Dr. Ellison Langford, please, it's a pleasure to have you on in our conference today. And I give the mic to you now.
Good morning. Thank you very much for that introduction. I really appreciate it. Good afternoon. My name is Allison Langford, and I am a maternal fetal medicine specialist and critical care physician at the University of Maryland in Baltimore, Maryland. I am honored to present Recognizing the Sick Mother, Risk Stratification in Obstetrics, a timely topic and one that I hope provides you with several tools to evaluate a sick patient. Our objectives today are to understand the challenges associated with recognizing a decompensating obstetric patient, review preventable causes of maternal morbidity and mortality worldwide, discuss the critical components of early warning system, and review several prediction models and practical tools to facilitate timely recognition and response for women developing serious acute illness. In obstetric patients, the early signs of life-threatening illness can be difficult to recognize for several reasons. Critical illness in pregnancy and postpartum women is relatively rare. Second, there is significant overlap between expected physiologic changes in pregnancy and abnormal findings in pathologic disease states. And lastly, healthy women have substantial physiologic reserve to compensate for pathologic derangements, which can mask the true degree of illness until physiologic collapse occurs. Unfortunately, delays in recognition, diagnosis, and treatment often precede a majority of deaths from hemorrhage, hypertensive disorders, infections, venous thromboembolism, and heart failure. Timely recognition of the decompensating parturient allows rapid escalation of care, implementation of treatment strategies, and potential prevention of serious illness or death. In a retrospective cohort study of pregnant and postpartum patients admitted to the intensive care unit in New Zealand for the management of sepsis, it was determined that 50% of cases were potentially preventable, predominantly due to delays in diagnosis and treatment. This data suggests that there's a need for further training in this clinical area. While there have been significant improvements in maternal mortality ratio in India from 130 deaths per 100,000 live births in 2014 to 2016 to 113 deaths per 100 live births in 2016 to 2018, there is still a substantial amount of work to be done to eliminate preventable causes of maternal mortality. I hope that over the next 20 minutes, I can provide you with several tools to add to your arsenal when evaluating pregnant and postpartum women at risk for critical illness. The ability to reliably predict who will become critically ill has been the focus of extensive research in both the obstetric and non-obstetric populations. Early warning systems have been recommended for non-obstetric patients for more than 2 decades to ensure timely recognition of patients who are developing acute illnesses. There are single parameter warning signs and multi-parameter assessment tools in which a score is assigned based on the degree of abnormality in each individual parameter. Some evidence suggests that aggregate weighted warning systems are more sensitive to detect early deterioration because multiple minor derangements may develop before a single parameter deviates far from the normal. Regardless, an effective warning system includes clear expectations for observation, predefined criteria for an abnormality, a protocol to trigger a response if an abnormality is detected, and facilitates timely diagnosis and treatment, thereby limiting disease severity and potential morbidity. Several of the most commonly used scoring systems validated in non-obstetric population are the Sequential Organ Failure Assessment, or SOFA score, Simplified Acute Physiology Score, also known as SAPS, and the Acute Physiology and Chronic Health Evaluation Score, or APACHE-2. In these reference populations, obstetric patients were often omitted or underrepresented. The SOFA score is utilized as an adjunctive tool to assess morbidity and mortality in sepsis. The choice of SOFA to measure organ dysfunction is due to its broad contents and calculates level of dysfunction in 5 organ systems, including respiratory, cardiovascular, coagulation, renal, and neurologic. The SOFA score is calculated on admission to the ICU and once every 24 hours. However, what would be more beneficial is if we had a screening tool that could be used in a non-ICU setting to predict the need for intensive care. Although not validated in the obstetric population, the Quick SOFA score, or QSOFA, is an excellent bedside tool that can be used to screen for sepsis in patients outside of the intensive care unit. While the QSOFA score was designed to be used in the setting of infection, I have found it very helpful when evaluating any sick patient of unclear etiology. A score greater than or equal to 2 points corresponds to a 3 to 14-fold increase in hospital mortality. If a patient score is greater than 2 or more on the QSOFA, then the next step is to assess for evidence of end organ dysfunction. Signs of end organ dysfunction include decreased urine output, cool and clammy skin, elevated lactate, and decreased mixed venous oxygenation. If the QSOFA score is greater than or equal to 2, and the patient has evidence of end organ dysfunction, the next step is to perform the SOFA score. Sepsis is defined by a SOFA score greater than or equal to 2 points secondary to infection. A SOFA score of 0 to 6 correlates with a mortality rate less than 10%. For scores 13 to 14, mortality approaches 50%, and for scores greater than 15, mortality of 90% is seen. A QSOFA score is simply a warning sign that a patient is at increased risk for deterioration when they have suspected infection. And while this model works very well for infection, there are many obstetric conditions such as hemorrhage and hypertensive disorders that contribute disproportionately to maternal morbidity and mortality that the QSOFA and SOFA score may not be applicable. Several of these early warning systems or prediction models, including the Quick SOFA score, do not perform well in the obstetric population. The failure of existing scoring systems to identify the risk of morbidity in obstetrics stems from the failure to account for normal physiologic changes seen in pregnancy. These changes include a decrease in diastolic blood pressure by 5 to 10 millimeters of mercury in the second trimester, with return to baseline in the third trimester, an increase in heart rate by 17%, and elevation in the leukocyte count. Those parameters that remain the same include temperature, systolic blood pressure, blood oxygen saturation, and percentage of immature neutrophils. Therefore, several pregnancy-specific prediction models have been developed to identify obstetric patients at risk of death using a combination of comorbid health conditions, clinical characteristics, physiological, and laboratory-based data. Obstetric critical care continues to evolve in both developed and developing countries. An efficient scoring system for assessment of the severity and outcome in the critically ill obstetric patient would not only contribute to the assessment of a sick obstetric patient, but would also enhance the risk stratification of pregnant patients and appropriate candidates for escalation of care. Due to the exclusion of obstetric patients in various scoring systems, such as the SAP score, Apache-2, and mortality probability models, multiple obstetric scoring systems have been created and validated over the past 20 years. Several of these tools are better at predicting hospital mortality based on pre-existing medical and obstetric conditions, while others are more effective at predicting morbidity and mortality based on changes in vital signs and laboratory data, and ultimately are better bedside tools. We will focus on the modified early obstetric warning system, maternal early warning criteria, CIPHER score, and WHO list of life-threatening conditions. Singh and colleagues evaluated the modified early obstetric warning system as a tool for predicting maternal morbidity by measuring the sensitivity, specificity, and predictive value of this model. The modified early obstetric warning system is based off of temperature, systolic blood pressure, diastolic blood pressure, heart rate, respiratory rate, oxygen saturation, pain score, and neurologic response. A trigger was defined as a single markedly abnormal observation, also known as a red trigger, or the combination of two simultaneously mildly abnormal observation, known as yellow triggers. A trigger prompted urgent medical assessment. Obstetric morbidity was defined as hemorrhage, preeclampsia, infection, venous thromboembolism, including pulmonary embolus or cerebral venous sinus thrombosis, intracranial hemorrhage, status asthmaticus, status epilepticus, diabetic ketoacidosis, myocardial infarction, pulmonary edema, and anesthetic complications. Outcomes at 30 days, including maternal morbidity, intensive care admission, and death, were collected. The charts of 676 patients were analyzed. 200 women, or 30% of the cohort, had a trigger requiring clinician evaluation. 86 patients, or 13%, met criteria for maternal morbidity, with the most common morbidities including hemorrhage, hypertensive disorders, and infection. One of the major limitations of this study is that despite the high rates of maternal morbidity, there were no ICU admissions, cardiorespiratory arrest, or death. The overall sensitivity of the modified early obstetric warning system in predicting morbidity was 89%, specificity was 79%, positive predictive value was 39%, and the negative predictive value was 98%. The modified early obstetric warning system demonstrated a much higher sensitivity than non-obstetric early warning systems that are currently in use for the adult population. The maternal early warning criteria were drawn from the initially designed modified early obstetric warning system red triggers, with several modifications that were generated by the National Partnership of Maternal Safety. The subcommittee on vital sign triggers was made up of members from 8 different professional organizations in the United States. Temperature and pain were deleted from the original criteria, and a measure of oliguria was added. All patients who meet any of the early warning criteria should receive prompt bedside evaluation. To assist in the evaluation of these patients, the committee formulated an extensive list outlining the differential diagnoses of each of the physiologic derangements. While I have not included the list in this presentation, it may be helpful to keep on labor and delivery as a reference in future circumstances. In a retrospective cohort study among 400 deliveries at the University of Chicago, Arnold's and colleagues evaluated the correlation between the maternal early warning criteria and maternal morbidity. Following the recommendation to implement the maternal early warning criteria by expert consensus, this is the first study to calculate the sensitivity, specificity, positive and negative predictive values of the maternal early warning criteria. Vital signs at the time of admission and during the labor course were reviewed to determine if they met the maternal early warning criteria vital sign triggers. Vital signs postpartum and on the antepartum floor were not reviewed, representing an intrapartum cohort only. The relative risk of morbidity was calculated in patients with single and multiple triggers. The same criteria for obstetric morbidity was used as in the modified early obstetric warning system by Singh and colleagues. 281 patients triggered the modified early warning criteria at least once, and 198 patients triggered the warning criteria multiple times. 99 patients experienced morbidity, with the most common causes of morbidity including hemorrhage, suspected infection, and preeclampsia with severe features. There was one death secondary to amniotic fluid embolism. The relative risk of morbidity associated with meeting at least one single trigger was 13.5, and with meeting multiple or recurrent triggers was 5.29. For a single trigger, the sensitivity was 97% and the specificity was 39%. Alternatively, for multiple triggers, the sensitivity was 84% and specificity was 62%. Screening tools should ideally prioritize sensitivity over specificity, and the authors found that the maternal early warning criteria have excellent sensitivity and negative predictive value. Based on this study, we can conclude that patients who do not trigger the maternal early warning criteria are at low risk for maternal morbidity. But in the current form, the maternal early warning criteria do not adequately identify patients who experience maternal morbidity. It is important to take into consideration that this cohort evaluated intrapartum patients only, and one would be remiss to think that antepartum and postpartum patients do not experience critical illness. The World Health Organization developed a list of criteria for identifying women with life-threatening conditions. The primary difference between the two groups listed in this chart is the severity of illness. In a population of 9,555 women presenting with pregnancy-related complications in Brazil, all patients that died had at least one of the WHO life-threatening conditions: intubation and ventilation not related to anesthesia, cardiopulmonary resuscitation, use of continuous vasoactive infusions, and cardiac arrest were associated with the highest relative risk of mortality. The WHO criteria for pregnancy-related life-threatening conditions were found to be highly associated with maternal deaths. While the objective of the maternal early warning signs are to identify patients before they have life-threatening conditions, this comprehensive list by the WHO is helpful in identifying critically ill obstetric patients and useful as a benchmark for assessing and improving the quality of maternal health care. In order to empirically derive an early warning score to predict maternal death, Caro et al. Analyzed physiologic data collected from obstetric patients receiving intensive care in the United Kingdom between 1995 and 2008. The authors identified the most extreme values in a number of parameters during the first 24 hours of critical care admission for more than 4,000 women admitted for pregnancy-related conditions. Based on this information, the authors created a scoring system to predict mortality that was highly accurate when applied to their validation cohort of intensive care patients. The mortality rate for all obstetric admissions to their cohort was 2.8%. The area under the curve for the receiver operating curve was 0.995. A cutoff value of 12 gives a sensitivity of 97% and specificity of 87% and total accuracy a score of 88% to predict maternal death. However, the authors note that not all of the patients in their dataset had already been admitted to an ICU, and therefore it is important to select a much lower threshold to detect patients at risk for deterioration. A more practical approach that was implemented was that the early warning score was categorized into 3 groups: low, medium, or high, which each category triggering a different response. For instance, a high score group triggered immediate notification of the critical care team. The Collaborative Integrated Pregnancy High Dependency Estimate of Risk, or CIPHER score, is a multivariable prognostic model specifically designed for critically ill obstetric patients. The CIPHER model differs from the Modified Early Obstetric Warning System and Maternal Early Warning Criteria in that it is not a bedside tool to identify the critically ill obstetric patient. The CIPHER score was made up of 13 collaborating sites with ICUs from 11 countries, including 5 high-income and 6 low to middle-income countries between 2000 and 2012. Women were included if they were admitted to the ICU for more than 24 hours during pregnancy or for up to 42 days postpartum. A composite primary outcome was defined as maternal death, need for organ support for more than 7 days, or acute life-saving intervention. 769 patients were included in the final analysis. The final variables selected for inclusion in the CIPHER model were maternal age, surgical status in the preceding 24 hours, systolic blood pressure, Glasgow Coma Scale, serum sodium, serum potassium, activated partial thromboplastin time, serum creatinine, serum bilirubin, and arterial blood gas pH. The primary composite outcome was observed in 127 or 16.5% of women. There were 59 deaths. The odds of experiencing an adverse outcome increased as serum creatinine, total bilirubin, serum sodium, and activated partial thromboplastin time increased. The area under the curve for the receiver operating curve was 0.84 for the prediction of the primary composite outcome. Although these early warning signs help identify patients at risk for clinical deterioration and often mandate immediate evaluation by a clinician, these prediction models do not always help determine which patients need an escalated level of care or transfer to an intensive care unit. In certain circumstances, such as hemorrhage, when resuscitation and treatment is initiated immediately, patients do not always require intensive care admission. On the other hand, especially as many of you have seen during the COVID-19 pandemic, obstetric patients that have signs of multi-system failure will require prolonged intensive care resources. The early warning criteria to predict maternal morbidity is more applicable at the bedside than a prediction model for maternal mortality, as this is much more uncommon. In addition, categorizing patients in low, medium, or high-risk categories for severity of illness may be helpful to guide frequency of assessment by a clinician and need for intensive care evaluation. When presented with a patient that meets early warning criteria, my suggestion would be to request help from your maternal fetal medicine specialists and intensive care colleagues early. As an intensive care physician, I would much rather know about a patient early in their course than when they are crashing. If the patient does not require intensive care immediately, then continue to be vigilant and with frequent reassessment and monitoring for signs of further decompensation. Often it is not the patient in overt septic, circulatory, or hemorrhagic shock that we have challenges identifying, but it is the obstetric patient that has in several clinical and metabolic derangements who appear clinically stable that we must identify and treat before they rapidly deteriorate. When I am asked to evaluate a patient with abnormal vital signs, my approach includes a combination of clinical and laboratory parameters to triage patient acuity. I find that heart rate, respiratory rate, need for increasing supplemental oxygen, mean arterial pressure, mental status, lactate, serum bicarbonate as a measure of acid-base status, serum creatinine, urine output, and evidence of end organ malperfusion are the most helpful determinants of patient acuity. This applies to both obstetric and non-obstetric patients, but it is critical to have an organized, systematic approach and high index of suspicion in these complex patients. In summary, consider the implementation of an early warning system on your obstetric unit, as this is the key step to recognize and facilitate timely interventions that have the potential to reduce preventable maternal morbidity and mortality worldwide. Thank you very much for your attention, and I'm happy to take any questions that you may have at this time.
Thank you very much, Dr. Ellison. That was a very, descriptive, way of telling us about various risk stratification course. And we, as we all know, these are like sort of dashboards. Some people call it as heat maps, and they increase our visual acuity and they help us in triaging the patients and then escalating their care pathways when we, look after them. And this is especially very important in obstetric patients because one patient can have multiple clinical conditions like preeclampsia with cardiomyopathy, with the valvular heart disease, and she can also be in sepsis. So it's very important to have some risk scoring system to understand which patient requires, higher care. So that was very relevantly taught to all our delegates. There are many questions, but you are also appearing in our next panel. And if you are there with us in the later half of the day and you don't mind answering the queries of our delegates, we'll be very happy. So is that okay with you, Dr. Ellison?
Yeah, that sounds great. I'm happy to answer any questions.
Yeah, so we will like to start the panel now as we are little, running behind schedule, and we unmute. So I will request Dr. Urvashi to take on and introduce the next session now. Thank you very much, Dr. Ellison.
Thank you, Dr. Kajal Jain and Dr. Allison for this wonderful session. Next up, we have roundtable discussion by experts on maternal smorgasbord. I hereby welcome Dr. Pooja Sikka, Dr. Aruna Singh, and Dr. Geetika Thakur from Department of Obstetrics and Gynecology, PGI-MER Chandigarh, to moderate this session.
Good evening, everyone. I'm honored to invite our esteemed panelists, Dr. Alison Langford, Dr. Subramaniam, Chief Anesthetist at the Rainbow Hospital, Hyderabad, Dr. Bhavani S. Kodali, Dr. Rajesh, Professor, Department of Cardiology, PGI Chandigarh, who's been running the cardio obstetric clinic for the past 20 years, Dr. Vikas Suri, who's an Associate Professor in the Department of Internal Medicine, PGI Chandigarh, Dr. Smriti Agarwal, who is our alumnus and currently Additional Professor at the Department of Obstetrics and Gynecology, King George Medical University, Lucknow. Now, without any further ado, I go to the first case scenario. A 23-year-old second gravida with one living issue at POG 35 plus 6 weeks with previous cesarean presents to the emergency with a BP record of 180 by 120 millimeters of mercury. BP has been high for the past 2 weeks. No treatment was taken for that. There are no other comorbidities. BMI is 26. The previous cesarean was done for fetal distress 2 years back. My first question is for Dr. Smriti. What is your advice to the residents on BP control and further evaluation?
Thank you so much. It is such an honor to be associated with my institute, parent institute, after such a long time. And as I can understand from your case, that this is a young lady, 23-year-old, who is a case of previous cesarean section done for fetal distress and with no comorbidities, but she has come with severe hypertension, blood pressure of 180 and 120 millimeter of mercury. So this lady would definitely need to be admitted in the emergency ward immediately. I would definitely advise my residents to immediately do a rapid initial assessment for her. Apart from blood pressure, check her respiratory rate, check her pulse rate, check her chest, check her oxygen saturation. And at the same time, also ask her if she's experiencing any symptoms like headache, oliguria, blurring of vision, or epigastric pain, so that I know what I'm dealing with. So after the initial assessment, because her blood pressure is 180 by 120, our first aim would be to control the hypertension. And I would advise my residents to secure an IV line for her and start an antihypertensive regime for acute hypertension in the form of labetalol injectable. And also give her magnesium sulfate at the same time, because she's 35 weeks, 6 days pregnancy, and she's presented with high blood pressure. So most likely she's a case of severe preeclampsia, and we would like to give her prophylactic Maxilf at this juncture. And apart from this, I would also like them to send certain investigations which are important for her further management. And those investigations include complete hemogram, renal function, liver function, LDH. And I would also like to do her coagulogram at this juncture.
Okay, thank you so much. Thank you.
After giving initial labetalol intravenous, the BP comes down to 140/90 to some records of 130/90 over the next half an hour. Urine proteins by dipstick are 2+. Magnesium sulfate loading dose has been given. The investigations which were sent are collected. The hemoglobin is all right. The positive findings are that she has a thrombocytopenia of 65,000. The serum creatinine is marginally deranged of 1.5, and she has transaminitis in the range of 120/200. She is now stable. A biophysical profile and Doppler USG is done. The fetus has absent end diastolic flow. NST is non-reassuring, showing spontaneous decelerations. So we planned a cesarean for the patient. The patient gets shifted to OT. Dr. Bhavani, what anesthesia do you advise for our patient?
So generally, my preference for all these cases is regional, as allowed by the coagulation. Sometimes, even if the coagulation is abnormal, like for example, low platelets here, I sometimes would prefer to give a bag of platelets and do regional, because regional has got a distinct advantages in a patient like this. Number one is because it actually prevents the sudden upswings in the blood pressure, and also the neurological status of the mother can be maintained, and in fact, her alertness and awakeness is an indirect indicator of brain functionality. And of course, the third thing is it also allows mother to participate in the delivery, and it will also avoid the use of inhalational agents that may also affect the tone of the uterus after the baby delivery. So regional has certainly distinct advantages. So I try to correct the coagulation as much as possible and work towards that.
Okay, sir. Thank you so much.
Go ahead.
That you've already covered. However, for our patient, we decided general anesthesia, sir. And on the OT table, her blood pressure was 160 by 110. Do you want to wait and control her blood pressure before giving anesthesia? We've not transfused any platelets, and we've already decided for general anesthesia for our patient.
Now, in a situation like this, if you have decided to give general anesthesia, the urgency of delivery is the one that dictates my course of action. For example, if the fetal heart rate is reasonably stable and the obstetrician is comfortable, I would probably first bring down the blood pressure. You can use any of the intravenous agents like labetalol or esmolol. And suppose, as you say, that the fetal heart rate was dipping, then we just go for an emergency cesarean section under general anesthesia. One thing which I would stress here is we have to prevent the upswings of the blood pressure because of intubations. And sometimes I use fentanyl, sometimes I use a little bit of Presidix, which is dexmedetomidine, or remifentanil. And also one could use a beta blocker just before intubation, like an esmolol or levetolol. So in this case, probably an arterial line would have been better, particularly if you want to monitor the blood pressure, continuously, and avoid swings at wherever it is possible, because hypertensive episodes can lead to cerebral hemorrhage in these patients, and that is something of great concern while anesthetizing these patients. Go ahead.
Thank you, sir. While doing the cesarean, oxytocin was given for the management of third stage of labor. Generalized ooze was seen from the peritoneal surfaces. However, no BPH was encountered. The duration of surgery was 1 hour 20 minutes. BP during surgery remained normal with a few records of 140/100. Urine output was 100 ml over 1 hour. Dr. Subramaniam, you are called at the time of extubation. As the patient shows no efforts, the chest is clear, pupils are unequally dilated, BP on monitor drops to 80/40, and patient has a tachycardia of 120 beats per minute.
Okay. Good evening, everybody. So, you have given away the diagnosis by talking about the pupil, but if you remove the pupil, and you should look at other causes of hypotension and tachycardia. There could be a sudden bleed in the abdomen, which very often happens in these kind of cases, that while you closed, you thought everything was normal, and very quickly there's some bleeder and a collection of blood. It could also be some fever or sepsis, which has caused hypotension and tachycardia. Of course, it may not be this sudden, some embolus. So all these are some things you should keep in mind, but because you said pupils are unequal, in fact, you would not first look at pupils in this patient till you ruled out these other things. So, pupils should raise your awareness about an intracranial event, most probably a bleed here, maybe because of the low platelet count combined with the high blood pressure. So it's a very rare possibility, but it has happened. Even in our institution, we have seen instances of intracerebral bleed with severe preeclampsia. Yeah, I think I'm done. Anything more you want to ask me?
That means you suggest that we should look for pupils when the patient is anesthetized, is under G. How do we come
normally
to know?
You don't look before extubation. You don't normally look at pupils. You assume everything is fine. Okay. But there's a way of ruling out what all are obvious causes, and one by one you rule out various things. So supposing you didn't look at pupils, what I was saying is you would look at whether there was a blood loss or other events which could cause hypotension and tachycardia, because that's visible on the monitor. Whereas your pupils, unless you open the eyes, which are normally taped, and look at it, you will not see the unequal. And the chance of a cerebral bleed is so rare that you wouldn't jump to look at pupils as the first cause. And also, I would like to add here that it's very unusual to have hypotension along with intracerebral bleed. Intracerebral bleed can happen when there is a high blood pressure. And that is the commonest, even in non-pregnant women. When you have a sudden intracranial bleed and you receive a patient in the ER, the blood pressure is on the higher side. So this is very unusual that you have hypotension and intracerebral bleed, but
And tachycardia, sir? Will the patient manifest bradycardia with the intracerebral bleed or tachycardia?
Of course. So if there is a raised ICP, then you will have both bradycardia and hypotension, which is called the Cushing's reflex.
Okay. That's
so if it's a small bleed, then you won't know till the patient wakes up where the bleed was. And there could be, if the patient is awake, you look for a focal neurological deficit, like may not be able to move one hand or may not be able to speak, things like that.
Thank you, sir. The investigations sent from OT are collected, which are suggestive of metabolic acidosis. The hemoglobin has fallen to 7.6, the platelet count of 50,000, with a prothrombin index of 70%. So this is already covered. Dr. Bhavani, with a clinical suspicion of intracranial bleed, we plan to ship the patient for non-contrast computed tomography. What prerequisites have to be taken care of while transporting a critical ill patient like this?
Now, while transport, now we have heard actually this in our previous lecture. Everything applies. Whatever we do in the operating room must be followed while transporting these patients. Now, this patient is, critically ill. So therefore, now, first of all, just I want to go back to one topic. Majority of the times, the pupil reaction is very, very difficult to make under general anesthesia because we use so many drugs. Most of the times we diagnose these bleeds because patients don't wake up after general anesthesia. And that is why we suspect something, there's a cerebral edema or cerebral hemorrhage. That's what Dr. Subramanian was trying to point out. Now, so for this patient, we have to actually monitor critically. That means we have to maintain the blood pressures in the normotensive range, or if the patient is hypotensive, normally we have to support it by inotropics. Ventilation should be continued. Oxygenation should be monitored, and the ventilation should be monitored with capnography. And this patient has to be, and also before we move the patient to the CAT scan, we must call the CAT scan and have everything ready. I mean, there's no point in taking this patient there and waiting outside the CAT scan room. So everything has to be ready prior, and probably an anesthesiologist or an additional anesthesiologist to help out in the CAT scan area to get the CT scan done. So whatever we do in the operating room must be continued during the transport and in this and during the CT scan procedure. Particularly when you are moving the patient from one stretcher to the other, we have to be extremely careful.
Thank you, sir.
Go ahead.
The NCCT head of the patient is collected, which is suggestive of frontal lobe bleed. Neurosurgery consultation is taken. The patient is planned for conservative management, closely being monitored for vitals, size of bleed, focal neurological deficit in the postoperative period. The patient was discharged after 15 days of hospital stay on tablet levetiracetam, 500 milligrams twice a day, and tablet amlodipine 5 milligrams twice a day. My last question is for Dr. Allison. What is your share of experience regarding such patients?
So, certainly we have had, and I think specifically with Dr. Kadali, I've had patients with these circumstances or something very similar that we knew often prior to going to the operating room. I'm not sure if I've experienced a patient that I suspected an intracranial bleed while under general anesthesia, but certainly did have the diagnosis prior to proceeding with cesarean delivery from likely either aneurysm rupture or from a hypertensive emergency. And I just echo what everyone else has previously said, that the most important thing is sort of medical stability of the patient before emergently proceeding with a procedure if we didn't have to, or stabilizing the patient as much as possible prior to transporting them to a CT scanner. Certainly for this patient in terms of long-term outcomes, thankfully, it sounds like she is doing okay, but that's not always the circumstance. So I think just maintaining a coordinated approach and involving, again, a multidisciplinary team as early as possible to kind of optimize these patients is probably the best thing.
Thank you, Dr. Allison. The take-home message has already been told by Dr. Allison. Now I would give the podium to Dr. Aruna to discuss the second case. Thank you, Dr. Kritika. Thank you, Dr. Kritika. So starting with second case of today's panel discussion, we have a case of 22 years old primary gravida who's a diagnosed case of rheumatic heart disease having severe mitral regurgitation and severe pulmonary artery hypertension for 3 years. Unfortunately, this patient had been non-compliant with medications. This patient was advised valve replacement from cardiology, but she didn't get it done and she got married. She planned unplanned pregnancy and she had a supervision at local dispensary. Now she has presented to our hospital at 35 weeks of gestation with recent worsening in symptoms with dyspnea of 7 days. On examination, this patient is uncomfortable with having a tachycardia of 120 beats per minute, although it is regular. And she has tachypnea of 28 breaths per minute, although she's maintaining a saturation of 98% in room air. Her GVP is not raised. On her chest examination, it revealed fine basal crepes. CVS examination showed a pansystolic murmur of grade 4 to 5. Obstetric examination was done, which was within normal limits, and this patient was not in labor. So my first question is to Dr. Samriti, ma'am. What will be your advice regarding management of such patients?
So thank you. So as I understand that this is again a young lady who is a known case of rheumatic heart disease, mitral regurgitation, and she has presented to us in NYHA4 because as I understand she's breathless and she also has crepitations, fine crepitations in her chest, right? She has a rapid heart rate, but her rhythm, do we have a comment on the rhythm? Is the rhythm regular?
Yes, ma'am. It's regular, ma'am.
Okay, so at least she is in a sinus rhythm, though she definitely has tachycardia, and her JVP is normal, it is not raised. So it clearly says that she is in NYHA4, and since she is not in labor, we have some time, we should take this opportunity and stabilize her. Definitely keep her in a proper position, give her oxygen, check her saturation, continue her oxygen saturation monitoring, and also give diuretics at the same time so that we can relieve her of pulmonary edema, and consult the cardiologist at the same time. And I can see that in our panel we have an esteemed cardiologist, and of course take their opinion because we need to control her heart rate immediately. At the same time, while I'm stabilizing the lady, I would also like to rule out certain precipitating factors which can lead to decompensation of this lady, which could be anemia. So I would like to send her investigations, do her hemoglobin, check her blood pressure. Is she hypertensive? Because that can again further worsen her condition. Or if she's experiencing any fever or any signs of infection, because these again can deteriorate her condition. I would like to stabilize her since she is not in labor, and call for an ECG and an echocardiography preferably, and seek advice from a cardiologist colleague.
Okay, thank you. Thank you, Dr. Samriti. On collecting investigations, she had a normal hemogram with no evidence of leukocytosis, and she had a normal HP. She had no evidence of dyselectrolytemia. On her ECG, there was evidence of sinus tachycardia with evidence of left ventricular hypertrophy. On her echo examination, it showed severe mitral regurgitation and dilated left atria, although there was no evidence of any clot. She had severe pulmonary artery hypertension, and she was maintaining a normal LV ejection fraction of 55 to 60%. So my next question is to Dr. Rajesh. Sir, what will be your advice to cardiology and gynae resident for stabilization of this patient?
Thanks for the invitation. I do agree with that Smriti regarding initial management of this case. Yes, the patient is in congestive heart failure with the MR, PH, NYHA class 4, and she needs the stabilization, which includes propped up position, oxygen inhalation, and the diuretic, preferably intravenous. and should be monitored for the saturation and also for the heart rate and blood pressure. ECG did show the normal sinus rhythm, which is something good, that despite having the heart rate, which is 120, it's a normal sinus rhythm. And this is all secondary to say underlying congestive heart failure instead of suspecting the atrial fibrillation. So for the time being, the management is going to be the same, oxygen inhalation and of course the diuretic. As the hemoglobin is 10.5, I would prefer to have it on the higher side. But as she is 35 weeks, there is no question to go ahead for more fluid load by giving, say, blood transfusion. So of course, the iron and B complex must be going on. And the potassium 3.5 is something which, as a cardiologist, I would prefer to have the value to 4. To the level of the 4 instead of 3.5. So that has to be raised. So a diuretic with the potassium sparing or potassium supplementation is required.
Okay, thank you, Dr. Rajesh. We propped up this patient, put on high flow oxygen and injection IV diuretic in the focusation proxima 20. Start was given, followed by twice daily dose. With these patients, symptoms improved. This patient stayed in high dependency area for another 2 days. After that, she was stepped down and shifted to general ward. On day 4 of admission, on morning round, patient complained of palpitations, chest discomfort, and pain abdomen. On examination, she was found to have very high, feeble, and irregular heart rate, and her respiratory rate was 38 per minute. Chest examination reveals CREPS. ECG leads were attached to monitor, which showed evidence of atrial fibrillation. Mild uterine contractions were present. This is the ECG 12-lead ECG, which was further ordered. It shows evidence of atrial fibrillation with fast ventricular rate. So, Dr. Rajesh, at this stage, how do we control heart rate of this patient?
So here, a patient who was already been advised for mitral valve replacement 3 years back got deteriorated at 35 weeks with atrial fibrillation and fast ventricular rate. The congestive heart failure got worsened because of AF and fast ventricular rate, and therefore she require intensive care and intensive management instead of, say, conservative management. At this point of time, the primary area of interest is going to control the heart rate and to have an appropriate cardiac output, forward cardiac output, and therefore patient can be stabilized. So main target is going to be control of the heart rate for the atrial fibrillation, which can be done by intravenous metoprolol or diltiazem. As the blood pressure is 100, time being we can avoid giving the DC shock. And second thing, as the atrial fibrillation is there, which is new onset, there is a need to have an anticoagulation to prevent the cardiac thrombus and peripheral systemic or pulmonary embolism. So heparin dosage is also to be given.
Thank you, sir. As this patient was in labor, so we did not give any anticoagulation at this stage. But however, for heart rate control, we gave injection metoprolol 5 mg IV, which was repeated on 2 occasions. After that, injection diltiazem 25 mg IV was considered as heart rate was not controlled. And subsequently, systolic BP started falling and it fell down to 80 millimeters of mercury. And we had a clinical scenario of persistent atrial fibrillation with fast ventricular rate. So this patient was shifted to OT for better resuscitation. So my question is again to Dr. Rajesh only. Sir, how will you proceed to revert atrial fibrillation in a patient whose heart rate is not being controlled by giving beta blocker and calcium channel blocker? And sir, what do we do first? Whether rate control first is our goal or rhythm control? How do we decide?
Okay, so at this moment of time, the patient needs the attention and intensive care by both obstetrician and also the cardiologist. Obstetrician for ongoing labor and uterine contraction at 35 weeks of gestation or 36 weeks of gestation. And for cardiologists, that's atrial fibrillation, which did not get control, and now patient become hemodynamically unstable with the blood pressure of 80 millimeter, despite giving IV diltiazem and IV metoprolol. So this is the time because of the hemodynamic instability and high morbidity and mortality for both fetus and for the mother, there is need to go ahead and put that DC shock. The site for the DC shock means where should it give? should be given either in the intensive care unit, ICU, or coronary care unit, or in the operation theater. I think best is to go ahead in the labor room, operation theater, where the coordinated approach with the anesthetic, with the anesthetic, obstetrician, and cardiologist, we can go ahead and give a DC shock. Before giving the DC shock, of course, there is a need to have a written informed consent because there is always a risk to have a fetal and maternal adverse outcome. Fetal monitoring is also required to look for any arrhythmia or cardiac stent in the fetus after giving the DC shock. So only treatment at this moment of time is the DC shock with appropriate emergency care.
Okay.
Here the need is not to control the rate, which we have already tried with IV metoprolol and Diljam. So here there is a need when hemodynamic instability is there to have the rhythm control, which can be taken care by a synchronized DC shock.
Thank you, sir. Okay, next. So how is DC shock different in a pregnant patient as compared to non-pregnant counterpart? Is there any difference, sir?
No, it is more or less same way one has to give, but then one pedal which is been put in the axillary part can be moved somewhat upward so that we are not going to give too much of current to the pregnant uterus and also the fetus. So that is the precaution to be taken care of during the DC shock. It's usually 150 to 200 joule which can be given, but then as I already mentioned about appropriate consent and fetal monitoring pre and post DC shock to be taken care of.
Thank you, sir. Thank you so much. My next question is to Dr. Subramaniam. Sir, what is your experience with such patients?
So, I mean, we are fortunate if we have a cardiologist to do all this, but very often, I mean, these kind of situations happen in the middle of the night or in the OT, and you know, many hospitals may not have the support system of an in-house cardiologist. So the anesthesiologist by default has to deal with these situations. And I would completely agree with Dr. Vijay Vargya's line of treatment that you first, we wait for, before giving DC shock, sorry, what I meant is DC shock is indicated if there is a hemodynamic instability and the medical therapy is not working. So whatever is the medical therapy, you have tried to decrease the rate. We have already mentioned beta blockers, calcium channel blockers, but digoxin is also another drug which can be tried and which is very useful. So if these don't work, and if there is a hemodynamic instability like we have shown with a low blood pressure of 80, then I think it's very safe to do a DC shock with very minimal sedation. It's very safe both to the mother and the baby, and I think we shouldn't waste time and quickly go ahead and do this.
Sir, why is it not the first line of management? Why do we try to control the rate with medical management if it's safe for the mother and the baby?
Yeah, basically because it's a procedure. You have to give some sedation. There is a concern about aspiration and mother's fasting state. You're not intubating here. You're giving some propofol, so you could lose the airway. So you don't know the correct amount to be given. So if, you know, those, you have to weigh the balance of the benefit versus the risk of causing a problem while trying to correct it with your medical, I mean.
In our patient, inotropium started since she had evidence of hypertension. Amiodarone bolus was given, followed by continuous infusion, and electrical cardioversion was done, and rhythm was reverted back to sinus. Simultaneously, uterine contractions were found out to be increasing in intensity, and we did a PV examination and found that cervical dilatation was 2 centimeters with 50% effacement. My next question is to Dr. Ellison. What do you suggest regarding labor management at this stage? Ma'am, do we do urgent cesarean section?
So I think one of the challenges in determining kind of mode of delivery is her, again, stability. Certainly, as we discussed, she has pulmonary hypertension, which would require probably invasive cardiac monitoring as her hemodynamics change throughout her labor course. Certainly, I always advocate for a vaginal delivery if possible, and involving the anesthesia team very early. So if it would be possible to get this person, this patient an early epidural so that we can manage her pain adequately. I think I would need potentially a little bit more information about her hemodynamics in terms of her right heart, given her pulmonary hypertension, and the fact that she's actually on inotropes makes me think if she's doing okay on that without, again, evidence of end organ dysfunction, then maybe I would consider proceeding with a labor course with an assisted second stage of labor.
Thank you, ma'am. We did a cesarean section for this patient. We intubated the patient and general anesthesia was induced with opioids, and cesarean was started. We delivered a live-born girl child of 2.3 kg with poor FGARs. This patient has another bout of atrial fibrillation with very fast ventricular rate. Here, systolic BP went down to 40 millimeters of mercury, and she received another DC shock. Rhythm was reverted back to sinus, and her vitals were stabilized with 2 inotrope infusion along with amiodarone infusion. So my next question is also to Dr. Rajesh. Sir, what do you advise a post-operative care of a patient who has been resuscitated twice and who's already on 2 inotropes along with amiodarone infusion? Do we consider CCU transfer?
Yes, definitely she needs the CCU transfer and intensive cardiac monitoring to look for how the hemodynamics do improve after having a normal sinus rhythm. For NTC shock, antiarrhythmic measure has to be hiked up, amiodarone infusion, other oral antiarrhythmic drug to be added to have a normal sinus rhythm, or even if there is reversal to the atrial fibrillation, the rate has to be controlled with the drugs. After having the appropriate hemodynamic stabilization, she needs the definite treatment for the mitral valve, which was advised her around 3 years back. So as soon as she is stable enough, or maybe this time after the delivery, or maybe at the follow-up, she has to be advised to go ahead for the mitral valve replacement.
Thank you, sir. This patient was shifted to intensive care unit on inotropes and amiodarone infusion, and thromboprophylaxis was started after 12 hours of cesarean. And after keeping this patient on medical management, she was discharged after 7 days. Sir, what are chances of recurrence of AF in postpartum patient, and what is role and ideal time to do a valve replacement?
So as this patient already had an AF twice, there is a subset of, say, LA enlargement, PAH, mitral stenosis, and mitral regurgitation. So she is going to have a recurrent atrial fibrillation and ultimately going to be in a permanent atrial fibrillation. So there is a high chance to have a recurrence, and that in that condition, she has to be an adequate control of the rate, this time not the rhythm, because ultimately she is going to have a persistent atrial fibrillation because of the underlying heart disease. And of course, there is a need to go ahead for the valve replacement at earliest so that any further hemodynamic compromise can be prevented.
Thank you, sir. Thank you so much. So goal of management of atrial fibrillation in pregnant patient are medical management to control rate and rhythm, cardioversion if hemodynamically unstable, and thromboprophylaxis. With this, I thank you all. Thank you.
So coming to the last case, this case is of a doctor who is 26 years old, primary gravida, had a well-supervised, uncomplicated pregnancy throughout. However, at 38 weeks of gestation, she's been having fever for 3 days. The fever trend was that it was between 38 to 39. She was taking antipyretics round the clock, but she got worried when she started having dyspnea. It was not associated with any cough, and the breathlessness was now even at rest. So she has come to you, which is a tertiary care hospital. So Dr. Smriti, please, will you take this question? I just want your advice on evaluation of acute febrile illness and management for the mother and baby at term.
Thank you, Pooja. As I understand, this lady had a short duration of illness, 3 days, but she presented with high-grade fever, 39, right? And plus, the symptoms which she had, what was important was to note was that she was having dyspnea and breathlessness at rest. So I think, as we had been discussing even earlier, I think you took an excellent talk on this topic. So I think I would like to do a rapid initial assessment for her, and at the same time, check her pulse, blood pressure, and check her saturation and respiratory rate. Auscultate her chest, because if she's having fever, 3 days, and breathlessness, I would like to rule out a cardiopulmonary cause first. So do her Q-SOFA score, because she is having fever. So her respiratory rate is more than 22. Though her mentation is fine, I don't know about her blood pressure. So and then we would proceed with the bundle, the sepsis bundle which we have, which includes.
Next slide.
So which includes, checking her lactate levels, obtaining her blood cultures, and starting her on.
I will give you the investigations, Dr. Smriti. Her hemoglobin is 10. Her THC, she has leukopenia around 4,000. Platelet count is 64,000. Her PTI is 80%. Her blood urea is 40. And her liver enzymes are also 4 to 5 times 120 to 200. She had already got a urine culture and a blood culture done from outside, which are sterile. Her RT-PCR for COVID-19 is negative, and her dengue NS1 is positive. So, Dr. Vikas, I want to know, what are the common causes of fever with breathlessness in pregnancy? Any investigations I have missed?
Firstly, thank you to the organizers for giving an opportunity to and for the invitation. Ma'am, if this question was asked to me in somewhere in February 2020, my answer would have been different. But as on date, if I have to name 3 causes, it would be COVID.
Yeah, I knew you would give this answer.
When I looked up the PubMed for the causes of fever and breathlessness in pregnancy, out of the 124 articles, 68 were COVID related. So if we go beyond COVID, if we want to de-COVIDify ourselves, then the common causes of fever and breathlessness in pregnancy would be divided into 2 parts, that is the infectious versus the non-infectious. The non-infectious, ma'am, as Dr. Smriti has said, we have to rule out a cardiopulmonary cause. We have to rule out pulmonary embolism, because sometimes it can also present with fever and breathlessness. But in India, I think so, from the third world country and developing country, the infections would remain the most common etiology for fever and breathlessness in a pregnancy. And we come from a tropical country. Tropical infections come foremost as compared to the other infections. We did a study in our adult patients. They did not include, it also included pregnant patients. This was the pre-COVID era. The most common causes of fever and breathlessness was scrub typhus, followed by H1N1 infection, and followed by malaria and other tropical infections. Dr. Pooja has done a wonderful thesis, which included 181 patients of fever in pregnancy, in which breathlessness and pneumonitis contributed about 30 to 40%. And the most common etiologies were again scrub typhus, dengue, and H1N1 infection. So we have to, the COVID and the non-COVID causes are different, but I would probably say that it is, you've already said that dengue is positive. One thing, the odd for a primary dengue in this patient is that patient has a fever for 3 days, patient has got transaminitis, patient has got thrombocytopenia. For primary dengue, it's odd. If the patient has dengue, then the patient probably has a secondary dengue. Secondary dengue is that the patient would have been infected by a different serotype of the dengue virus. And this time she may be infected by a different, because the thrombocytopenia in primary dengue occurs generally by day 6 or day 7. It does not occur very early. While in secondary dengue, all these transaminitis and the thrombocytopenia occur very early. The IgM occurs, the seroconversion also occurs very early. The IgM and IgG are, the ratio is altered. they generally have severe disease and they go into more complications. So my hunch is that if she has dengue, it is secondary dengue. And lastly, I would say that we have to rule out co-infections. Co-infections with malaria and dengue, co-infections with malaria and scrub, co-infections with dengue and even COVID have been described. So in the study which Dr. Pooja had done, 10% had co-infections. So co-infections have also been ruled out in this patient. So as a protocol in PGI, we have developed a mnemonic which is known as LEMDES, which includes leptospira, enteric. We work up for leptospira, enteric, malaria, enteric, scrub typhus, and other viral infections. So this is the spectrum of infections which we cover in patients of fever and breathlessness.
Okay, thank you so much. So what I assume is that rare things can also happen, and even during febrile phase, she has had transaminitis and thrombocytopenia, which should not have occurred. So I wanted to ask you which investigations I have made. So this is her chest X-ray, which is showing very subtle change of ARDS. So I want to know, suppose she is NS1 positive, it is around day 3, day 4 of fever. What is your advice on supportive management, specifically on fluids? Do we give her antibiotics? She is 38 weeks. How do we critically monitor her for worsening?
Ma'am has already said that this patient seems to be, because the X-ray is nearly normal, so we can say that she doesn't have the typical pneumonitis type of illness, that is scrub typhus or any other lung-specific illness. So she has probably only dengue, and that too secondary dengue. They generally do not no role of prophylactic antibiotics in pure dengue patient. But as in your study, you had said that that empirical antibiotics, if we're suspecting, if we have any of those LEMDES worker positive, then we can consider. But antibiotics per se for dengue has no role. We have to monitor because she is in a high risk category for developing severe disease. So we have to monitor for the pulse pressure, the hematocrit, all the critical parameters, which includes the transaminitis and the look for thrombocytopenia, probably at least once a day, and all the clinical parameters every 4 to 6 hours. Supportive management, we can probably monitor all these and then decide accordingly.
She has to be hospitalized and to be kept in HDU. Okay. So her fever has been persisting. It's 48 hours of admission. She requires some oxygen support. She is accepting orally. Her urine output is adequate. Dr. Smriti, as she is stable, almost stable. So now you have done an obstetric ultrasound. Fetus is live and AFI is 3 to 4. Her NST shows reduced baseline variability with late decelerations. So my question is to Dr. Ellison, please. Ma'am, what will you do? Do you want to give her additional stress of labor or cesarean, or do you want to wait? As Dr. Vikas has already said, she is coming out of the febrile phase and maybe entering the critical phase. So do we give her the stress of labor, cesarean, or just let go of the fetus? She's a doctor, she's 38 weeks term, uncomplicated throughout.
I think if at this point with signs of non-reassuring fetal status with oligohydramnios and decelerations, unfortunately, I think our hands are probably tied. As long as we've optimized mom, she's adequately fluid resuscitated, she's not hypotensive. If there's nothing else that we can optimize, I think we would move forward with delivery at that point, especially if there's any potential benefit that may actually help her. So in this case, it does not seem that the baby would likely tolerate labor, so probably would favor cesarean delivery.
That means dengue into critical phase is not a contraindication for operative delivery cesarean. So the obstetric team and the patient decided for cesarean. Subramaniam sir, what special precautions will you take before taking her up for cesarean? I specifically want to understand or know about anesthesia, transfusion of products, drugs you will prefer or avoid, and backup facility.
Thank you. So one thing is, I mean, in dengue, as you said already, there is a higher chance of her going into a dengue shock with any added stress like surgery. Ideally, if you wait for 7 days, she would have come out of this, and the outcome would have been a lot better. But I mean, this is an obstetric decision, as earlier Dr. Kodali said. This is for you people to decide. And if you say we can't wait, then we have no choice but to proceed for section. So I think because of her low platelet count and breathlessness and other symptoms, general anesthesia would be the choice of anesthesia. And coming to transfusion of blood and products, normally pre-anesthesia, we would go by the CBP, the PCV especially, the Paxil volume, to see the intraoperative volume status. And we try to guide the fluid therapy based on the PCV and aim for a normal PCV and fluid therapy to ensure there's no hemoconcentration. And the blood products specifically are, I mean, though 60,000 platelet count is a contraindication for spinal or epidural, for surgical, for a safe surgery, a platelet count of 50,000 is adequate. So I wouldn't transfuse platelets till if I'm anticipating a further fall or the patient platelets fall below 50,000. Likewise, I wouldn't give blood unless the hemoglobin is less than 7 or so, because she's otherwise fit and healthy. Coming to
what I understand is that she is going to bleed from the uterus after delivery of the placenta, but still.
Yeah, I mean, so keeping a product ready and actually transfusing are two different things. So in an institution like PGI or wherever, if you keep the products ready and then you proceed accordingly, that would be the plan rather than preemptively transfuse unnecessary products. So the other thing is FFP.
What is the harm in transfusing? Build up to 80,000.
I mean, there's no harm. What if a patient's platelet count is 1 lakh and you give and make it 1,50,000? So I don't think, see, when it is safe to do a surgery with a platelet count of 50,000, why do you want a higher count? Unless you're predicting that it's going to fall lower than that, which we are not sure of.
I just wanted to know whether transfusion is going to make her condition worse. It's nothing like that.
That possibility also exists. If she has a tight vascular compartment, then transfusion could tip her into a pulmonary edema or something. But it's all case to case how you take this.
Okay.
And there's no specific drugs which we avoid. Most of the anesthetic drugs are very safe for most of the patients. They're all tried and tested. There are very few anesthetic drugs which we use for general anesthesia, which are fairly safe for most patients. Coming to backup, this patient, majority of the time we would not think of extubating on table. We would take her to, depending on what your setup is, in our hospital, we have a maternal intensive care. We would ventilate for a day or two and gradually wean her on CPAP or whatever and then extubate rather than try extubating on table. If that facility doesn't exist, she should go to an intensive care multidisciplinary unit.
Okay, very clear answer, sir. Thank you so much. So, Dr. Ellison, any specific advice to the operating team regarding the incision, how to prevent PPH? We don't want to transfuse her unnecessary platelets and blood. Advice to the obstetrician?
I think, certainly having the most experienced provider perform these surgeries in critically ill patients, and that, certainly while we advocate for teaching, this is something that should be done very quickly if possible. There's really, unfortunately, it's really challenging to minimize blood loss per se, but in a term patient with a low transverse hysterotomy, hopefully, certainly we wouldn't need to do a classical hysterotomy for any reason, which we know can be associated with much greater blood loss. So just communication with the anesthesia team. If there is any indication that there's greater blood loss, certainly being proactive in using uterotonics if necessary. So as we've oxytocin, as well as if she needed other uterotonics, such as I don't think she had any contraindications for methergin per se or misoprostol, then we could use those medications early.
Okay. Thank you. So the cesarean was done under general anesthesia. She maintained her vitals. Blood loss was around 1 liter. She received uterotonics in the form of oxytocin and rectal misoprostol. Baby is fine. Input, the IV fluids given during cesarean were around 1.5 liters. And the urine output during the cesarean is 40 ml. So Dr. Subramaniam has already told that he doesn't plan to extubate her and he doesn't want to shift her to CLR or SLR and wants to shift to ICU or HDU. That's great, sir. So our patient was extubated, however, and she was shifted to HDU, but the resident felt that she is still tachypneic and she has labored breathing. Her hemoglobin is 8, platelets is 50,000, PTI is 65%, urea has risen from 40 to 54, and creatinine is 1.8. 8 hours post-op, the resident sees that the urine output is 60 ml since surgery. Her ABG pH is 7.24. Her bicarb is 15-16. Her oxygen saturation is 95 and lactates is 4. So, Dr. Vikas, what is your suggestion? What should we do? Should we now transfuse blood, platelets, give her IV fluids, we give her Lasix, but she has no fever now. So what I mean to say is that she is maybe out of the febrile phase and has drastically entered the critical phase. What is to be done for her urine output? AKI has been settling for last few hours now.
Firstly, ma'am, giving platelets in dengue fever can be harmful also, because there is no role, and actually studies have shown given prophylactic platelets is actually harmful. The indication for transfusion blood products is purely on obstetrical basis. For dengue, the cardinal treatment, the gold standard is IV fluids. The choice of IV fluids, crystalloids are always preferred over colloids. Only indication of colloids is the patient who is unstable and who has shock. In this patient, because these dengue patients are pseudo-hydrated, because of the plasma leak, they're pseudo-hydrated. So we have to be very careful in giving fluids to them. And the choice of fluids, they say that even very large amount of 0.9% on normal saline may even lead to hypochloremic acidosis and even worsen the lactic acidosis, which probably would have happened in this patient. Probably because of the fluid loss and because of the pseudo-dehydrated state, patient may be going into a dengue shock syndrome. And that is why this is contributing to her decrease in the urine output.
So that is what I want to know, that exactly at this point of time, do we try fluid and Lasix challenge or
we have to give fluids? It has, as already Dr. Subramanian said, it has to be directed based on the hematocrit. If the patient goes into shock, we can try colloids. But crystalloids, that is, we have to juggle between 0.9% saline and ringer acetate rather than ringer lactate, because ringer
and
lactate.
Not dialysis at this time?
I would not, because at this moment her urine output is okay. I would probably more consider on giving her guarded fluids and so that prevent her going into dengue shock syndrome and give her fluids rather than Lasix. And we have many non-invasive measures to see the fluid status, IVC, and see the other things. And we can probably fluids would be better in this.
So she has not responded to fluids. In next 6 hours also, urine output is 10 ml. AKI has settled and we've got a nephrology consultation now, and she's been planned for hemodialysis. So Bhavani sir, I wanted to know, because we had extubated her, will you intubate her before shifting for dialysis?
So first of all, yeah, for dialysis, actually the patient, the patient should not be moved from here. I think the dialysis should be done in ICU itself. I would certainly intubate this patient because she is already tachypneic, hypovolemic, and dialysis is going to produce a lot of fluid shifts, and she would go into hypotension, and and that would worsen her her presentation and will need an emergency intubation during dialysis. So I think at this stage, I'll probably go ahead and intubate this patient and have the dialysis done in the ICU itself, rather than shifting this patient to the to the dialysis unit. And I would probably may have to have some sort of inotropic support as a standby if needed.
So your advice is that such patients should not be shifted to HDU. They should be shifted to ICU, where there is a facility of at least bedside dialysis, and they should not be
bedside dialysis. Yes, yes, absolutely.
So Dr. Smriti, she was shifted for dialysis. We had not intubated her, and you are now called for sudden hypotension. Dr. Bhavani has already told that hypotension will happen because of fluid shifts. What is in your thoughts now, and what is the advice to your resident? Are you thinking of, okay.
As an obstetrician, a woman who has just had a cesarean section, whatever her complications or medical history may be, my first thoughts would be to rule out hemorrhage.
Yes.
External or internal. So I would definitely want, us to rule out postpartum hemorrhage. Maybe she's having atonic PPH, and do a bedside sonography and clinical examination to rule out any free fluid, because that will guide us if she's having any intraperitoneal bleed. So I think definitely hemorrhage needs to be ruled out.
Okay, thank you. So she was intubated in the dialysis room, nor had to be started. Dialysis was withheld, and it was planned to shift her to ICU, and after stabilization, maybe bedside hemodialysis. So the final question is to Dr. Ellison. How will you inform this doctor's status to her family, and on what critical factors does the prognosis depend?
I think the most important thing is to be very honest with the family and direct in our communication, and inform them that she is critically ill. That certainly, we are actively resuscitating her in terms of her kind of hypotension, needing additional support. Her prognosis, ultimately, I will be honest, I'm not very familiar with dengue shock. That's not something that I encounter here, but, I think in terms of overall trying to kind of prognosticate based on her renal function, certainly in an otherwise young, healthy patient, despite requiring dialysis, hopefully as she gets through her phase of critical illness, that her kidneys will recover. And that once that can be managed, then hopefully from a pulmonary perspective, that we could work towards intubation. But I think the most important thing is just being very, very open and direct with the family to express how critically ill this patient is.
Okay, thank you. Luckily, this patient improved and went home after 1 month of ICU stay. And I wrap up the panel discussion, and thank you all. Thanks a lot for such a beautiful and intelligent discussion. Thank you so much. Thank you.
Thank you so much for giving us food for thought. Management of critical illness in pregnant and postpartum women requires a multidisciplinary approach with contributions from obstetricians and obstetric anesthesiologists. So we have our upcoming session appropriately titled Twinning, Tackling Hemorrhage Together on Placenta Accreta Spectrum, Learning the Art of Managing an Actively Bleeding Mother. And I invite Dr. Vanita Jain to moderate the same.
Thank you, Urvashi. For the last few hours, we have been discussing various conditions like sepsis, preeclampsia, heart disease, jaundice, conditions which had led to maternal critical illness. And now is the time to talk of a condition which is a leading cause of maternal mortality worldwide, and that is hemorrhage. Hemorrhage is notorious to be killing more women than any of the other causes, and is the fastest killer. And of hemorrhage, one of the important causes is placenta accreta. Now, placenta accreta is a condition where the placenta is morbidly adherent to the myometrium, and therefore the clinical implication is that after delivery, it does not separate spontaneously, since there is no plane of cleavage between the placental basal plate and myometrium, and any attempt to remove it usually leads to massive hemorrhage and usually requires hysterectomy as well. And despite a clinical diagnosis of placenta accreta and multidisciplinary planning, it is known that placenta accreta may lead to severe morbidity in the mother. There is massive hemorrhage, and then we have complications due to hemorrhage, like the acute renal failure, the ARDS, the DIC, and then complications of blood transfusion. And actually operating on a patient with placenta accreta is a nightmare for obstetric surgeons. Our aim is to minimize the intraoperative blood loss, and various techniques are being tried. Today we have with us Dr. Turan, who is a professor in obstetrics and gynecology, and he's the director of fetal medicine and obstetric surgery, complicated obstetric surgery at University of Maryland School of Medicine. He has pioneered a technique for decreasing the blood loss during surgery of placenta accreta. And we are very happy to have him with us. He will talk about his technique, which has been published using the linear cutter vessel sealing systems. And we are very happy to have you, Dr. Turan. We would like you to share your experience of placenta accreta surgeries and the reduction in intraoperative blood loss. We also have from the same institute, the anesthetist, Dr. Shobna. First, I would like to invite Dr. Turan, please, to share his views on intraoperative management of placenta accreta syndrome. Dr. Turan, please.
Good morning. Are you able to see my screen?
Yes, Dr. Turan.
Good morning. Thank you, Dr. Jain, for the nice introduction. I'm going to talk today about the management of placenta accreta spectrum. I tried to make it a compact presentation as much as I could to fit in the time frame that we have allocated. I have no conflict of interest. I just want you to remember 4 things from this talk if you don't remember anything else. The classification of placenta accreta spectrum is still not perfect. Abnormal implantation can be diagnosed as early as first trimester. Multidisciplinary discussions enhance the care, and standardized surgical technique improves outcomes. As you know from your medical school years or residency training, there are 3 types of placenta accreta: accreta, increta, and percreta. This is a very old classification. That classification has been, or nomenclature has been challenged many times in the last 20 years. First used as morbid lateral placenta, then abnormal invasive placenta, and now recently we're using placenta accreta spectrum. So MAP, morbid lateral placenta, is been used until beginning of 2010 and is erased from the old literature. Abnormally invasive placenta means that increta and percreta only. If you think you want to use accreta as well, it's placenta accreta spectrum. Even I'm the steering committee member for International Society of Placenta Accreta Spectrum. We changed the name from invasive placenta to placenta accreta spectrum. In 2019, FIGO actually published a new classification system for placenta accreta spectrum. The aim was to actually standardize the approach, because not every accreta is the same accreta, not every percreta is the same percreta. Therefore, they try to make it a unified description. If you compare with the old classification, when they say grade 1 is actually for old classification accreta, grade 2 increta, grade 3 percreta. The most important part is the grade 3, the percreta, because not every percreta is percreta. I'm going to show you later on in my slides. But there are types of percreta. One group is just only reaches to the serosa, not goes beyond the serosa and invade bladder or other organs. The other ones, the grade B is invades the serosa, and C goes to the parametrium. So these 3 disease just only sits on the serosa versus goes to the parametrium has a different consequences. Right now, we propose to use this classification, at least to standardize our technique or our results. I have a case for you. This is a 6 weeks patient who has a history of any one miscarriage. Her last pregnancy delivered at 41 weeks. After delivery, placenta could not be separated by infusion of oxytocin, manually removed, required DNC and the balloon placements for control of bleed. She received 2 units of blood. Placental pathology did not diagnose accreta. The patient wants to know what is her risk of recurrence. If you look at this story, there are important things in this story. One is placenta did not separated routine way, required DNC and control of blood loss, and she had actually blood loss, which is replaced by RBC. So although the pathology did not diagnose accreta, the placental pathology is actually a very poor way to diagnosing accreta. If you want to make a diagnosis of accreta, you need to have a uterus or at least a big chunk of uterine muscle that can show that the actual villi is growing into the myometrium. Therefore, this case is actually an accreta case and the recurrence rate is about 30%. So why it happens, I just want to give you a brief explanation about the trophoblast invasion and the model or proposed story of how the accreta develops. As you know, every spiral artery from a myometrium develops into the placenta and drain the blood to central sinus to allow baby to grow. And this spiral artery is models around 11 to 13 weeks and then 16 to 18 weeks to make them to large bores that can transfer blood as much as it's possible. So all these movements of trophoblast has been arranged by different factors, metalloproteinases, progesterone, growth factors, blood vessel developing factors, all them actually play in role to making the spiral arteries a large great blood vessels. And as you know from your medical school or embryology years that there is a decidua and a Nitabex layer that's actually control the spiral arteries remodeling process. The trophoblast cannot go beyond that point. When the normal pregnancy is like that, if there is no decidua or Nitabex layer, then there is no barrier to trophoblast to continue to grow into the muscles. And when the trophoblast continue to grow into the myometrium, as you know from our pathology specimen, we got a grade 1 or accreta. If that goes into the deep layers of the muscle, that creates a kind of grade 2 or increta. And if goes beyond serosa or beyond, it causes a grade 3 or percreta. There is a nice study in the cell cultures done and measured the speed or invasiveness of the trophoblast, and they found that actually if the decidua is intact to compare the incised decidua, there's a significant difference in the speed of trophoblast. But we know this from our clinical knowledge, right? If you have a C-section, one C-section, and no placenta previa, or the placenta is not at the scar line, your risk is to get a placenta arcata 0.03%. However, if you have a placenta previa, means that the placenta covering the old incision line, now your risk is about 100 times increase. If you have 3 C-section, your risk is 400 times increase. So this is actually a known fact. I want to show you another case. A patient is 38 years old, 9 weeks, and referred for cervical ectopic pregnancy. Obstetric history complicated with 4 previous C-section. In this picture, you see that this is the bladder, this is uterus, cervix, and you have a distorted cavity of pregnancy. So, and you're looking for a transvaginal ultrasound, and this is the best way for this gestational age to demonstrate what it is. This is the cervix, this is the gestational sac, embryo, and as you see that compared to bladder, that is actually at the lower uterine segment and almost in the scar. As you see, the thickness of the myometrium is very thin at this gestational age, and it's almost at the bladder, the placenta. And as you see, the placenta is indenting into the almost to the bladder. Again, this is 9th week. So differential diagnosis, this is either a cervical ectopic, scar ectopic, placenta accreta spectrum, or it could be a miscarriage. But as you know, this is mainly a scar ectopic. This is the cases of from our institution. As you see that all these cases is implanted at the lower uterine segment or previous scar and continue to grow until the term. So if you look at the literature, if the fetal heart rate is present at first trimester, most of them goes to the second or the third trimester. And if goes to, then it's end up with the placenta accreta spectrum, which is about 75%. And if you look at the risk of rupture of uterus is about not small, but it's about 10%. Our patients came back at 13 weeks. We counseled her for hysterectomy at 13 weeks or DNC under laparoscopic assistant. And she said, no, I want to continue this pregnancy. And she came back on 17 weeks. As you see, this is the cervix. This is the placenta growing to again to the bladder. And she said, no, I don't want gravity hysterectomy. I want to continue. This is 20 weeks. The placenta is growing to the whole. There is no muscle left between bladder and the placenta. So how do you manage these things? How do you can actually make it happen? So we developed a multidisciplinary care group at University of Maryland. We're using this algorithms the last 7 years, but how it started, this is one of the best paper from 2011. It came from a Utah group. They actually compared two institutions, one of them multidisciplinary care center, one of them a standard care center run by very experienced obstetrician. And when they look at the risk of morbidities, when these cases perform, these two institutions, and when they compare, if they manage by the multidisciplinary care team, they reduces the risk of 60%, the complications, particularly early complications, using more than 4-unit blood, reoperation, etc. When they check just only cases who were not came urgently, just the scheduled ones, that's actually is about close to the 80%. So what requires for a multidisciplinary team? You need a diagnostic team, who could be MFM, obstetrician, or radiologist, and require ultrasound, MRI, and knowledge of all those skills. You need a surgical team. That this team needs to have a kind of experienced surgeon who has a pelvic surgery experience. The gravid uterus and non-gravid uterus, two different things. I will show you lots of anatomical picture later on. In the normal gynecologic hysterectomy, you just clip the uterine arteries and you're done. But in obstetric hysterectomy, this is different. And you need other services that's possible, particularly obstetric anesthesia. You need an ICU team, you need blood bank, you need other consultative services. How do we do at university? In our, the red bar shows that these are the standing members of the complex obstetric surgery or our multidisciplinary team. And the yellow ones is we ask them sometimes to present during the meetings. And MFM, an obstetric anesthesiologist, COS and L&D coordinator, these are the two important elements of our team, radiologist and general OR coordinator. This one, the COS coordinator, her job is not just only accept the transports to us, as also works in the OR as a case manager. And this is a bridge between surgeon and anesthesiologist, and oversee the case, because if there is a difficult case and patient is bleeding vaginally, while you start your hysterectomy, and anesthesia is doing their own job, I'm doing my own job, but somebody needs to communicate between us, follow up the blood results, and take care of how much patient is bleeding, and then communicating between us. we found very important role for this course coordinator. I really strongly suggest you guys to create a kind of algorithm for yourself. For example, I want to give you an example of our approach to timing of delivery, which developed by our multidisciplinary team meetings. As you know that the ACOG says 34 to 36 weeks, the rule. But there are, why is this rule coming from? Because risk of bleeding from the placenta previa data, if you wait to 37 weeks, your unexpected bleeding is about 30% if this is a previa. However, we know that the cervical length is a good predictor if the patient is going to get inactive labor or contractions or not. So that is, if it is more than 30 millimeter, only 28% gets. Less than 30 millimeters, about 79%. By combining these two data, which we developed an algorithm, if the patient's cervix is more than 30 millimeters and there is no bleeding before, we allow them to go beyond 36 weeks. If there is cervix is less than 20 millimeters and patients had to bleed, even less than 32 weeks, most of the time, when we reach the 32 weeks, we do the surgery at the time of less bleeding to prevent a catastrophic bleeding. Let's go back to our patient. This is our patient again at 27 weeks. As you see here, this is the placenta, bladder, and placenta growing into all these muscle layers. How we manage this? We decided to deliver this patient. She never had, she had one bleeding, is about 35 weeks. What is the surgical management and how we do that? We do all those interventions at university. Because of the time, I'm just going to concentrate to the cesarean hysterectomy. I can discuss with you if there's a question for the other management algorithms. This is an old slide of mine. This is all the possible published papers and comparison of our technique. If you look, this is our results from 25 cases. Done is similar to the literature, and as you see that there are all similar results. But when we use a technique that I am going to discuss with you soon, then we make a huge change in the outcomes. The transfusion of 4 units of blood loss dropped to the 18%. The rate of ICU admission dropped to the 2%, and there is no reoperation. By the way, the no technique group, I performed about almost 2/3 of the cases in this group as well. But the difference is the technique. And this is from our last publication from the same group. As you see that the cumulative blood loss dropped to 1100 cc's from 3500 cc, and transfusion of red blood cells dropped to 68% to 18%. That's a significant difference. And when we look at if this is because of we were making surgeries on less severe cases or not, actually the per crita cases is much higher in the technique group compared to no technique group. And when we look at the statistically look at why this blood loss is dropped, and the only reason came back as surgical technique. So is this technique is a reproducible technique or not? And when we look at our data from the first case to the first 3 years, we found that after the 5th case, we kind of establish a 1500 cc blood loss. Of course, you will have a good cases and bad cases for blood loss wise. That is what it is. But a median number never changed to 1500 cc. So what is our technique? There are 4 elements of the technique. So I'm going to go step by step. Step 1, using a linear cutter to make an hysterectomy. This is a critically important step to me because using this linear cutter, I don't know the price of this linear cutter in India. In the United States, it's a couple, $100 or $200 instrument, and used very judiciously at general surgery. When you use this, you will get an excellent sealing around the hysterectomy, and it's not going to bleed after that. If it doesn't bleed, you actually spare about 400 to 500 cc blood loss during delivery, and if you go for hysterectomy during hysterectomy. So this is an example, and we place the linear cutter, the membranes is posed up, and then as you see, it really doesn't bleed. It's completely make it hemostatic. The second one is a very well-known universal rule. Do not manipulate the placenta, don't touch it. If you touch, it's going to bleed. The third rule is cauterization of vascular anastomosis using handheld vessel sealing system. This is an anatomical picture, as you know. The lots of blood vessels you will see on the cesarean hysterectomy. Most of them comes from not only uterine arteries, but also cervical branches, superior vesical arteries, and superior vaginal branches. All these small blood vessels, these are the bridging blood vessels in the ultrasound language. Those ones is going to bleed when you start dissecting bladder. So how we do that? As an example, how the vascular could be one case, as you see from here. That is a placenta is growing out from the uterus. Bladder is coming from here. As you see, this blood vessel is pulsating. This is a communicating blood vessel between ovarian artery and uterine artery, and bladder comes until there. So how we are going to dissect all this bladder from there? This is a description and depiction of our technique. So I use a sealing system. Before I use this, I don't have any share with this company. I'm not advertising the company. Before I found this instrument, I was using single bipolar and medicine bound. And this is still possible. This only gave me a little bit same result, but a little bit time, sparing some time. So what I do, I open the loose leaflets between bladder and if I can find a first loose place, and then cauterize all the blood vessels one by one. So I'm going to show you a small video clip that how we do this. Again, this is the blood vessels opening and then closing all this blood vessel one by one. Sometimes this takes is about 30-40 minutes, but it's really worth it, because if this part start bleeding, you lose all your control. And this is from our paper again, the opening side of the two sides of the loose leaflets in the between bladder and uterus. There's a dissection, and then closing all blood vessels. The fourth step is completion of bladder dissection until the cervical-vaginal junction before ligation and division of uterine arteries. This is one of the most important steps to me. This is a vaginal cuff after the hysterectomy. This burns black things is actually the burns or sealed blood vessels. As you see, lots of engorged blood vessels is around the cuff. Tell you that there's a huge increased pressure in this blood vessels. Now go back to 10 minutes prior. This is uterus. This is the same place we are looking. They are not that much engorged or under pressure. So if this is the anatomy, and if you ligate uterine arteries from here, what's going to happen? The remaining of the blood pressure in this blood vessel is going to go back and come back to here, and your dissection is going to be much difficult. And I saw some cases is if the blood vessel lumen is so thin, during vaginal cuff closure, some of them is actually pops up by itself. So the fourth step is important step is complete the whole dissection and then grasp the uterine arteries and the remaining. Now I want to give you a brief results from our complex obstetric surgery program. Whenever I do this talk, they always ask me how I initiated this program or how we successfully gathered this program. So I'm going to show you two slides, next two slides from my first presentation in 2014. Again, we did with Dr. Barbash together. What is our proposal at that time? So first we identified the patient population at risk. These are placenta accreta spectrum, placenta previa, the morbidly obese patients, more than BMI 50, fetuses require extraposition abdominal cerclages. Why we choose this group? Because this has a different risk factors for other than regular OB surgeries. And then we decided to create this multidisciplinary team meetings to identify individual risk factors. These could be an obstetric risk, anesthesiology risk, operative risk, and delayed risk factors. And by using this multidisciplinary team approach, we created management plans for elective and urgent conditions. What if patient comes in the middle of the night? Who is going to call? What kind of lights needs to be placed? Who needs to be in the case or not? And we documented those plans in our electronic medical system. When we developed this program, we have 3 aims. One of them is they give the high quality of pre, per, and postoperative care, which I will show you soon. We reached that goal. Participate in regional, national, international research, and we are doing that, and we already published 2 papers. And the third one is on the review right now. And we try to continue to educate our providers. You met with Dr. Shannon previously. She was actually trained by us, and now she is on our faculty. And 3 other fellows, Wisconsin, Louisiana, and California, is texting me after their case when they completed the same technique with the same results that we taught them. And this is our results from 2015 to 2020 fiscal years, means that 2014, 1st of July to 2015, end of June, the fiscal years. And as you see, the patient numbers is significantly increased even with the COVID is hit for 2020. And our hysterectomy numbers is steadily increasing. Last year, fiscal year, we performed 37 cesarean hysterectomies. Not just only the case numbers increased, we also increased the percentage of referrals. At the beginning, half of the cases is only been referred outside. Now is about only 3% of cases belongs to on our courts. The remaining is coming from different institutions because we are successfully handling those cases. And also we improve ourselves in doing this 7 years. We were placing central line every case when we first started. Now, just only 2 large boards. Dr. Borwash is going to give you more information about the anesthesia approach. But right now, we just use 2 large boards, 1 A-line, and done. At the beginning, we were doing everyone in the general anesthesia. Now we don't any. And I don't remember the last 3 years we converted any case from regional to the general anesthesia. We were doing all those cases in the big general ORs. Now we are doing in LND OR. By the way, we changed our LND ORs quality as well, and we adjusted ourselves for this new program. And right now we are all recording all our cases using a camera on the electrical light and try to educate our juniors, residents, and fellows. And this is the kind of a diagram when the patient comes and how many other specialties actually involve the care of one patient. As you see, first patient comes to our imaging center, sonographers and attending our complex obstetric surgery nurse is all takes care of the patient. Then patient transferred to our outpatient clinic, seen by our residents, attendings. And then we goes into the multidisciplinary meeting and discuss all the plan, surgery time, and how to do the surgeries plans. And then the postoperative care again attended many other parts of the hospital individuals. We also perform lots of research on placenta accreta spectrum. We have a basic science lab for that, and we're trying to find small clues other than the imaging to diagnose this problem or overcome this hassle. I would like to thank you all your attention and give the word to Dr. Barwash.
Thank you so much, Dr. Turan, for sharing your experience on this condition with all of us. We have many questions, but just selected 2 of them to ask you that what is your opinion about doing a subtotal hysterectomy if there is difficulty in dissecting down up to the cervix? And second, do you have any experience of conservative management, that is leaving the placenta in situ?
So that's a good questions. The first one, if this is placenta previa and essential placenta previa, and the placenta is at the line of the cervix, and doing a subtotal is not going to change your blood loss, so it's going to be bad. So I really suggest a good mapping of the placenta before you decide to do the surgery, because if this is a little bit, complete anterior placenta, a little bit around the cervix, yes, you could. But if this is a central placenta is covering entire a low return segment, I suggest don't do that, because your bleeding is going to be much more heavier. For the second question, yes, we do. Right now, we have one case is on our conservative management. That's require lots of requirements. You cannot just say, okay, I'm going to leave this placenta in. The number one, patient shouldn't have any bleeding antenatally. Number one rule. Number two, the patient shouldn't have any bleeding during surgery, a vaginal bleeding, even a drop. I don't do that. Number three, the patient should be a believable individual that can come immediately to the hospital. Because I have one case, I wasn't planning to live in situ, but we were doing an interval hysterectomy. At the 8 weeks, we were planning to do the surgery. And then one day prior, she came and told me that she has some spotting. I said, you need to be in the hospital now. And she refused. She was a nurse. She refused and went home. Next day, she was in NICU and bled 4 liters. And we saved her life, but I don't know what could happen if she would be at home. So there are lots of prerequisites to leave the placenta in. Luc is my good friend from France, and he published this conservative management algorithms or study, but you have to be very careful when you pick your patients. If you pick a correct patient, yes, I suggest, but you have to be very experienced about picking your patients.
Thank you so much, Dr. Turan. The 2 pillars of management of placenta accreta in the spectrum, one is the surgeon and the second is the anesthetist. And it is the anesthetist who estimates the blood loss, does the point of care testing for the hemostasis, plans the transfusion protocol, coordinates with the blood bank, is responsible for the hemodynamics of the patient. And so we have with us Dr. Shobna Bhardwaj, who is an obstetric anesthesiologist at the University of Maryland School of Medicine with us. Dr. Shobna, we would like to hear from you how you manage the anesthesia end of the patient who is likely to have massive hemorrhage intraoperatively. Dr. Shobna, please.
Thank you very much, Dr. Vanita Jain, for your kind introduction. I'm going to get started right away. Let me see if I can share my screen. Are you able to see my screen? Okay. All righty. So the main thing, Dr. Turan talked to you all about the surgical part of it. Now coming over to the anesthesiology part of it. I don't have any conflict of interest, except that I am a team member for the COS program. And what I'm going to talk to you all about is teaming up in tackling these cases, a brief pre-op, intra-op, and post-op considerations from the anesthetic standpoint, a couple of words on massive transfusion and how we did on our anesthesia side, before and after Dr. Turan has developed his unique technique. So having this team is very, very important in managing these cases. And time and again, it's been proven that multidisciplinary approach is excellent compared to a standardized approach for these cases. Not only when you're doing the multi-D planning, you're taking care of the clinical part of the patient care, but you also, the team also does some major management of resources, to make it efficient, effective, and economical. And of course, the team also helps with role designation, who is going to get the blood, who is going to be the anesthesia tech support, and how Dr. Turan mentioned about the cost coordinator, who is up on top of the cumulative blood loss. So you pretty much design the, designate the roles, and always have a contingency plan when you are making plans for these cases. As a team, we always have a contingency plan in place, meaning what will happen if the patient comes in bleeding? What will happen if the ORs are all occupied? What will happen if it's not a trained personnel who is operating or providing anesthesia? Where do these cases go? So these are all like contingency plans that we have in place when we do these team meetings. And of course, nothing is complete if you don't do your PDSA, plan, do, study, act format of continuous quality improvement. So having all these in mind, that is the major role and outcome of the team in an excellent patient care. Now, we see these patients antenatally. We encourage these patients to be seen antenatally as far as anesthesiologist is concerned, because you have a very short time. You have to develop your rapport within that time. So during that antenatal consult, we basically look on patients' comorbidities, their airway, and how easy it would be to have a peripheral access. And if they have any comorbidities that need some additional workup, we transfer that information to the MFM team, and they take care of that. Also, as an anesthesiologist, you should be participating in all these multidisciplinary meetings for any updates, okay? Because these patients are seen by the obstetricians more frequently than we do. So any change, like, how Dr. Turan talked about the cervical length as a determinant of delivery, you get first-hand information. And we type and screen these patients for antibodies, because it is likely that these patients have bled in the past and have gotten transfusion, like the case that Dr. Turan had mentioned. So they may have developed antibodies. It's better to know that, and that will help with your blood ordering. And of course, treat anemia if the patient is low on her hemoglobin. And I think in India we are still working on mobilization of donors. I remember this from my own personal experience. When my dad had a GI bleed, we had to mobilize AB negative, and we scanned the entire city of Chennai to get like 13 donors. So I don't know how things are now, but that would give us time to mobilize donors if that is the hospital practice. And also, you have to give them an informed consent. It's not really to scare them, but it is for them to understand what the situation is and what our thinking is and how well we are going to be prepared for them. So it not only gives them the information, also the reassurance, fetal exposure to GA, and, definitely the transfusion risk. Even though if you're setup is that the obstetricians talk to them about the transfusion, but at that point in time, it's the anesthesiologist who transfuses blood. So it's really important that we talk to them as well about the transfusion risk, not just short term, but also the long term, any kind of invasive lines, if you're choosing on a regional, how the conversion to general anesthesia works, and, recall and post-op mechanical ventilation and ICU stay, and also for, any truncal nerve blocks, risk of any truncal nerve blocks, and the benefits of it for post-op analgesia. You get a baseline labs that should at least at the minimum have a CBC, coags, and also fibrinogen. over the years, we have noticed that there's a huge a range of fibrinogen in pregnant patients, anywhere from like starting fibrinogen being like 230 all the way up to 630. Don't forget your pre-medication, and I wouldn't start these cases if I don't have blood in the OR. So that's how we pretty much go by. It's a totally different scenario if they come in an emergency, but we can talk about that. So now deciding between the two anesthetic, the things that you have to keep in mind is, with the neuraxia anesthesia, there's less exposure of the fetus to the GA. The patients are awake, they're conversing, and also you may have to think about converting the GA in the midway, especially on an airway that may be much more swollen than if she has to come just normally pregnant. And then with general anesthesia, you can get hold of the airway much early on. You don't have to struggle under the drapes. It's more controlled. It's comfortable for the patient, because you're having them deep under, especially when the surgeons are in their hands in the peritoneum. So, they can get a little bit of discomfort. It may be easier to do invasive lines, but you have to be keeping in mind the long induction to delivery time. Now, talking about that part, we published an abstract at the SERB a couple of years ago, looking at the outcome, the neonatal outcome of between general anesthesia and regional anesthesia, especially in the setting of long anesthesia start to delivery time. So in this, we looked at about 136 cases, and then we found that at 5 minutes, the AVGAR scores were not much different, and the umbilical cord pH was not much different. And in fact, it was a little better on the GA side. And for all these cases, the mean times from anesthesia start, which either it is a spinal dose in terms of neuraxial or the induction time when we push drugs for intubation. So that time was between around 40 to 45 minutes. So having said that, if you have a very well-conducted multidisciplinary service, you do have favorable neonatal outcomes regardless of the type of anesthesia. Now, so which comes us to the point, so do I do GA or, regional in my patients? But, to be honest, I do not have an answer for that. It totally depends on a lot of other parameters, like, is a patient coming in an emergency? Is a cesarean hysterectomy happening in an emergency, which we try to avoid because Dr. Turan just showed that, urgent deliveries, urgent hysterectomies bleed way more than the controlled ones. So we try our best to avoid these emergency operatingness for these cases, but you just have to bear that in mind. There are certain things out of our control. Patient preference. If the patient is going to say, hey, no, I want to be awake, then you have to respect their wishes. And of course, the degree and certainty of the invasion of the placenta. See, that is when our team planning comes up. So where your obstetrician or the MFM specialist is going to tell you, hey, this is pretty bad. This is a real case. So you just have to know how bad it is. And of course, you yourself should be comfortable with that type of anesthetic. If the anesthesiologist himself or herself is not comfortable with giving, neuraxial anesthesia for these patients, then, that is something that we have to think about. And surgeon experience and skills. There is a huge range of heterogeneity in management of placenta accreta spectrum. We are very blessed and thankful that we have Dr. Turan in our practice, but we do know how these cases went, years ago when he wasn't there. So that is one of the major factors is surgeon experience and skills. And definitely, the patient's airway class, either you can choose to avoid the airway, go on with neuraxial, or you can say that, hey, you know what, I'm just going to get the airway from the get-go so that I'm not dealing with a difficult airway under the drapes. So logistics, your practice setup, and your resource availability are the major determinants of what kind of anesthetic that you're going to offer. And of course, the bottom line is you have to be open for safe alternatives. And I'll show you how our practice changed. And just to quickly go over the types of anesthesia, either you can choose to do neuraxial, straight up neuraxial, or neuraxial conversion to general. It can be general as needed, or it can be like definitely converting to general as soon as the baby comes out, or like I said, general anesthesia from the get-go. So with the neuraxial anesthetic, you prefer to do as continuous spinal anesthesia, or definitely a CSE, and that is our majority of our practices, a combined spinal anesthesia, where you take the advantage of the spinal dose, and also you have the epidural catheter to keep the levels going for, it's a 3-hour surgery or 4 or even 6-hour surgery. You remember, you have to maintain T4 levels because of the peritoneal manipulation. And you have to watch for local anesthetic toxicity. If if the case gets prolonged, you're topping off the catheter, and at the end of the procedure, the block team comes and deposits another 30-50 mLs for a truncal block, then you may be close to a local anesthetic toxicity. So you really have to calculate it. And there may be a lot of local anesthesia involved in these patients because you're having these patients awake for a reason. And like I said, when you want to combine your anesthetic, like I said, you can just convert it as soon as the baby comes out when things are not like really hosing out, or you can just save it for like, oh, I'm going to convert it only if she bleeds. In that situation, you have to see how your hemodynamics are during your rapid sequence intubation, because you already have on board the hypotension from bleeding, you already have on board the hypotension from your spinal dose. And so you really have to make sure what kind of medications that you choose, how you want to keep the hemodynamics stable, during this conversion. And you're putting the patient under 2 different anesthetics. And also, at least in our institution, these cases are done under lithotomy, where your airway is like a little far away from than usual. So you really have to start the case with the patient in a good position for intubation, because you are going to be intubating under the drapes. And as far as general anesthesia is concerned, you have to optimize the intubating condition from the get-go. It's very, very important that you maintain maternal CO2 level, 28 to 32, we do not overshoot on the CO2, entitled CO2 levels. You have to keep it tight because that's how the fetus sheds its CO2 as well. And we typically convert to total intravenous anesthesia after delivery so that we don't have the uterine relaxation from the inhalation agent that's going to cause more bleeding. And in these patients, because of the fluid shifts, there's a possibility of post-op mechanical ventilations. So it's all about being prepared for these cases. You have a dedicated team. So when these patients show up on your labor and delivery, they exactly know what they have to do, or start developing guidelines, start developing protocols, and you don't want to start these cases with a small gauge IV access because the blood loss is going to be high. So at least have a 16 or a 14 gauge and an A line while you're figuring out, central access or not based on your practice setup. Have all your vasoactive drugs ready to go. And remember, these are long, these are not 1-hour C-sections. We are talking about like few hours in the operating room with an open belly and a lot of blood loss, warm blood loss. So you need a forced air body warmer. You need to have like fluid warmers, and any kind of rapid infuser setup is very important. So that is one of the things any labor and delivery unit should have a good, reliable device to rapidly transfuse for these patients. You may choose to use cell saver. The most recent devices have a leukocyte depletion filter, so they are okay to be used. You don't have to fear about amniotic fluid embolism in these cases. However, you may not be able to use that for blood loss through the vagina. There can be a huge blood loss vaginally in these procedures. So you just have to keep that in mind, because using a cell saver is definitely, going to add to your cost. So during the case, remember to redose your antibiotics, if there's any 1500 or more blood loss, and of course the timing of the surgery, pay close attention to urine output. They are working very closely with around the urinary structure. So any decrease in urine output, you don't want to assume that they are hypovolemic or they're not resuscitated, but you have to communicate that with the surgeons who are on the field, and go on with the cumulative blood loss. Don't wait for the end of the case to tell you, or don't wait for the patient's hemodynamic instability to tell you how much they have lost, or the labs to tell you how much they have lost. Just have an eye on the field. And then definitely you have to optimize surgical condition, be it positioning of the patient or giving them an optimal anesthetic. You don't want a patient who is moaning and groaning on the table if you're not able to keep up the T4 levels of anesthetic, especially during peritoneal manipulation. And also under general anesthesia, you don't want the patient to be bucking and throwing up their intestines into their operating field. And preventing coagulopathies. That is one of the most important role of an anesthesiologist. I mean, look at the field that Dr. Dr. Turan displayed. Imagine if this field was like all oozy, then it is a problem. The surgeons cannot operate. So it's very important that you pay attention to that part of the surgical condition as well. Send off periodic labs. There are some hospitals who are lucky, they have TEG and ROTEM, point of care testing. Just remember that the correlation between the regular coax, the PT, PTT, INR doesn't relate very well with the clinical situation too. So what we can do is, Dr. Kodali always does this. We call it the poor man's TEG, but it's a red top tube. You get the patient's blood, put it in a red top tube, stick it up to the wall, put your timers on. If it's not clotting less than 10 minutes, it's not. So just keep that in mind and be prepared to have a transport to the IR and use your POCUS, ultrasound to scan the heart if there are any issues with hemodynamics. And there's also some talk about, arterial REBOA, for occlusion, but aortic occlusion, but I don't want to go deep in that because of the time issues. And I want to quickly touch base on the massive transfusion. So a lot of hospitals have a massive transfusion protocol. We all know that hemostatic resuscitation rather than just standardized resuscitation improves outcomes. Having an MTP, it ensures timely and continuous supply of all the products. It definitely needs a multidisciplinary approach. That process should also have periodic review, and you can in your own practice preset the ratio. In our hospital it's 6 in 1 and then 10 units of cryo if we initiate the protocol, and there should be clear orders for the blood bank as to when you're starting it and when you're stopping it. If you have stopped it in your mind or in the OR, you're not communicating it to the blood bank, then they're going to keep making all these units and keep thawing all this FFP, which is not a great idea. So you have to give the surgeons and the patient the hemostatic resuscitation. Now, when would you do it? There's typically it is recommended that, if you have to replace more than 50% of the blood volume within 2 hours, you have to start thinking about it. Or if the bleeding keeps continuing within 1 or 2 hours with the 4 units of packed cells. And also if you're hypotensive, tachycardic, and you have an uncontrolled bleeding. And when you are on MTP, you're pretty much going by your clinical judgment and not waiting on any labs. Now, there can be downsides, and there are downsides. We talked about the plasma and cryo being thawed, and they have an expiry time once they are thawed, and a risk of transfusion-associated lung injury, transfusion-associated cardiac overload, and transfusion-related infectious diseases, acute kidney injury, immune modulation, and also you had to think about the hyperkalemia and hypocalcemia and the citrate toxicity. You're talking about these huge amounts of saturated blood going. You just have to keep that in mind. What are pharmacologic options? You have TXA, especially after the women's trial, and now you have the fibrinogen. You want to keep it between 150 to 200 as a target. Typically a 10-unit cryo would increase the fibrinogen by 100 milligram per deciliter. And if you want, or if your hospital has it in your formulary, then go for the fibrinogen concentrate, which is 2 grams per, over 100 ml. And the PCC, the prothrombin complex concentrate, has very limited data in obstetrics. Typically, they have used only half the dose that's used for warfare and reversal, which is about 10 or 15 international units. And factor 7A is not, it used to be in the early stages a go-to option, but not these days because they have shown some risk of thrombosis and it cannot be used in the setting of a DIC. Now, out of the OR, you have to see how the patients are doing, close monitoring. Are you going to extubate or keep the patient intubated? Go to the ICU, and based on the coagulation status, you're removing the epidural catheter or not. And post-op pain control is extremely important in these patients so that they can get up and ambulate. And there's, for interval hysterectomy cases, you may want to look at the prolonged invasive monitoring or, discharge him to crib. Now, prior to the technique that Dr. Turan had developed, like he said, we were doing all these cases in Main OR. All patients had central access. We had 6 and 1 in the room, and all patients had general anesthesia, PCA, and they all went to ICU post-op. On average blood loss was 3,500 with 68% transfusion rate. And once Dr. Turan has developed his technique, all these patients get now an antenatal consult. We are doing it in our L&D. In fact, we have them on an enhanced recovery track. We do not do central lines. We do them all under CSC, and our cumulative blood loss is about 1,100 on an average, and our transfusion has come down to a whopping 18% from all the way to 68%. Now, there are always outliers. Those are the cases that make us humble. So we just learn from all those cases. And so in summary, multiple planning is key for these cases. Choose your anesthetic based on all the factors that I had talked about. Open communication is very, very important, and always be prepared, because failing to prepare is preparing to fail. And this is our complex obstetric surgical team of nurses and obstetricians and MFM specialists and fellows. And this is how we tackle our hemorrhage together. And thanks a lot to the YUVA FOGSI team, Dr. Kodali and Dr. Turan.
Thank you so much, Dr. Shobna, for an extensive description of how to maintain the hemodynamics in difficult situations. For lack of time, I think I'll ask only one question, which is that a delegate wants to know that what is the role of early cryo during the massive transfusion protocol?
So as far as any transfusion is concerned, just like how, Dr. Subramaniam had mentioned in his previous discussion panel, you don't want to give it just because you want to give it, but you go by how the fibrinogen falls and also your clinical judgment. Like I said, there's a wide range of fibrinogen that we are noticing in pregnant patients. So probably you may want to look at the percentage of fall rather than your actual numbers.
Thank you so much. Thank you so much, Dr. Shobna, and a special gratitude to your entire team for having shared with us your experience in a condition which is so much, so difficult for the obstetricians to tackle. Thanks a lot.
Thank you very much for having us.
Thank you very much for providing us with pabulum for reflection. Next, I would like to welcome Dr. Kajal Jain to moderate the session on problem-based learning on point-of-care ultrasonography in maternal emergencies, old tool, new uses on labor floor.
Thank you very much, Urvashi. We come to the next part of our today's obstetric critical care workshop. And I have my extreme pleasure to introduce to YUVA FOGSI attendees, Dr. Sunil Pandya. He is currently the president of Association of Obstetric Anesthesiologists India. And he's our great leader. We look at him for so many, academic ventures. And today he's going to tell us one very important, topic, and that is point of care ultrasound in maternal emergencies. And I feel this is particularly important to our obstetric colleagues because they are already using ultrasounds and they have a fair hang on how to, use different probes. Only in maternal emergencies, they need to, develop this skill. And Dr. Pandya is going to highlight how we are going to use this old tool on labor floors for new indications. And it is surely going to replace our stethoscopes in this 21st century. So over to you, Dr. Sunil, and very welcome to this August gathering of YUVA FOGSI.
Thank you, Dr. Kajal.
Dr. Pandya, can you stop sharing and again share your presentation? You share your mail.
I'm sharing my screen, right? Is it visible?
Your mailbox is visible. Can you stop the sharing and again share your PPT?
My screen is visible, right?
Yes, Dr. Pandya, your screen is visible, but your mailbox is visible. You can stop sharing again and again share your PPT.
Is it okay now? Is it okay?
Now it is okay, sir.
Yeah. Good evening, one and all. Again, on behalf of AOA, it's my privilege to be here, and I thank Dr. Kajal for the lovely introduction. And again, I thank YUVA FOGSI North Zone and PGI team for giving me this opportunity. So next 20 minutes, I shall be discussing on the role of POCUS, the point of care ultrasound in maternal critical care, especially for the obstetricians, keeping obstetricians in mind because you are used to doing ultrasound quite freely in pregnant women. So nil conflict of interest. The machines that have been depicted in my presentation are the ones we use by hospital. I have no personal interest in any of those companies. The demo staff volunteers are volunteers, so they are all normal videos and pictures, no pathology, and all the pathology that is shown is from the literature and internet. And we have followed PCPND protocol during this recording. We have this scan machine in our OT complex and ICU complex, and it's a 4-probe machine, which we use these three, and these for the obstetricians. So this foresight, like comprehensive perioperative ultrasound examination, is what we have been doing for the past 7-8 years, where we virtually scan from head to toe using ultrasound. But I shall be discussing the topics which I have been asked by the organizers to deal with, like dealing with raised ICP, lung ultrasound, and intravascular fluid volume assessment. So first of all, dealing with raised ICP, like if you see intracranial pressure pathology, or whenever a parturient is having raised ICP, one of the easiest measurable surrogate marker is optic nerve sheath diameter, and ultrasound is a fantastic tool to measure this optic nerve sheath diameter because it is rapid. You can just assess within 2 to 3 minutes. It can be its bedside because ultrasound basically is you have what ultrasound machine in virtually in OTs, ICU, labor ward, everywhere. It's non-invasive and you can obtain serial measurements, and it's a short learning curve. Just probably a few hours, you can obtain a short learning curve, and you can expect a good finicity in taking the measurements. So what are all the conditions in pregnancy where we encounter elevated intracranial pressure and where ONSD measurement is quite useful? Yes, first and foremost is severe preeclampsia, especially when you have severe preeclampsia with CNS features like altered sensorium or CNS irritability or parturients with press syndromes. Unfortunately, if you have intracranial bleeds, that can be also detected, especially if they manifest with raised ICP. Incidental space occupying lesions like tumors presenting with altered sensorium, and rarely idiopathic intracranial hypertension. So first and foremost, before you go on with the hands-on, it is always better that you explain to the patient so that you obtain oral consent. It doesn't do any harm to the patient, and generally we use a tegaderm to cover the eye so that the jelly doesn't harm the eye. And generally the tegaderm is fixed in such a way that there are, especially in the crevices in the middle side, there are no air gaps. So you need to fix this tegaderm properly. And whenever you're obtaining, generally we use a oblique axial view so that you avoid the path of cornea, iris, and lens. Whenever you are obtaining optic nerve sheath, you should not see this, at least these two structures, because if you are seeing these two structures, you may not get a clarity of the posture part of the eye. So if you see this video, we have covered the patient eye with tegaderm, and importantly use a lot of jelly. It's very, very important that you use a lot of jelly so that the medium is, there are no air medium. And importantly, as I said earlier, you have to use oblique axial view. As you see, he is tilting his hand so that you can cut open and you can directly visualize the posture part. And this is what when you are putting oblique axial view, you see a structure like this in the posterior eyeball. This is nothing but the optic nerve fibers. And this image is much more clearer. This is the optic nerve, and you can see arachnoid layer, and you can see hypoechoic line, which again is nothing but the CSF. So generally what we do is measurement is 3 down and 5 horizontal, 5 millimeters horizontal. So basically you take the marker scale from the optic disc, go vertically 3 millimeters, and from the dura, like you see the dural end, from here to here vertically, they take a horizontal distance of 5 millimeters, and that is what the diameter of optic nerve sheath is. Generally, you see 3 millimeters down and 5 millimeters width, and you see 0.5 to centimeters, 5 millimeter, 550 to 5.2 millimeters, which is normal. So any value more than 5.7 is the cutoff. Like 5.7 and above, you consider it as a raised intracranial pressure, and it corresponds to more than 20 millimeters of mercury. So it's a very, very simple test. But one of the things, as I said earlier, do not take the cornea, lens, iris, and the lens in the picture, and you can obtain this. Other important thing is whenever you are seeing it, you can also do Doppler study. Basically, again, obstetricians are very well versed with uterine Dopplers, umbilical artery Dopplers, middle cerebral flow artery Dopplers. So it will be easy for you to calculate. But if you can see end diastolic flow is absent, then it indicates again you can obtain retinal. You can put the probe on the retinal artery, and you can measure the Doppler study. And if you see absent end diastolic flow, then again it indicates a surrogate marker of raised intracranial pressure. And you can corroborate this with, again, transcranial Doppler also. So generally, whenever you have a pathology like this press syndrome, this is a case of severe press syndrome, or patients with intracranial bleed, you can see differential pupillary size, anisocoria is there. So whenever you have this pathology, ONSD is a very, very important tool, simple tool, simple way of measuring optic nerve sheath diameter, and you can obtain the intracranial pathology. There have been lots of studies where they have used ONSD as a marker, and they have studied before giving magnesium sulfate and after giving magnesium sulfate 24 hours later, and there have been perceptible difference in the size of ONSD before and after magnesium sulfate therapy also. Other important things that you can also see with ocular ultrasound is retinal detachment. And in trauma cases, you can see subluxation of lens and other things also. But importantly, retinal detachment is another thing which can be easily seen. So whenever you have a student presenting with blindness, sometimes you have this occipital blindness, central blindness, or sometimes you have this RD. So just by placing a linear probe on the eyeball, you can obtain, you can see this picture of retinal detachment. One of the most important thing that you need to remember when you're doing ocular ultrasound is do not exert pressure on the eyeball. It's very, very important. And especially because you are doing this, measuring this in an awake patient, um, see that you don't press the eyeball, and you should not support the hand on the patient face. Very, very important. So you have to be quick and come out of this after taking the measurements. The second thing which is important from a critical care viewpoint is the lung ultrasound. And when I say lung ultrasound, yes, it's one of the things which is favorite and dear to us, because we are dealing with gas exchange and respiratory failure. And the common conditions where a participant has respiratory failure in pregnancy, acute pulmonary edema because of hypertensive crisis, because of fluid overload in severe preeclampsia, or it could be cardiogenic pulmonary edema, or sometimes you see pulmonary edema with oxytocics and tocolytics, or sometimes COVID pneumonia presently in the present season. Yes, we got a lot of patients with, I don't say a lot, but significant number of patients with COVID consolidation and ARDS. And many a times we have seen tuberculosis effusions and massive pleural effusions because of nephrotic syndrome, and very rarely pneumothorax following either intervention, which is very, very rare, or mostly it is because of secondary to trauma. So whenever you are doing lung ultrasound, you can use all three probes. You can use a linear probe, you can use a curvilinear probe, or you can use a sector probe, which is used by phase array probe, which is used by cardiologists for the 2D echo. And the parts of lung that you need to visualize is the anterior part, the lateral part, and the posterior part. And generally, we start from anterior axillary, mid-axillary, mid-clavicular line, and then parasternal border, mid-clavicular line, mid-axillary line, and posterior axillary line. So generally, you see the lungs in either side, both bilaterally in this parameter. Then believe me, it will not take more than 30 to 45 seconds in each zone. So virtually, you can complete the entire lung assessment in less than 3 to 5 minutes, less than 3 to 5 minutes. And as I said, you can use curvilinear probe, you can use phase array probe, or especially if you're seeing for effusions and this thing, you can use curvilinear probe. And the signs that you look for when you're doing lung ultrasound, there are a lot of signs that have been mentioned. One is the bat sign, the lung sliding sign, the A lines, the B lines, the C lines, the seashore sign, the stratosphere sign, the rocket sign, lung point and sinusoidal sign. I'll be discussing about these things, but more importantly, you have to remember that the bat sign is nothing but a normal lung. So whenever you're putting a linear probe, these are the two rib shadows that you see, and you can see the pleura, the parietal pleura sliding easily. So basically, you should see this sign. That means the pleura is intact, pleura is sliding, and basically lung ultrasound is nothing but the reverberation artifact of the air as well as the tissue. And this lung sliding sign, if you corroborate, and this is the artistic presentation by Lichtenstein, who is the authority on lung ultrasound, is also known as father of lung ultrasound. And he described this pattern of hypoechoic region because of the rib, and the hyperechoic because of the pleura, resembling something like bat. And this is a bat sign that you can visualize in a normal patient. Now, whenever you are doing a lung ultrasound, you see, as I said, the air in the lungs and the alveoli, they are very, very poor absorbent, and you see artifacts. And the parallel lines. Basically, the parallel lines are the A lines. A lines are nothing but air lines. As I said earlier in my presentation, A lines are normal lines because of air. Whenever you see B lines, it is basically bad lungs, and C lines also are bad lungs because they represent consolidation. That's the thing. So basically, whenever you see A lines, these are normal lungs. And if you are putting a M mode, whenever once you have put in the plural line and you see A lines, you put the M mode, and you can see a classical seashore sign where the pleura is basically seen as the sea touching the shore, and there is a sandy beach appearance. This is a depiction. This is from the article. So basically the sea and the sand and the pleura. So basically in a normal lung, you should see lung sliding sign, you should see A lines, and what you see is a seashore sign on an M mode ultrasound. So I'll just go with a case that we had a couple of years back. I've mentioned this year so that you don't confuse with COVID. A 29-year-old primary care at 23 weeks gestational age presents to triage with cough and breathlessness. She is a known case of CKD on irregular follow-up, and as we typically see in our country, changing hospitals. She already visited 3 hospitals before she came to us. And in the triage, the nurse has taken the vitals, afebrile, mild tachycardia, but blood pressure is quite high, tachypneic, and desaturating. So what do you expect in this patient? So basically, it's a case of chronic hypertension, probably with superimposed severe preeclampsia is what we say. And whenever we have chronic hypertension with superimposed preeclampsia, basically you are nothing but a parturiente with reduced diastolic compliance and acute pulmonary edema. So whenever you have acute pulmonary edema, you see typical, these are the vertical B lines. You can see this rocket-like signs, which are nothing but B lines. So generally, when you see more than 3 B lines per segment, it is considered as significant. So B lines are basically nothing but acute pulmonary edema. And if you look at the X-ray, you can see bilateral hilar congestion. And this is what can be depicted. So virtually, once you gain mastery in obtaining this picture by doing bedside ultrasound, you can virtually rule out doing X-rays, because even the X-ray has minimal exposure, radiation exposure, or minimal risk, but still you can obtain the same picture on an ultrasound. Why expose the patient unnecessarily for radiation? This is another case. 34-year-old G3P1L1 A0 18 weeks gestational age presents to triage area with a history of fever, cough and breathlessness, shortness of breath, acute onset, last few hours. Clinically, she's febrile, tachycardic, and blood pressure is okay, mildly hypotensive, but again tachypneic and room air sats are 80%. So if you look at this picture, quite tachypnea is quite severe. And when we obtained the ultrasound, X-ray, it was like bilateral severe ARDS, and you can classically see shred sign or consolidation sign. This ultrasound picture doesn't belong to this patient, but otherwise generally you see this typically patchy opacities with air bronchograms, and shred sign is what you see in consolidation, which is also considered to be a bad sign. This is another case, 30-year-old primary graduate at 22 weeks gestational age, has a motor vehicle accident, was hit by a car while she was riding a two-wheeler. ABCDE is fairly okay, airway, breathing, circulation, and deformity, and this GCS is fairly 15, normal, no cervical spine injuries, but she has multiple chest confusions. Chest wall crepitus also is there. And she complains of breathlessness. Normal temperature, tachycardic, mildly hypotensive, tachypneic, and desaturating. So what do you expect in this case? Yes, basically you do an ultrasound. Again, this is a picture that has been obtained from the article. But if you see the one part of the picture, one half of the picture is having his lung is moving. You can see pleural line, but the other half is not moving. That means there is no sandy beach appearance. Basically, if you see, this is like a stratosphere sign. Stratosphere sign is nothing but it indicates pneumothorax or lung point. Lung point is nothing but the point where the lung sliding sign, the lungs keep sliding, the pleura keeps sliding, and at the side of pneumothorax, the pleura doesn't slide, and that point is known as a lung point. And if you put a M mode at that point, you see typically one half of the lung you can see sandy beach appearance, the other half of the lung you see uh, uh, stratosphere appearance. So pneumothorax is one of the conditions which can be easily diagnosed by ultrasound. Yes, it requires little learning curve, but it's easily diagnosable pathology. Other thing which I said earlier is fourth part, the basal part, posterior axillary line, where generally we use curvilinear probe to obtain better clarity here. And generally we start from subcostal area. So when you're screening at a posterior axillary line, subcostal area, a lot of jelly again has to be used. Typically you see kidney, you see Morrison's pouch, there is no free fluid, this is the liver. And this shiny hyperechoic structure is nothing but the diaphragm. And if you see, it is very important that you see, this is the diaphragm, this is the liver, and the mirror artifact, the posterior part of the lung, the basal lung is looks like liver, and there's nothing but the mirror artifact. So suppose if at all there is any pleural effusion in a supine position, it accumulates here, and if you put a M mode at this point, you can see a typical sinusoidal pattern, which again I had described earlier. So basically pleural effusion, you can see posterior basal segment, and generally lung ultrasound, generally we see in ICU patients in supine position or propped up position, and sometimes the patient is cooperative, you can see in sitting position also, especially the patient declining forward with the cardiac on a cardiac table, and you can screen the posterior zones also. It's very important. There are lots of papers where they have seen lung ultrasound, where they have used lung ultrasound for various pathologies. So the patient presents with this pathology where you have florid pulmonary edema, and patient needed crash intubation because of severe desaturation. What picture do you expect? So whenever you have pathology like this, generally we expect multiple rocket signs, like several B lines, more than 5 or 6 per segment. And this is what is acute pulmonary edema because of either fluid overload, or it could be because of cardiogenic pulmonary edema. We don't know, we need to evaluate. So the problem, the one thing which is very important is whenever you are doing ultrasound examination, be a good clinician also. It is very important on your part to take a proper history, have a mental picture in your mind that, okay, this is the history and this is the pathology, this is a clinical condition, and I may expect this on the ultrasound. Otherwise, you may be blind. So the next thing is volume assessment. So whenever you have volume assessment, ultrasound is an excellent tool for intravascular fluid volume assessment. And generally we do volume assessment in shock in pregnancy, as this has been discussed excellently in the morning skill afternoon skill station, where you had discussed septic shock, and the earlier lecture hemorrhagic shock by Dr. Shobna and Dr. Turan, where they have evaluated and they have emphasized the various parameters of resuscitation. But more importantly, other thing that you have to remember is anaphylaxis shock, hypovolemic or hemorrhagic shock, cardiogenic shock, septic shock, obstructive shock, or neurogenic shock. So whenever you a patient presents to ER in a state of shock, invariably, if you don't have an attendant who is educated, you may not be able to elicit proper history. And if you have an ultrasound, you can differentiate between all these different kinds of shock. So whenever you have to assess volume assessment, again, you can use a phase array probe, which is a cardiac probe, or you can use a curvilinear probe. First and foremost is put the probe in the xiphoid process and go just 1 to 2 centimeters paramedian. And once you put the probe in the xiphoid process, you see both the aorta as well as the IVC. If you turn the probe horizontally, you can see the IVC going into the draining into the right atrium. This picture, obtaining this picture is very, very important. Otherwise, you may confuse with aortic pulsations also sometimes. So it is very important that you need to keep a proper probe, and you need to have trace the IVC into the right atrium. Other thing that is specific to pregnancy, you have to remember that all parturients after 22 weeks, 22 weeks of gestation, they are prone for aortic cable compression, supine hypotension syndrome. So whenever you have this, again, you may not get the collapsibility index of IVC properly. So keep this patient complete left lateral, or at least see that they are semi lateral. There is a weight under the right hip, or they are turned on the left side whenever you are taking these measurements. Very, very important point. So as you can see, we just move the probe towards the right paramedian area, and then you need to trace the IVC to the draining into the right atrium. And once you obtain the IVC draining into the right atrium, it is very important that you ask the patient to take a deep breath. When the patient takes a deep breath, you can see the IVC walls collapsing. That means the patient is fluid responsive. Suppose if the IVC is distended, IVC is distended more than 2.5 centimeters and doesn't move with respiratory variations, then that means is the IVC plethora is there, and these patients most likely to have a cardiogenic shock or an obstructive shock. Very, very important. So once you obtain a good IVC picture, you freeze the frame, and then you can obtain the diameter of the IVC. You can see in this case probably it's around 1.4 or 1.5 centimeters. Whether how to assess fluid responsiveness. So one of the thing, yes, by just simply collapsing IVC with rest inspiration, you can obtain collapsibility index and you can obtain the IVC measurement. But more scientific in critically ill parturient is passive leg raising test. So you ask your assistant or your technician who is helping you to raise the legs by 45 degrees, and after 2 minutes again obtain a ultrasound, and then you can see a difference in diameter. Like collapsibility index is 1.7 here. If you see during deep inspiration, and earlier it was this during at the end of you have to obtain at the end of expiration, diameter at the end of expiration, at the end of inspiration, and then you can obtain the IVC collapsibility index, which is nothing but a diameter of IVC at, during expiration, diameter minus diameter of IVC during inspiration divided by diameter of IVC at expiration divided by 100. So in this patient turned out to be 19%, is a normal or technician. So the thing which I want to mention is in inferior vena cava collapsibility index can be obtained in a normal parturient in left lateral position. And if you are if you want to make it more scientific, you can always do a passive left leg raising test. Again, there's little technical difficulty in this parturient, because if you want to do a leg raising test, you need to keep the patient supine, then only you can raise the leg. So antenatally, there are not many studies in pregnant women. Our own data also is not very encouraging, but most of these patients who are postpartum patient in shock, you can use this test left, right, and center. Antepartum, you can just use without PLR, but postpartum you can use with PLR, passive leg raising test. So to summarize, POCUS or point of care ultrasound in maternal critical care is of great help. It's a fantastic tool with a relatively short learning curve, especially for the obstetricians, because you are well versed with Doppler, you are well versed with pulse wave, you are well versed with the anatomy of the fetus. When you are doing fetal ultrasound, you are doing you're vigilant in the cardiac chamber, you are calculating the cardiac output, you are and in fact you are diagnosing the congenital heart disease also. So you have a greater insight into the using the ultrasound and the physics of ultrasound and Doppler principles. But yes, once you overcome the learning curve, you can minimize the inter-observer bias and you can master this technique. It is more evidence-based and it is more accurate than conventional hemodynamic monitoring. Like I was very impressed in the morning when Dr. Kajal was moderating the septic session, where the clinical parameters of CVP and arterial blood pressure tracers were correlated with advanced hemodynamic monitoring like flow track. EV1000 was used, and she could assess the cardiac output, she could assess the stroke volume variation, she could assess the systemic vascular resistance, which will help and guide the clinician to give fluid or inotropes or vasopressors. But I must tell you that ultrasound and echo are better monitoring tools compared to flow track. This is my personal experience, because flow track EV1000 requires a patient who is breathing spontaneously, whereas if you see in ICU patients who are on ventilatory support, they may give erroneous results. And importantly, this is a fantastic tool, especially once you are up on the learning curve. One of the limitation factor is availability, and of course errors if you are not high on the learning curve. So as Kajal pointed out rightly at the beginning of session, ultrasound is going to replace stethoscope, but at the end of the day, you still have to be a good doctor, a good clinician. So do not forget to take a good history, clinical history, obtain a mental picture, okay, what you're going to visualize when you're putting the probe, what type of probe to be used, what are the parameters or the settings of the ultrasound. It has to be changed. Like most of the software now in ultrasound automatically changes when you put the probe, but many times older models you may have to put, like for example, when you're doing ONSD, you have to put thyroid as a screening tool because you're dealing with a superficial structure. And when you're putting a volume assessment, probably you may have to put abdominal or a cardiac ultrasound, a cardiac tool for taking the metrics and parameters. Thank you very much. Any questions I can take?
Thank you very much, Dr. Sunil. And this was, again, a very relevant talk for our obstetric colleagues. And if you recall, at the beginning of the session, somebody had posed this question that what is the use of ultrasound in preeclampsia? And well, you have highlighted it very well that those women who come with high blood pressures and they are complaining of difficulty in breathing, you can put your linear probe and have a look bilaterally for the B lines. So I'm sure this is one very good tip which you have given. And since all of them are dealing with preeclampsia day in and day out, one thing which they are going to use right away. And I don't think it requires a big learning curve.
Absolutely.
So, yeah, thank you very much for this enlightening talk. And now I will hand over the session to Dr. Urvashi to give us the concluding, concluding session of the day. Thank you very much for being with us.
Thank you very much.
Thank you so much for this stimulating session. Up next, we have e-skill station on maternal cardiac arrest, and I request Dr. Sunanda Gupta, Professor, Anesthesiology, Gitanjali Medical University, Udaipur, to moderate this session.
Good evening, all the delegates and our esteemed faculty at YUVA FOGSI. Thank you very much for inviting me, Dr. Vinita and Dr. Kajal. All the talks and e-skill stations have been very interesting with lucid, informative talks, panel discussions which were very animated, and the chat boxes were filling up fast with comments. So this shows how much interest these topics have generated. Now we come to the last e-skill station program, and as you all know, initially the reason for maternal collapse may not be obvious. Therefore, a generic approach to resuscitation may be helpful, and these steps can be augmented with specific treatments along the way as the diagnosis becomes more apparent, and that is provided that the parturient is lucky enough to reach hospitals in spite of the despairing picture that Dr. Anjan had painted there. But of course, it is very true. And so it is important that we have well-defined and rehearsed emergency pathways in each and every obstetric unit. And so we have a hybrid session wherein we have 3 speakers, Dr. Anju, Nidhi, and Ashima. And Dr. Anju is the first speaker, and she is a very prominent feature on the national circuit in anesthesia and comes from Ludhiana. She's a professor there. And she's going to tell us about the latest changes that have been incorporated into the 2020 guidelines. And over to you, Anju, as the first speaker.
Good evening, dear friends. It gives me immense pleasure to talk to you about maternal cardiac arrest, the e-skill station. On behalf of the Association of Obstetric Anesthesiologists, myself, Dr. Anju Grewal, and Dr. Nidhi Bhatia will take you through the skills needed for managing maternal cardiac arrest. But before we start that, we need to understand why are we discussing and trying to learn CPR as obstetricians. We all are aware that 2 lives are at stake. And despite parturients being young and healthy, the survival rates following cardiac arrest have been reported to be as low as 17.8 deaths per 100,000 cardiac arrest in US. And recent data shows 58% survival to discharge in these particular cardiac arrest, telling us very clearly that the data in our country would be pretty dismal. And what has been observed among various studies is that there are immense knowledge deficits in at least 40% of obstetric care providers, resulting in poor resuscitation skills. Hence, it becomes imperative for us to understand that we need not panic on all of our calls to say, pray that it doesn't happen on my call, but indeed to learn how to tackle it. And to tackle it, we will go through a video. So we have a series, we have recorded a series of videos, which will be interspersed with some instructions on how to carry on this e-skill station and also how to carry on this CPR efficiently.
This is the scene of the labor room and the time is past midnight. A 32-year-old female without any comorbidities at 38 weeks of her third pregnancy is in active labor.
Patient is having effective uterine contractions and her CTG is also reactive. Kamala, don't shout. You will be delivering normally within 2 hours. Don't shout. Kamala, what is wrong with you? Keep your hands down. Kamala, why are you making weird noises? Kamala, what happened? Kamala, are you fine? The patient is having tachycardia. Her saturation is falling down. I'm giving her oxygen. Kamala, don't panic. I'm giving you oxygen. You will be all right. Patient is throwing seizures. I need help. I'm calling my SR, Dr. Shivani. What happened, Samyukta? The patient is throwing seizures. Her vitals are unstable. I'm positioning the patient laterally. You call sister. Sister, help needed. Sister, help needed. Secure IV line, Samyukta. IV line is secured. What was her vitals? One patient was having desaturation and she was having tachycardia and then she threw seizures. Sister, give me mouth care. Ma'am, should I give Midas or MGSA4? Is she hypertensive? No. Then load Midas. Sister ji, please give Midas. Midas given to the patient. Repeat her vitals. Patient's vitals are falling down. Patient is hypotensive. Call the maternal code blue team. Maternal code blue team activated. Maternal code blue team activated.
This is the
So what you saw in this clip is what usually happens in our labor floors. There was this patient who was laboring and has suddenly deteriorated clinically. And hence, to combat that, we need to understand that we need to look at our patients more acutely and prevent a clinical deterioration happening. Thereby, maybe we are in a position to prevent a cardiac arrest happening on these labor floors. And to look at this whole scenario, we shall be taking the help of the American Heart Association guidelines and also the guidelines from the Society of Obstetric Anesthesiologists and Perinatologists. Now, if you look at this chain of survival, which has been amply given in 2020 by the AHA, the first link in the chain of survival talks about early recognition and prevention of cardiac arrest, which means thereby that we have mechanisms in our hospital and our systems where we can pick up very early on any signs of clinical deterioration and prevent a cardiac arrest from occurring in these mothers. However, if cardiac arrest does occur, then we need to immediately recognize the cardiac arrest, that there has been a cardiac arrest in our labor floors, and activate the emergency response system. We'll look at how different is this emergency response system from non-pregnant patients. Initiate high quality CPR till the code blue team or the maternal code blue team arrives on scene, and the location staff will also incorporate with high quality CPR steps of early defibrillation with the help of either a defibrillator or an automated external defibrillator device. And then with the help of the maternal code blue team, go on to provide high quality ACLS interventions, post cardiac arrest care if ROSC occurs, and also provide rehabilitation and help in the recovery process of this mother. Now, if we look at the first link in the chain of survival, and that is what we want all of our obstetricians to focus into their labor floors, is to incorporate within their vital monitoring chart this kind of a chart, which is basically a modified early warning score sheet, which is adapted to the obstetric scenario. And in this, we do nothing great, but except that we monitor the vitals, and we have given different scores and color-coded up different
parameters of the hemodynamics, the respiratory parameters, the heart rate, the various parameters that we normally do monitor on our labor floors. Now, this will help us to identify a point in time of managing these patients where we can pick up the sick parturient as early as possible, trigger a rapid response team, which is a team that is called in before the maternal code blue team comes in, or maybe is synonymous to the maternal code blue team, and comes in and tries to identify the cause of deterioration of this clinical deterioration in this parturients, thereby preventing the cardiac arrest and happening. Just to name a few interventions that can help all of us to prevent cardiac arrest in our patients is to have all your laboring mothers, especially the full-term laboring mothers who are beyond 20 weeks in left lateral position at all times, to administer 100% oxygen if they do get into respiratory distress or they show signs of desaturation. Have an intravenous access, and when I say an intravenous access, it should be a wide-bore intravenous access at all times, and hence the pink gelcos needs to go away, and the green and the gray gelcos, as the 18 and the 16 gauge gelcos, needs to come in. And they should always be established above the level of the diaphragm. We need to treat hypotension and identify the cause of hypotension and treat it accordingly. Of course, fluid boluses will help in these mothers, and always be on a lookout for reversible causes that are causing the clinical deterioration or causing the mother to become sick and thereby prevent an arrest from happening in them. However, as I said, despite your best efforts, there would be times that your mothers can get into cardiac arrest. And that is the point in time where we need to understand that why is this CPR in this pregnant parturient different from a non-pregnant counterpart. Now, we all understand that beyond 20 weeks, there is an immense amount of aortocaval compression, which decreases the cardiac output by 30 to 50%. And this would be hampered very significantly in the event of a cardiac arrest. In addition to that, we are all aware that there is an increased oxygen demand by the mother and the fetus, and there is an element of physiological anemia further compounding the whole issue. In addition, there is a decrease in the functional residual capacity, which leads to poor oxygen reserves. And we all need to be aware that there is a difficult airway underlying with an increased risk of aspiration lurking behind. All of these have a propensity to make CPR ineffective. And hence, priorities of CPR in these pregnant parturient is not only high quality CPR, but to make it really efficient and high quality, we need to relieve the aortocaval compression, and hence we will ensure some measures to relieve this at all times during CPR. We need to ensure that an early definitive airway is in place so that the oxygen requirements of the mother are met. And also we need to evacuate the uterus so that this aortocaval compression is actually relieved very well, and the neonate is also available to us for resuscitation. So to do this on our labor floors where no help has as of now arrived, what do we need to do? We need to remember that in a non-pregnant parturient, while we were doing CPR, there were something called a triangle of resuscitation where 3 providers were mandatory. One was the provider who provided chest compressions. The second provider got the defibrillator and used the defibrillator in case of need. The third was a provider who supported the airway and the breathing. However, in this case, we were in a pregnant parturient. A CPR would require at least 4 of such first responders. When I say first responders, I mean responders on the location. So what does the first member of this 4-member team do? The first member would check responsiveness, will shout for help, and then would at the same time simultaneously start to check pulse and breathing for a minimum of 5 and not a maximum of 10 seconds, and will initiate high quality chest compressions. The second member who has actually responded to the help would activate the maternal code blue team. Now, this maternal code blue team essentially encompasses of the basic code blue team that is going to respond to all cardiac arrest across the hospital. And in addition to that, would include a team of obstetricians, neonatologists, and anesthesiologists who would help in perimortem cesarean delivery. And this is also the time where this member would note the time of cardiac arrest, because this would help us to respond and initiate PMCD timely. Also, after they have activated the code blue, maternal code blue, and noted the time, this member would get in the defibrillator or an automated external defibrillator device, and get it and attach it to the patient and deliver the shock if needed. Now we have two members, one doing a role of a compressor, the one in the red, and the one in the blue is the one who would be doing the role of a defibrillator on the monitor. The third member now needs to come in as fast as possible and perform a continuous manual left uterine displacement so that the aortocaval compression is relieved at all times while a high quality CPR is going on. And the fourth member would now come on to the airway and breathing side, will take up the bag and mask device from the crash cart, attach oxygen to it, and we should be delivering 100% oxygen during cardiac arrest, and would be ready to deliver 2 breaths after 30 chest compression. If this fourth member happens to be an experienced or an expert airway provider, then this member can proceed to put in a definitive airway. Of course, a more easier definitive airway in this particular scenario on the labor floor by an obstetrician would be a second generation laryngeal mask airway. Now we'll just have a look at how this team proceeded in case of a further deterioration in the status of their mother.
What was the TB finding, Samyukta? Patient was 6 cm dilated 10 minutes back, ma'am.
Maternal cord blue team has arrived. What is the matter?
And she is third drive, the uncomplicated term pregnancy. Suddenly throwing the scissors.
Okay, let us all wear our gloves and masks. What is her name?
Kamla.
Kamla, open your eyes. Kamla, aankhein kholo, jawab do. She's unresponsive. Pooja,
yes,
can you note the time, yes, and get the crash cart and defibrillator, attach and let me know.
Okay, ma'am.
Now, what you see here in this scenario is that the code blue team has indeed arrived, and indeed the location providers haven't done anything except for activating the maternal code blue team. And they were lucky enough to have the maternal code blue team arriving in time. In real life scenarios, these teams would be arriving with a lag period of at least 2 to 4 minutes. And that is the time period where the location nurses or the staff or the obstetricians need to initiate high quality CPR. So this is what you see now is that the team has arrived and the team leader is now allocating rules as per.
Get the crash cart and defibrillator, attach and let me know.
Okay, ma'am.
Are you noting my message?
Yes, ma'am.
Ananya?
Yes, ma'am.
Can you check the pulse and breathing? And if it is absent for 5 to 10 seconds, start with chest compressions.
1002.
Jeevan?
Yes, ma'am.
Please put the patient, take the uterus, manually lift it and displace it to the left side.
Yes, ma'am.
There is no pulse, there is no breathing. I'm starting chest compressions. Start chest compressions.
Displacing the uterus to the left side.
Okay, Michelle,
yes,
can you get the bag and mask?
Yes, ma'am.
Attach oxygen and be ready to deliver breaths.
Yes, ma'am.
Is the monitor attached?
Attached.
Okay, we'll just pause chest compressions, Ananya.
Yes, ma'am.
The monitor shows, can you move? Monitor shows an organized rhythm. So it's a PEA, continue chest compressions. We will do high quality chest compressions, push hard, push fast, ensuring complete chest recoil and minimizing interruptions in chest compressions. So Michelle, during the 30 compressions, you will give 2 breaths over, 1 breath over 1 second.
1 second cycle.
Keep counting the cycles.
10, 11.
You'll also start recording. Yes, Pooja. And you'll also tell me when the 2-minute time is up. So we will call the PNCD and the maternal PNCD team and the gynecologist.
Okay, ma'am.
3, 4, 5, 6, 7, 8, 9, 10. To
11,
have Tanuja in the team. Tanuja, can you go to the IV, check the IV is working and prepare 1 milligram of epinephrine. Can you repeat my message?
I just check the IV and prepare the 1 inch.
1004. Cycle 4. 4, 5, 6, 7, 8, 9, 10. Good chest compressions. 14, 15,
Giving 1 inch epinephrine.
19, 20, 22, 23, 24. Please give 1 milligram of epinephrine and follow it with 20 ml of normal saline.
1 inch epinephrine given.
Yeah.
Flushed with 20 ml saline.
1, 2, 3, 4. 1/5 cycle. Okay, so it is going to be 2 minutes. Ananya and 15. Tanuja, you're going to change compressor role. And Tanuja, you'll check the pulse before you start chest compressions. Okay. 28, 29, 30. Chest. 1001. Check the pulse. 1003, 1004.
2 minutes over.
Okay. Can you call the PNCD?
A very good evening to all of you.
So what we just saw was a team of rescuers performing good and high quality cardiopulmonary resuscitation. The roles of each and every member of the team was clearly defined, resulting in very good team dynamics. So having said that, what are the fundamentals of basic life support and advanced cardiac life support interventions, and how are these different in a pregnant patient? Now, as soon as a parturient collapses, it is very important that first you ensure safety. In a hospital setup, you don yourself with your gloves, mask, and gown. Then immediately check for the responsiveness of the victim. Now, if the patient is not responding, immediately one of the team members should activate the code blue team, get a crash cart and a defibrillator or an AED. Simultaneously, the other member should assess for breathing and check for the presence of carotid pulse, and this should be done for not less than 5 seconds and not more than 10 seconds. So for 5 to 10 seconds, you have to assess the carotid pulse and the breathing simultaneously. If both the pulse and the breathing are absent, then in this case, high quality chest compressions should be immediately started. Now, it is very important to keep in mind that during all this time, one person has to at all times manually displace the uterus towards the left side. Once 30 chest compressions are given, then the person who is at the airway will open the airway and deliver 2 breaths. Each breath is to be delivered over a period of 1 second. And always remember to attach oxygen and give 100% oxygen whenever this is available. So this 30 compressions to 2 breaths constitutes 1 cycle. After 5 cycles or 2 minutes of CPR, again, the pulse is checked. And if it's again absent, then the same chest compressions or 30 chest compressions and 2 breaths, you continue doing this. At the same time, it is important that as soon as the defibrillator arrives, the shock is delivered to the victim if the patient has a shockable rhythm. The idea is to defibrillate as soon as possible in cases of a shockable rhythm, and the maternal code blue team should aim for a uterine incision at less than 5 minutes from cardiac arrest. Now, during CPR, the most important thing is providing high quality chest compressions. What do we mean by high quality chest compressions? This includes pushing hard, that is compressing at the depth of 5 to 6 centimeters, pushing fast at the rate of 100 to 120 per minute, allowing complete time for chest recoil, and minimizing interruptions in chest compressions. Whenever the chest compressions have to be interrupted, these interruptions should be of less than 10 seconds. Then in a pregnant patient, there is no change in hand location, and the hands have to be placed in the lower half of the sternum to give compressions. Always monitor your CPR quality with feedback devices and end-tidal CO2 if this is available. So if your ET-CO2 is available and if you have put in an advanced airway, this can act as a good guide to tell you whether your CPR is or your chest compressions are of good quality or no. So at all times during chest compressions, if your end-tidal CO2 is more than 10 mm of mercury, it indicates that your compressions are of good quality. At all times, it is very important that you ensure excellent team dynamics, minimize interruptions in chest compressions, and always ensure high chest compression fraction of at least 80%. And always remember to rotate compressor every 2 minutes. Now, having said that, in a pregnant patient, it is very important to remember one thing, that when a pregnant patient is lying supine, the gravid uterus, it tends to compress the aorta and the inferior vena cava, as a result of which there is a decrease in cardiac output. And this results in a fall in blood pressure. So during chest compressions, if you keep this patient supine, then only 10% of the cardiac output is generated as against 30% in a non-pregnant adult, thus limiting the effectiveness of chest compressions and adversely affecting the maternal hemodynamics and the fetal oxygenation. So it is very important that the uterus be always displaced towards the left side manually during your entire cardiopulmonary resuscitation. this relieves your iotocaval compression during chest compressions. So the manual left uterine displacement can be done by either a two-hand technique or a one-hand technique. The two-hand technique is definitely better than the one-hand technique. In this, the manual left uterine displacement is performed using two hands from the left side, and the designated provider pulls the uterus leftwards and upwards. The other technique, as I said, is by pushing the uterus from the right side using your one hand towards the left. So the two-hand technique is definitely better, and during the entire process of cardiopulmonary resuscitation, I'm again emphasizing the left uterine displacement should always be maintained. Now, initially it was said that the table can also be tilted towards the left. However, this is to be discouraged and it should not be done, because when we are tilting the table, it results in your chest compressions becoming less effective. And further, if you place a wedge below the table so as to tilt it by 27 to 30 degree, again, your chest compressions are ineffective. And further, there is evidence that this actually does not relieve the aortic compression. So now once the chest compressions have been given, you give 30 compressions and you ventilate, give 2 breaths. Now, like Dr. Anju also mentioned, your pregnant patient is one indication to take an advanced airway early. So in a pregnant patient, as soon as possible, you should place a definitive airway device, which could be an endotracheal tube or a second generation supraglottic airway device. So always remember, try to minimize interruptions in chest compressions whenever you are placing a definitive airway, and always ventilate with 100% oxygen. Now, a pregnant airway is always considered to be a difficult airway. So whenever you are attempting to put in a definitive airway, one of the most experienced providers should always do it and take a maximum of 2 good attempts at intubation. If you are not able to achieve intubation within 2 attempts, the best is to put in a second generation laryngeal mask airway and secure the airway. Now, once a definitive airway is in place, it is important that you confirm its placement by an end-tidal CO2 monitoring. And once a definitive airway is in place, we no longer follow a 30:2 compression to ventilation ratio. After a definitive airway is placed, the breaths and the compressions, they become asynchronous. So the person who is giving compressions continues to do so at the rate of 100 to 120 per minute. And the person who is giving breaths continues to give breath at the rate of 10 breaths per minute. Now, what are the other ACLS modifications in a pregnant patient? One is you need to identify the rhythm, and if it is a shockable rhythm, the usual doses of defibrillation, like we do in a normal non-pregnant patient, they apply. That is, you give 200 joules of defibrillatory shock in case if it's a biphasic defibrillator, and 360 joules if it's a monophasic defibrillator. Then always remember to remove your fetal monitors, and if the adhesive pads are available, they are preferred over the paddles. Then AEDs may be considered in hospital settings to facilitate early defibrillation. AEDs, the basic goal is to deliver shock as soon as possible, ideally within 3 minutes of collapse. And AEDs are especially useful in areas where the staff has no rhythm recognition skills or the defibrillators are used infrequently. In addition, the IV access should be established as soon as possible, and it should be established above the diaphragm. Then the appropriate drugs should be administered, and the doses remain the same, which are the ACLS doses which we use in non-pregnant adults. Then always assess for hypovolemia and give fluid boluses whenever they are required. In addition to all of these, while you're giving compressions and ventilating, it is very important to also identify the reversible causes of arrest and treat them. So there are various mnemonics which you can remember so as to identify the differentials, and these could be either BU-CHOPS, which includes bleeding, embolism, your anesthetic complications, uterine atony, cardiac disease, hypertension, the 5 H's, 5 T's, placenta abruptio, and sepsis. Or you could remember it as A, B, C, D, E, F, G, and H. The idea is at the back of your mind, while you're performing CPR, you should always think of the possible reversible causes of arrest and try to treat them as soon as possible. Always be familiar with pregnancy-specific diseases and procedural complications. Pregnant patients are commonly taking magnesium. Magnesium is being given to them. So if your patient who has arrested was on magnesium, remember to stop it immediately and give calcium. If you think that the cause of arrest was a local anesthetic toxicity, then remember to give intralipid. So having said that, let us see how our scenario progresses.
So let us go forward and look at how did this team perform.
1, 2, 3, 4. Pooja, call the PMCD team loudly. 10, 11, 12. PMCD team. 16, 17, 18, 19, 20. Yeah, you will have to prepare your PMCD because in 4 minutes we will start the PMCD. By 5 minutes we will have the baby delivered. Okay? Do we have the neonatologist ready with the kit? Yes, ma'am.
PMCD kit ready.
Ma'am, I'm going to intubate the patient. Okay. If you do not get the first attempt success in intubation, please be ready to put in a second generation LMA. Yes, ma'am. Pooja, be ready with the syringe to inflate, and Tanuja, inflate, attach and ventilate. Yes, ma'am. Got inflated, able to ventilate. Are we getting can we attach an ETCO2 monitor?
A word of caution up here, most of the times providers would not be as expert as our provider was to put in a successful endotracheal intubation while the CPR is going on. So if you need to stop the chest compressions, the pause has to be less than 10 seconds.
Able to ventilate. Are we getting can we attach an ETCO2 monitor? Yes, ma'am. Attach, ma'am. And let us look at the ETCO2. What is the ETCO2 like? 12. Yes, ma'am. Yeah. Attach, ma'am. Okay. Capnograph attached. Capnograph reading. Is the PMCD ready?
Yes, ma'am. PMCD ready. Remove clothes. 4 betadine.
We still have the manual left loop and displacement. We are getting good chest compressions. Our ETCO2 is 16. Good. It should stay above 10.
5 cycles done.
Okay, PMCD in process. Neonatologist ready to deliver. Take the baby.
Switching compressors.
Change compressors.
Baby delivered out.
Continue high quality chest compressions. And after 5 cycles, right? 5 minutes are up. Yes. So after 5 cycles, that is 2 minutes, you will let us know. We will check the pulse. If and see whether ROSC is there or not. Return of spontaneous circulation is there or not. Good team effort. Which cycle, Michelle?
4th cycle, ma'am.
Okay. So Michelle, now that we have a definitive airway, we will continue to give chest compressions continuously for 2 minutes. Yes. So Pooja is monitoring the time. And you will give breaths at the rate of
5 cycles
10 breaths per minute. 5 cycles over, 2 minutes. 2 minutes over, not 5 cycles. Let us check the pulse, Tanuja first. Tanuja, the ETCO2 has risen to 44.
Yes, ma'am.
Can we check the pulse and the breathing?
Yes, ma'am.
Count for 5 to 10 seconds. Checking for pulse.
1001, 1002, 1003, 1004, 1005. I can feel a feeble pulse.
Yeah. Tanuja, can you check the blood pressure?
Okay, I'm pressing the blood pressure. Blood pressure is 90 by 60.
Good. We continue post-resuscitation care and plan to shift the patient to ICU. Yes, ma'am. Yes, Michelle? Yeah.
So what you saw here is a prototype of ACLS interventions blended with high quality BLS interventions. And what is important for us to remember that a best outcome is achieved with good teamwork. Teamwork includes a lot of elements, especially having clear messages getting across, having clear roles and responsibilities allotted to each member of the team, having good closed loop communication, to name a few of the good elements of team dynamics. At the same time, what you also saw during this team effort is perimortem cesarean delivery being done. Now, what I want to highlight from our end is that this PMCD, which is also now known as the resuscitative hysterotomy, is indeed a part of CPR, and therefore we shouldn't be shifting these patients to OR and needs to be performed simultaneously to a high quality CPR so that the maternal resuscitation is optimized further by uterine evacuation. So our target here is that a PMCD needs to be done, initiated at the very site of maternal cardiac arrest where a CPR is going, with a target to empty the uterus. And as I said, this would help not only in better maternal hemodynamics and respiratory mechanics, will make the CPR more efficient, hence improve the chances of maternal survival. In addition, it gives access to neonate for resuscitation. And what does the guideline now say? Is that if there is no return of spontaneous circulation in the 5-minute endo period, perimortem cesarean section should be initiated as soon as possible. That would mean that we prepare ahead of time, and therefore, when we identify that a cardiac arrest has occurred, when we find that the mother is unresponsive, that is the point in time where the time 0 is noted down, and the clock starts to tick from that point in time. We call the maternal cord blue team and the PMCD team, which starts the preparation so that they're able to do an incision at that point in time and deliver the baby within 5 minutes of an arrest happening. The details of this PMCD will be dealt by Dr. Ashima later after our talks. As you saw in our scenario, ROSC, that is return of spontaneous circulation, occurred after PMCD and high quality CPR. Now, one of the most common complications that occurs after ROSC is PPH. And therefore, we need to remember that use of oxytocin after perimortem cesarean delivery can often cause rearrest. And hence, we need to focus on using either intramyometrial prostaglandins or methyl ergometrin. However, as obstetricians, we need to have a lower threshold for applying uterine compression sutures, or in severe cases, maybe use of internal iliac or aortic cross clamps can be used. Right? Post-resuscitation care following ROSC needs to continue, and it's extremely paramount. And so therefore, we need to support the airway breathing of the mother. If your mother has not been intubated, now is the time to intubate her and put her on a vent, support her circulation as well, ensuring a blood pressure of at all times of more than 90 millimeters of mercury, systolic blood pressure. And of course, if the mother still stays comatose despite return of spontaneous circulation, we can institute mild hypothermia in these cases. A word up here is that in certain cases where there is recurrent cardiac arrest, or you are suspecting local anesthetic systemic toxicity, which is not amenable to therapy, then despite delivery of baby, we can consider in special cases an ECMO CPR, and the patient goes on ECMO, which provides a bridge till there is a reversal of the underlying cause of cardiac arrest. And as you can see, there are so many events and so many actions happening at the same time. You're having a high quality BLS, intertwining it with ACLS intervention specific to the mother, and also doing a PMCD. And hence, all of this needs a good team dynamics, and a lot of information and a lot of cognitive load occurs on each of the provider in addition to the emotional overload that occurs with this mother. And it is therefore a good practice to have checklists which can be, adhered to, and will also act as an aid to remember the steps and not forget each of the vital steps during CPR. So a take-home message is for this particular skill station is that we need to focus on preventing cardiac arrest if feasible. We need to diagnose cardiac arrest as early as possible and need to document the time of arrest. A maternal cord blue team, which is a multidisciplinary team, in addition to the regular cord blue team, needs to come into this picture. We need to initiate high quality CPR and blend it with the ACLS intervention. But the most important intervention here is a manual left uterine displacement at all times. An early definitive airway needs to be secured so that 100% oxygen can be provided with whatever means is available to us. And a prompt initiation to his resuscitative hysterotomy or a perimortem cesarean delivery needs to be done. And therefore, we need a huge change in our attitudes and mindsets to go ahead and do that while doing a CPR at the site of cardiac arrest. And to do all this, we need to prepare systematically, train ourselves, and have a lot of mock drills. And this is the only way that institutions can standardize their responses and improve their care to these collapsing mothers. At this point in time, we would like to thank, both of us would like to thank our entire team, the team from the OB-GYN led by Dr. Ashima and her vibrant team of residents up there, and Dr. Kajal, Dr. Nidhi from PGIM Chandigarh with their team of enthusiastic providers from anesthesia, and of course a word of thanks to Ladal, Mr. Karamveer and his associate for providing us with the SimMom and helping us and shoot these videos and present to you and this particular maternal cardiac arrest management to all of you. Thank you so much.
Thank you so much.
Good evening. So just a quick recap about perimortem cesarean. Where do we stand? PMCD is any cesarean that is done after a CPR has been initiated in a pregnant lady. We'll discuss today what is the rationale behind it, when, where, how to do it, the legal and ethical aspects, and the recommendations from various international bodies. To understand the rationale, it is simple. Effective chest compressions produce approximately 30% of normal cardiac output in the best of circumstances. However, with a mother lying flat on her back, cardiac output is reduced by another 60%. Stroke volume, as we know, in a healthy woman at term in supine position is 30% that of a non-pregnant. Therefore, chest compressions at best will produce 10% of normal cardiac output. Simply, for effective CPR, iotocaval compression has to be relieved. This is the primary intervention. You can do it in any of the ways, by tilting the patient, manual displacement of uterus, or emptying the uterus. Now, tilting was what was advised earlier. However, chest compressions and recoil are compromised, making the CPR less effective and more tiring for the caregiver. Manual displacement is better than tilting. But the most effective method is emptying the uterus. It has manifold advantages, like IVC compression is relieved, so venous return increases, autotransfusion occurs as the uterus contracts, blood flow to uterus decreases instantaneously, which we note is to the tune of 1 liter per minute at term, allowing redistribution of blood to more vital organs, decreases the oxygen consumption of mother. Now there's a direct access to abdominal cavity when you do a PMCD. So there's an additional benefit of treating the primary cause if the hemorrhagic shock is secondary to trauma to abdominal viscera. And also direct aortic compression is possible. When, where and how to do a PMCD. If return of spontaneous circulation is not achieved after 4 minutes of correctly performed CPR, go ahead if POG is more than 24 weeks. If you do not know the period of gestation, do not waste time in calculating. Do it if the uterus is above the umbilicus. Do not waste time in checking the fetal heart rate because this has to be performed even if the fetus is dead. No abdominal preparation is needed. Vertical incision is usually preferred, but you can go ahead with whatever you are faster with. Attention should be given not to damage the bowel or bladder, and scalpel is the only essential equipment that you need to start a PMCD. With no circulation, blood loss is minimal, no anesthetic agent is required. Very, very importantly, CPR must be continued during PMCD. If maternal resuscitation is successful after you empty the uterus, please remember broad spectrum antibiotics, Foley's catheter, oxytocin, good closure with adequate hemostasis, and mother to be shifted to ICU with a high threshold of extubation. Please remember PMCD must be done at the place of arrest. Do not even try to move the mother for performing PMCD to OT or to any other place. What are the legal aspects? Now, any emergency procedure may be performed if it is in the patient's best interest. And given that PMCD is the standard of care, consent is unnecessary in an emergency. Law of doctrine of necessity is valid here, and doctor is required to do it whatever is necessary to preserve life and limit harm. And hence, legally you are safe if you perform a PMCD without a consent. Now things are so clear. We know it must be done, when to do, where to do, how to do. Still, where is the problem? Still, so many arrests, PMCD is not done. The problem is probably the fear that we all have within us of leaving the husband with a neurologically damaged child in addition to a dead wife. However, the literature says there is no reported case where survival beyond the early neonatal period was accompanied by neurological disability. Hence, practically more or less, either the fetus does not make it or makes it to a neurologically normal fetus. Based on thorough literature review, both ACOG and RCOG have agreed that PMCD must be resorted to as part of maternal resuscitation in case CPR in a pregnant lady with uterine height at or above the umbilicus, and presence of a perimortem cesarean section tray on resuscitation trolley is a must. RCOG even goes on to say that this must be done even if the fetus is already dead. There is a theoretical possibility that the outcome of the child may be severely damaged. However, the interest of the mother must come first. If you do not think about it at arrest, you will never be able to do it within 5 minutes. So think about PMCD at every maternal arrest. What makes it even more easy to accept now is the change in terminology. In 2015, we changed the term from PMCD to resuscitative hysterotomy. So now it is easier to accept that PMCD is a resuscitative intervention to improve the chances of maternal survival by allowing good maternal resuscitation. This language reflects the life-saving benefit to the mother, and hence there is now a transition from a fetocentric approach to a materno-fetal resuscitative protocol, where benefits of both mother and fetus are considered in parallel. Just to sum up what we did today, if there's any maternal collapse, you start CPR, please call for help, call for the Code Blue team, the obstetric surgeons, the neonatologists, everything. If there is no return of spontaneous circulation with CPR, please go ahead with PMCD. Please remember to ignore the consent. Please do not waste time in sterility and the technique. No time wastage in the catheterization. And after emptying the uterus, if successful resuscitation is done, remember to have a meticulous hemostasis, layered closure, uterotonics must be administered, antibiotics must be given. And hence, let's pledge today for maternal safety, because women are not dying because the diseases we cannot treat. They are dying because societies have yet to make the decision that their lives are worth saving. Today, let's pledge for this. Thank you.
Thank you very much. The resuscitative team was very explicit and all the take-home messages were very clear. So since there are no questions in the chat box, I think I'll ask one question each from all of you. We start with the last one first. Ashima, you talked about resuscitative hysterotomy. And what our concern is, are there any reports from India, any studies which have been done, and what do they tell us about the survival rates in the mother and the fetus?
Ma'am, there can obviously not be any studies, but yes, reports are there. We recently met the critical care team from Fernandez, who had performed 5 resuscitative hysterotomies, and the 4 out of the 5 mothers could be revived after the emptying of the uterus. They have reported it also. The causes were obviously good, causes like embolism, in which the chances of maternal resuscitation were better rather than causes like sepsis. So only from Fernandez we have reported cases from India. Otherwise, there are no studies reported from anywhere.
There was a depressing study which came out from the Dutch people from Netherlands. And once MOITS was instituted in Netherlands, they found that about 83% of maternal deaths occurred and 55% of fetal mortality occurred. And the major reason they said was that resuscitative hysterotomy did not take place within the 5 minutes. Yes. So it is so very important that this occurs within the 5-minute time frame. Unless we do it within that time frame, we are really not able to, make the child and the mother survive.
And the
yes.
And the only 2 things that have been associated with good outcome is the time lag and the place. Means one thing is that we should be fast with it, and the second thing is we should not be shifting the patient to OT for conducting a PMCD. These are the only 2 things which affect the survival the most.
So in continuation with this, Dr. Anju, this is a patient who is morbidly obese, a high BMI, and she's in the ward. She has she has had a cardiac arrest. Now, how do you resuscitate, do an effective cardiac compression in this patient? We do not have a board available there to do, make it a stiff one. So do we put the patient down on the floor or do we continue on the bed? And are the steps any different in a morbidly obese patient? Because left uterine displacement is going to be really very difficult here.
Yeah, it's pretty a challenging scenario.
They're very challenging.
Yeah.
And we do meet such 130 kg and 140 kg. And I bet Sunil will tell you that he has been, with 180 kg females in Hyderabad. So it's a really tough and challenging situation. And what I'm worried about is how do you do, left uterine tilt? Unless you have a male resident who is putting all his pressure and pulling the uterus to one side.
Two things. One is very imperative in today's times, and since we all know that we will be having obesity is on the rise, so all the crash carts must have a kind of a board, a hard board, that can be slipped beneath the chest of the patient, so that effective chest compressions can occur. Yes, there would be issues about tilting the uterus, and therefore maybe pushing it from the other side could perhaps be a little more, easier in morbidly obese patient. Maybe, I don't have much of personal experience into it, but I do believe that would help.
Yes, pushing it from the opposite side would be a much better option there.
And of course, we need not, one thing that is very important for us to remember is that shifting these mothers to the floor or any other place is not to be done at all. We need to be stationed there itself. The best option is to climb up on the bed and be on your knees. When you're on your knees, you actually have your hips above the patient level, and then you can use your body weight to good high quality chest compressions because you're actually compressing on the sternum, where I believe the fat would not be there and you could be doing a better job at that. You should use, these are the situations where one must use feedback devices because they would help us to tell us whether we are doing efficient chest compressions or not. And AHA also recommends that even with the help of a bag mask device, we can have an ETCO2 monitor attached. But the best option in this particular scenario would be to shove in a second generation as a laryngeal mask airway. In our hospital, all labor floors and OB-GYN floors, and including emergency, have a second generation LMA and a PMCD kit stationed on the crash carts. So that the advantage you get is you can attach an ETCO2 monitor and monitor the quality of your chest compressions and be sure that your chest compressions are really effective. And of course, you need a very efficient PMCD team to do PMCD on these patients. That's very important. Yeah.
Ma'am,
So
can I add something?
Yes, sure.
Yeah, according to the recent 2020 guidelines, actually, initially it was never emphasized, but in 2020 guidelines, they've actually emphasized this point that the patient should never be shifted on the floor. So this emphasis has been done in the recent guidelines. So like ma'am also said, Dr. Anju, that you should never shift the patient on the floor and try to do where the patient is. Another thing which can be done is you can use mechanical compression devices in patients who are very obese.
Yeah,
that can also be used.
But then, yeah, you're right. And these devices have to be indeed in place for, if you are anticipating a cardiac arrest, and they have to be already there because the time to put them on is going to be creating a lot of time lag.
Yes.
Another thing that I wanted to highlight here is that the 2020 guidelines, the AHA recommends use of two things. One is a CPR coach. And that is essentially a person who is on the defibrillator. So if you had seen in our videos, we did not use the defibrillator person to interchange with the chest compressor. We use the IV person. The defibrillator stands just opposite to the compressor and can actually monitor with the help of either the feedback device or visually the quality of chest compressions, keeps a track on the chest compression fraction. That's the most important thing for good recoveries. And that is the time that you spend for doing chest compressions divided by the total time of CPR. So it should be aimed, as Dr. Nidhi said, to be something around 80%. You can achieve them with good team dynamics, repeated rigorous mock drills, and that can actually come in there. These are two things that CPR coach and improving your chest compression fractions is a lot of focus now. We need to also look at our rhythms, and as has been pointed out, rhythm recognition skills are often not very efficient in these floors, and therefore use of the combo devices where there is a defibrillator pad and an AED mode can be switched on to your defibrillator can be really helpful to these mothers.
So another important point which I would like Nidhi to clarify is how frequently these skills should be reinforced.
Actually, ma'am, they should be like there is no time that you should do these monthly or 6 monthly or yearly. But yes, annually, once in a year, they have to be reinforced because the guidelines also keep on changing, and plus your skills have to be brushed up regularly. So it is very important that all residents, especially the new joinees, they regularly practice on mannequins. And so that at the time of an emergency, they are ready and they're prepared. So
But Nidhi, isn't 1 year too much of a time lag? I think it's a very short remembering span. I think it's around 3 months or something. What about Anju? What do they say?
Ma'am, there are no specific timelines given. AHA recommends, renewing your card every 2 years. But I agree with you that people do tend to, lose on their skills and the cognitive everything ability goes off. So, in our hospital, what we do as a part of NABH initiative, we have a monthly code blue event analysis. And we also mandatorily have now shifted to doing at least 2 mock drills. Of course, they're not on maternal code blues. They are code blues across the entire hospital.
Yeah.
So we choose every floor, each floor of the hospital sequentially. It does help you, but it is indeed difficult to getting all of them going through. So I believe a more doable is an annual one. Of course, if we can do it biannually or more frequently, that would be. Another point that I questioned was there in the chat box was, should you move the mothers to, I think Ashima can answer that better. But I only have to add one thing, should mothers be moved for hemostasis to OR after PMCD and successful resuscitation? Just a point to remember, please move your mothers when they are stable. Yes. Don't move an unstable mother. And that, of course, has been highlighted very well by Dr. Anjan.
So with this, if there are no more questions there, I think I thank all the team members here of this e-skill station. And since each one of you has already summarized the resuscitative hysterotomy, and Anju and Nidhi have already summarized the CPR guidelines, we do not need to go back to that. And thank you very much for a very good hybrid presentation of the skills which you showed. The team was exemplary from PGI, and the SimMum really helped show it in a more virtual and more authentic manner. Thank you very much.
Thank you so much. Thank you, ma'am. Thank you so much.
Thank you so much for this insightful session. Now I invite Dr. Ashima Arora, Associate Professor, Department of Obstetrics and Gynecology, PGI MER Chandigarh, to propose a vote of thanks for today's workshop.
Good evening, though I know we are getting late. On behalf of the entire crew of the Obstetric Critical Care e-workshop, I extend a very hearty vote of thanks to everyone who has in some way contributed for the success of this academic event. And this day has really been a day of collaboration between obstetricians and anesthetists, collaboration between East and West, collaboration between the experienced and the YUVA. We really had a day of stronger collaborations. On behalf of FOGSI and PGI Chandigarh, I'm really grateful to the team from Maryland University, USA. And because of you people, we could hear the thoughts from across the globe. And equally sincere gratitude to all the clinicians from all over India who graced the occasion in spite of their busy schedule. And this type of event is obviously it doesn't occur overnight. The wheels started rolling more than a month back. And I was really fortunate to have a dedicated team of clinical photographers and telemedicine experts who were very well versed with their jobs. Special mention to the team of Lardell and Edwards for providing the simulation setup. And lastly, I would like to thank the residents and faculty of the Department of OBG PGI Chandigarh who worked on screen and behind the screen for making this day a success. Let's hope the academic feast continues for the next 2 days and see you all tomorrow. Thank you.
Thank you, Dr. Ashima. Now I invite Dr. Komal Gandhi to conduct post-test, which will be followed by display test and post-test along with their answers. I thank you all for being a part of this workshop today. It sure was a great source of intellectual nourishment for all of us. Thank you. Hope to see you tomorrow in the CME.